I'm
all right. Thank you for having me here. My name is Walter Chen. I'm from Brigham and Women's Hospital and Harvard Medical School in Boston. I'm going to be talking a little bit about Chicago classification and the optimal use of it and some limitations to the classification itself. Some of it will be a little bit of an overview of Chicago classification as well. So let's think back a little bit about Chicago classification over the years. Remember, when it was we started using high resolution manometry, the first classification came out in 2008, and at the time, a lot of these diagnoses are still similar to what previously were developed for water perfused manometry. And the first metric based on HRM was introduced, a new metric called integrated relaxation pressure. The IRP was introduced back then. And then when it progressed to the second version, then some of these diagnoses started to evolve with introduction for more parameters, including distal contractile integral, distal latency, which basically give us the measurement of the peristalsis of the swallow, as well as break in the swallow. And then the third version came out a few years later to further refine these diagnoses, really to take out some of the diagnoses that may not be as clinically relevant and make sure that we have diagnoses that we can actually treat and act on. And then the most recent version came out in 2021, which many more authors and really focusing on consolidating these diagnoses into one that we can take action on and do treatment. The main thing that were introduced, the thing to emphasize on was really the clinical evidence part and some of the other adjunctive testing that can help us determine clinical relevance. So this is going to be a little bit of a basic overview. So I'm going to go through this fairly quickly. This is the protocol of high resolution manometry per Chicago classification. Mainly, usually start with the supine 10 wet swallows, followed by a set of multiple rapid swallow sequences, and then followed by change in position and upright swallows, followed by, at the end, a rapid drink challenge sequence. You can also reverse the upright and the supine swallows as well. The new measures, the provocative measures were added, the multiple rapid swallows, the rapid drink sequence. Dr. Gwali is going to talk a little more about those in the next talk, so I'm not going to go into the details of them, but they are now part of the standard protocol. And there are also some other optional maneuvers that you can perform during the high resolution manometry, including solid test meal, measuring solid bolus swallows, and also something called postprandial protocol, where you measure conditions like rumination syndrome. So this is, some of us may be familiar with this in terms of reading manometry for Chicago classification. I'm going to quickly go over some of the metrics. We know some of the landmarks, the basal pressure, the diaphragmatic pressure. We usually classify each swallows by when the upper esophageal sphincter relaxes. One of the major parameters that we need to look for is something called a contractile deceleration point, which signifies the end of the contraction. Usually you measure it by seeing when the contraction happens, where the slope changes. That's considered a contractile deceleration point. Another important metric that was introduced since the first version of Chicago classification is the integrated relaxation pressure of the lower esophageal sphincter. This takes the minimal average pressure during at least a 4-second period at the EG junction, hopefully to tell us how well the lower esophageal sphincter is relaxing. Distal latency is the interval from when the upper esophageal sphincter relaxes to the contractile deceleration point. Obviously, the shorter the distal latency, the quicker the swallow, maybe the more spastic it is. Another metric is the peristaltic break, which is the break in the contraction along the esophageal body. This usually corresponds to the transition zone of the esophagus, where the skeletal muscle turns into smooth muscles. And then finally, the distal contractile integral, which is a measurement of the contractility of the esophageal body. So with each swallow, you can measure these metrics that will allow you to score and classify each swallow, then you can go through the Chicago classification. And what are some of these, how do you classify these metrics? And this is a summary of how you can classify these metrics. With DCI, you can classify each swallows into ineffective or normal, or hypercontractile. With the distal latency, you can see if they're premature, meaning they're more likely spastic. Peristaltic break can help you determine if the swallow is fragmented or normal. The longer the break, the more likely they are fragmented. Integrated relaxation pressure tell you if there's any signs of outflow obstruction at EG junction. And then there's another metric you can look at, which is intrabolus pressurization, which is looking at the pressure throughout the esophagus. Either when there's nothing happening, you see increase in pressure in the esophagus in general, it might indicate some type of obstruction. There's compartmentalized pressurization, which is increase in pressure between the contraction and also the EG junction. Usually when you see increased pressurization in the esophageal body, it might suggest some type of obstructive outflow obstruction. So how do we do Chicago classification? I'm going to go through this fairly quickly, but usually you start with looking at the IRP and whether or not it's abnormal. If you have an abnormal integrated relaxation pressure, then you look at whether or not there's any normal peristalsis. If there's no normal peristalsis, plus an abnormal IRP, you're thinking about one of the three classes of achalasia, whether it's if there's failed peristalsis, then it's achalasia type 1. If there's pan pressurization, the increase in pressure in esophageal body we just talked about, that's type 2 achalasia. If it's associated with a very spastic non-peristaltic swallow, that would be type 3 achalasia. If it doesn't satisfy the criteria, but the IRPF is abnormal, then in the previous version of Chicago classification, we would call those patients with having EGJ outflow obstruction because the relaxation pressure at the EG junction is high. What I'm going to show in a little bit is that it turns out to define EGJ outflow obstruction just by one metric turns out to be very nonspecific. A lot of patients for various reasons can have an elevated IRP but not true obstruction. So in Chicago 4, we want to be more specific in finding true clinically relevant EGJ outflow obstruction rather than diagnosing everyone with one elevated IRP metric as EGJ outflow obstruction. So what Chicago 4 requires is instead of just relying on the supine IRP, you want a second position, namely the upright IRP, to also be abnormal to be considered for the diagnosis of true EGJ outflow obstruction. And not only that, Chicago 4 also require, in addition to the two metrics, the two IRP in two position being abnormal, also other supportive evidence, such as increase in intrabolus pressure, and also an abnormal finding on either time barium swallow or flip panometry. And this is an example of EGJ outflow obstruction on the left. And on the right is someone who have an artificial increase in IRP that's not a true EGJ outflow obstruction, where in these patients, if you sit them up, their IRP measure may normalize. So this is how we want to distinguish them. So if you don't satisfy the criteria for achalasia or EGJ outflow obstruction, if there's no evidence of EGJ outflow obstruction, then you're thinking about one of the disorders of peristalsis. You can start with if there's no normal peristalsis, they're all failed, but with a normal IRP, and they're patients with absent contractility. If they have at least 20% of swallow with premature contractions, meaning the distal latency is short, those are the patients that we diagnose with distal esophageal spasm. And if it doesn't satisfy that criteria, but if they have high contractile force, if they have high contractility in at least 20% of swallow, meaning the DCI is high in at least 20% of swallow, those are patients with hypercontractile esophagus. And if they're on the flip side, if patients have a lot of ineffective swallows or a lot of failed or weak swallows, those are patients with ineffective esophageal motility. So these are examples of these various diagnoses. So if you look at the whole classification, if you go through the algorithm after scoring each swallow, they can lead you to one of these diagnoses or diagnoses of metametric patterns. So it sounds great, right? It's pretty easy to do. You can come up with these diagnoses, but what is the best way of utilizing this information? Because are they all clinically relevant? And what are some limitations for this? One of the important thing to think about when you think about using manometry is looking at different types of esophageal symptoms. And you can generally classify esophageal symptoms into different categories: perceptive symptoms, transit symptoms, or some atypical symptoms. Perceptive symptoms are the ones where you can feel, right? Heartburn, pain, adenosphagia. Transit symptoms is really related to abnormal transit through the esophagus, dysphagia, food impaction, maybe regurgitation. And there are also some other atypical symptoms like belching. And there are different etiologies that can be causing these different types of symptoms. But the one that I want to draw your attention to is really these transit disorders, basically conditions where you lead to transit abnormalities or swallowing dysfunction. And this is a group of patients where manometry can really help guide your treatment and guide your management of these patients. So in terms of when you think about which patients are going to most likely benefit from esophageal manometry, really the patients with transit symptoms are really the ones that that manometry will play an important part in your management algorithm. Obviously, there are a lot of endoscopic signs that can help you classify some of these, but a lot of patients may have these transit symptoms with normal endoscopy, and that's when manometry can come into play. And what are some of the common indications for doing manometry? I think the most important one, as we just talked about, is really to diagnose or rule out an actionable esophageal motor disorders. What do we mean by actionable motor disorder? Is the one that you have effective treatment for. Some of the examples are achalasia, maybe some cases of esophageal gastric junction outflow obstruction, maybe some patient with distal spasm or hypercontractile esophagus, maybe some patient with supragastric belching or rumination. These are patients that we have different types of treatment for. So doing manometry makes sense to either evaluate for them or at least rule them out, so you know you can treat for other conditions that may be a functional disorder. When you have to think about doing a reflux testing, like placing a reflux or pH probe, you need the manometry to help you properly place it so you make sure the pH sensor is the right place. If you think about sending a patient for anti-reflux surgery, this will be important to make sure there's no contraindication to anti-reflux surgery. You obviously don't want to send a patient with maybe underlying achalasia to anti-reflux surgery, even if they have reflux symptoms. And some metrics may even prognosticate the outcome of anti-reflux surgery as well. So these are some of the common indications for manometry. But what's really the optimal use of this in clinical management? And this is where clinical relevance of manometric pattern becomes important. How the symptoms a patient come in with relate to these manometric patterns. And one of the important things to really think about that's related to those transit symptoms is an obstructive physiology, because we know when there's obstruction, there are ways to treat them. And this is actually a table from a paper that came out a number of years ago now, really bringing into this idea of an obstructive physiology, where a lot of these conditions, where the way they cause symptoms is because there's some type of obstruction. And we know now we have fairly effective treatment for obstruction: myotomy, dilation, Botox injection, or maybe medications. So really finding this obstructive physiology may help you manage these. A patient with obstructive physiology will help you find patients that you can actually improve the symptoms by treating their underlying motility disorder. So patients with an obstruction are patients where intervention, where you reduce a true obstruction, can improve their transit symptoms. Also, if you do intervention to create an obstruction, like maybe an anti-reflux wrap, may worsen symptoms in patients who have underlying obstruction. So identifying this obstructive physiology is important. Unfortunately, there's really no single universal gold standard metric in definitively diagnosing these true obstruction. Really, if you think about it, is the balance between the contraction in distal esophagus and the EGJ barrier function. If you can overcome that, then things can go through. If you cannot, then there's an obstruction. So really, when you look at manometry and look at the different diagnoses and look at some of the adjunctive metrics that Dr. Gwali is going to talk about, it's really to identify evidence of whether or not there's obstruction, because those are the patients you can treat. And also maybe to avoid doing things that can worsen the obstruction. So in terms of what's the optimal use of Chicago classification and also high resolution manometry is really to identify these group of patients to either rule in or rule out this actionable obstructive physiology. But there's also limitations to high resolution manometry. One of them is the EGJ outflow obstruction group, which we talked about, because this is really a heterogeneous entity, especially from how we used to define it, which is an elevated integrated relaxation pressure. As you can see in this table here, there are many different reasons why there can be an elevated integrated relaxation pressure, ranging from a primary motility disorder to really just an anatomical changes or medications. So the main thing is which one of these patients are truly the ones that you want to do a treatment on. And if you look at some of the study, really have shown that just having a supine IRP being elevated alone really correlate very poorly with bolus transit symptoms and even treatment outcome. But if you add the upright IRP to measure to it, it can help reduce an overdiagnosis of this obstruction. And this is a study you can see here where patients who had an elevated IRP in a supine position, and then when you classify, when you look at the upright IRP, the group with and also an elevated IRP in an upright position, they are more likely to have an abnormal dysphagia score. But importantly, for those who have a normal upright IRP, despite an abnormal supine IRP, almost none of them have radiographic evidence of outflow obstruction. So maybe combining the two metrics, the supine and the upright metric, and looking at both of them will be important. And there have been studies have shown that the upper IRP of a cutoff of 12 had a good sensitivity for detecting radiographic outflow obstruction and a high negative predictive value. And looking at an increase in intrabolus pressure may also further support this outflow obstruction. So you see the contraction pattern there. You can see the pressure that increases underneath that contraction. That's an intrabolus pressure. When you see that, that may indicate some type of obstruction as well. Esophageal body function may also be relevant in patients with these elevated IRP. So in patients with elevated IRP, but then abnormal esophageal body motility, there have been studies have shown that the bolus transit may be decreased in these patients. Intact contractile function with higher DCI generally correlate with better clearance of the esophagus. And there have been some studies that also classify a patient with EGJ or an elevated IRP and different motility pattern and how they relate to symptoms. So a lot of times you may have to think, even if you think about some of these patients with esophageal body dysmotility, you also want to look at whether or not there's outflow obstruction that might actually be worsening or causing their symptoms. Another limitation, so when you think about limitation of IRP, some other limitation with this metric, sometimes patients can have what we call LES pseudo-relaxation. So in patients with spastic contractions, a lot of times the longitudinal muscle of the esophagus also contracts. It shortened the length of the esophagus. It pulled the LES up. So if you measure the IRP just at the original bottom level, it might give you a normal number. But you can see here the LES is actually pulled up. So it's actually, there's an outflow obstruction here. So looking at the IRP and making sure you're looking at the right spot is important. Another limitation is effective medications like opioids. There have been a lot of studies that have shown that opioid users are more likely to have elevated IRP and outflow obstruction. There could be structural lesions can lead to an elevated IRP that you might want to identify. What I'm going to talk about next is absent contractility versus achalasia, because there have been some studies that have shown that patients with absent contractility with a normal IRP per definition may actually have underlying achalasia. And this is a study is actually from Dr. Gwali's group. We're looking at different patients who are diagnosed with absent contractility per Chicago classification. Remember, these are patients with a normal IRP, but 100% failed swallow on manometry. It turned out when you look at these patients with absent contractility, a portion of them actually end up having achalasia because there might be some obstructive physiology at the EG junction with a completely failed esophagus not able to overcome. These actually are patients that are like achalasia. And the main thing is that the supine IRP might help you identify some of these patients, and also some metrics, some adjunctive metrics that can also help you identify these obstructive pattern, so that when you have patients that you diagnose with absent contractility per Chicago classification, you want to find out whether or not they belong to this group of achalasia. Because if they do, achalasia type treatment will actually help them. So definitely consider achalasia if evidence of obstruction is present in patient absent contractility. IEM is another group that clinical relevance is uncertain. These are patients, there have been some study looking at patients with ineffective esophageal motility per Chicago classification 4.0. And it's been shown that this may be present in 10% of healthy asymptomatic individuals, which is a lot of patients. And compared to the definition by Chicago classification 3.0, the newest diagnosis is actually better in identifying patients with abnormal symptoms. They generally had higher reflux burden. But when you look at bolus clearance between the older and the newer version, it's still not very good at distinguishing those with poor bolus clearance. And when you're looking at correlation between IEM and GERD, the correlation is still fairly inconsistent. And there have been studies that have shown that with more ineffective swallow, not surprisingly, dysphagia severity may increase. But overall, in some of these studies, the overall dysphagia severity is still really low, even in patients with a high number of ineffective swallows. So the clinical significance of IEM pattern per Chicago classification 4.0 remains unclear. And a lot of these patients, there's been studies that have shown that if you study them many years later, they become normal. A lot of times when you don't do anything, this pattern becomes normalized or the symptoms improve. So the important thing is IEM is more a pattern rather than a true clinical diagnosis, and you really need to approach these patients carefully. And how about hypercontractile disorder? There've also been a lot of studies that have shown that even the hypercontractile diagnoses may not be really relevant. There are a number of studies looking at patients with hypercontractile esophagus, remember with a high distal contractile interval or high DCI in these patients. All these studies basically show that even if you don't do any treatment or just do very non-specific conservative therapy like PPI, they actually improve. And when you compare them to using other treatment etiology that focus more on relaxing the esophagus, the treatment outcome is not that different. So main thing with hypercontractile disorder is that their symptoms often improve with no or conservative management only. So the question is this pattern alone clinically relevant? So you really need to put together the clinical case when you see these patients and determine whether or not treatment targeting these hypercontractile esophagus would really help these patients. And this is another study basically looking at these hypercontractile esophagus patients where they randomize them into doing Botox or not treating them at all. And it turns out that there's no change basically between these two groups in terms of outcome over time. So should we treat these patients? I think that's one of the questions you have to answer when you see these patients. So these are all limitations from what we noticed from Chicago classification and high register manometry. So knowing these limitations, what kind of symptoms can these different motility patterns explain? Well, achalasia spectrum disorders or spastic disorder with evidence of obstruction are more likely to have these transit symptoms, right? Dysphagia, regurgitation. If they have spastic disorder but no obstruction, maybe they have reflux or other perceptive symptoms like pain. Absent contractility and ineffective esophageal motility patients are usually more likely to be associated with reflux, generally not so much dysphagia. And patients with normal manometry, generally, if you have symptoms, they're usually from reflux or maybe esophageal hypersensitivity. So in summary, I think these are some of the take-home points for my talk. Most important role of HRM really is to diagnose or rule out these actionable motility disorder. And what you need to consider is assessment of these obstruction or obstructive physiology to look for these signs of obstruction. EGJ outflow obstruction is still a heterogeneous finding with multiple underlying causes. So you really need to confirm this diagnosis with other supportive modalities before you decide on treating these patients. When you see patients with absent contractility, you should consider achalasia if there are signs of obstructive physiology that's present. And finally, ineffective esophageal motility, hypercontractile esophagus, or even spasm without obstruction are manometric patterns of unclear clinical significance. So you really need to correlate them with symptoms and other supportive findings to see any treatment is needed. Thank you.
Thank you so much, Dr. Chan. Please have a seat. I think we can take all the questions together after both the talks. So now we welcome Dr. Prakash sir. Please come in and for your talks, and I'm sure it will be very enlightening for all of us. Thank you.
Thank you very much, and good morning, everybody. Delighted to be here talking about topics that I'm very interested in. So I'm going to talk a little bit about how to improve the diagnosis of obstruction or other manometric patterns using complementary approaches. And I'm going to start with this image that Dr. Chan showed. It's really very important to recognize that obstructive physiology may be present in any motor diagnosis, including normal, because the metrics that we use, including IRP, are not perfect. So if somebody has a symptom that is suspicious for obstructive physiology, it's important to enhance that and use certain complementary approaches. It's important to prevent overdiagnosis of obstruction when there is no true obstruction, but also to identify obstruction when the manometric pattern doesn't overtly show obstruction. These are some of the measures that we can use: upright swallows, rapid drink challenge, barium swallow, solid test meal, functional lumen imaging probe. But there are certain motor disorders where the major consequence is reflux, so potential for reflux in certain settings. And sometimes those can be enhanced by looking at certain features in the manometric study, including contraction reserve, barrier function, and looking for behavioral symptoms, behavioral syndromes that can sometimes overlap with reflux disease. So Dr. Chan already showed you this. Upright swallows are a means of preventing overdiagnosis of obstruction. So if it looks like obstruction in the supine position, you do upright swallows and you don't see an elevated integrated relaxation pressure, that tells you that what you saw in the supine position may have been an artifact. Here's an example of a situation where it was not an artifact. And one of the clues to true obstruction in this context of EGJ outflow obstructions, if you can see intrabolus pressure. So what I've indicated here is those vertical bands of pressure are intrabolus pressure. You should not see intrabolus pressure unless there is an obstruction. So if there is some resistance to flow of content from the esophagus into the stomach, then you see the intrabolus pressure compartmentalize upstream of the area of obstruction. There is no obstruction, that intrabolus pressure actually resolves into the larger stomach. Now, preventing underdiagnosis of obstruction may be more important, because if somebody has a dysphagia symptom that you've done a manometry for and you haven't detected it in the supine swallows or the upright swallows, then challenging the patient with a large bolus of fluid, in this case 200 ml of fluid, can bring out obstruction. So on the left side of this image, you can see a normal pattern where the person did not show any obstruction. The normal esophagus is able to handle these large volumes of fluid without any manifestation in the esophagus. The LES relaxes completely, the esophagus inhibited, and the fluid just flows into the stomach. On the other hand, on the right-hand side, you can see panesophageal pressurization, and that is a sign of obstruction. Sometimes you see esophageal shortening in addition to panesophageal pressurization. That's from the longitudinal muscles. This is a study that the Italians did a few years ago, looking at patients who are symptomatic despite treatment of achalasia. And in that population, using the rapid drink challenge was equivalent to performing a barium study with relatively good performance characteristics. This is another study done by the Italians in EGJ outflow obstruction, again showing that rapid drink challenge, pressurization during rapid drink challenge, or elevated IRP during rapid drink challenge is equivalent to performing barium studies. And indeed, symptoms correlate as well. The higher the Eckert score, which is a measure of esophageal symptoms in achalasia, the higher the IRP during the rapid ring challenge. So these supplementary or provocative maneuvers during HRM improve the diagnostic yield of high-resolution manometry. Now, you can go beyond just giving large volumes of liquid. You can give a solid bolus, or you can give the patient a test meal with the catheter in place. And on the right-hand side, you can see an elevated IRP in a patient who did not have an elevated IRP with the wet swallows. With the solid meal, the patient had an overtly obstructive pattern. And there have been other studies that have demonstrated that you can have obstruction despite normal IRP. And sometimes you can identify these patients with FLIP. And this is a study where the single water swallow group, these are the patients who had single water swallows with manometry, had a normal IRP, but a very low distensibility index. And those values were indeed even lower than the patients who had a solid test meal and elevated IRP during that time. So a solid test meal can increase confidence in a diagnosis of EGJ outflow obstruction or any obstructive syndrome in the esophagus. But very often we need to confirm obstruction using alternate techniques. And one of the most useful here is a timed upright barium swallow. This is a barium swallow where a large volume of barium is given, just like the rapid ring challenge, and images are taken in the upright position at 1, 2, and 5 minutes. And here you can see a patient with achalasia on the left-hand side, treated, and you can see that the barium that you saw on the left-hand side is gone after treatment. Here, another patient treated, but unsuccessfully treated because you can see the barium in the esophagus despite treatment on the right-hand image. So this is the method of doing a timed upright barium. Sometimes you can add a barium pill to that. If liquid barium flows through, you can give the patient a 13 millimeter barium pill. And if the barium pill impacts, that is also positive. And of course, the newest test is the functional lumen imaging probe. This uses impedance technology to measure cross-sectional area. It uses impedance technology to measure cross-sectional area. And the ratio between the cross-sectional area and the distending pressure inside the balloon is what's called the distensibility index. Now, the modern catheters have 16 pairs of electrodes, and you can get an image of cross-sectional area that looks kind of like this. This is the older form of EndoFlip 1.0. In this particular context, you can see the distensibility index is 1.1, which is very low. Generally, we say values below 2 are conclusively abnormal. Values above 3 are normal, and everything in between is inconclusive. You can also see a narrow diameter. The diameter here is 6 millimeters. Generally, a normal esophagus can open up to 16 or higher. In this second example, this distensibility index is 5.8, so it's normal, it's above 3, but the diameter is 10, which tells you that there is a narrowing at the EGJ that is not related to the muscle of the esophagus. This is a stricture. Now, when you compare manometric characteristics such as IRP to distensibility index and diameter on FLIP, you can see that they're kind of equivalent. So supine IRP, 15 is the threshold. Upright IRP, 12 millimeters mercury is the threshold. Distensibility index, 2.0 is the threshold. Diameter, 13 threshold, compared to barium studies as the gold standard. And you can see the area under the curve is similar, suggesting that these two tests are complementary. So how do you use it in actual patients? So remember, a manometric diagnosis of EGJ outflow obstruction is always inconclusive. And so if you do FLIP in these patients and find obstruction, the patients who have obstruction on FLIP tend to have an abnormal rapid ring challenge and an abnormal timed upright barium. And if you take these patients and offer them conservative management, remember you found obstruction, conservative management, they don't get better. But you offer them achalasia-like treatments, their Eckert score comes down below 3, as seen here. So achalasia treatments are pneumatic dilation, myotomy of some kind, or botulinum toxin injections. On the other hand, if they have no obstruction on flip, the likelihood of having a normal rapid drink challenge and a normal time-bearing esophagram is much higher. These patients don't need achalasia treatments, and they tend to get better with conservative approaches. So these provocative tests, time-bearing esophagram and flip, help solidify EGJ outflow obstruction diagnosis. Particularly important, and Dr. Chan talked about this, particularly important if you find absent contractility and the patient has dysphagia. IRP may not be very reliable in that setting. If the patient has dysphagia, losing weight, your story suggests achalasia, manometry does not suggest achalasia. It's important to chase these patients down with other tests. So this is the study that Dr. Chan talked about. We did barium studies and flip. You can see the rates of obstruction that we found. Dysphagia was an independent predictor of achalasia in absent contractility. And abnormal HRM provocative maneuvers, so those rapid drink challenge, solid bolus swallows, those were also predictive. And if both were present, dysphagia with abnormal provocative maneuvers, you had a much higher performance characteristic for identification of achalasia. Walter showed you this, but all the patients that we identified as achalasia who we treated and could follow up uniformly reported improvement of their symptoms, which tells you that there is an outcome benefit in these settings. So how do you get to a confident point with obstructive diagnosis? How do you get to a very confident diagnosis of obstruction? You get there by using as much information as you can. So not just your supine IRP, but also upright IRP, the rapid drink challenge or solid test meal, and time-bearing esophagram or flip. So if you have all of these showing obstruction, then your confidence in obstruction is going to be high. If your confidence is high, then you have diagnosed an actionable obstruction, and you can offer these patients permanent treatments to their esophageal obstruction disorder. And the important point about permanent treatments is you cannot go back. You've done something to the esophagus that is going to completely change how the esophagus functions. And if you do it in the wrong setting, you're going to create a problem rather than solve a problem. So achalasia spectrum disorders are what you're trying to identify in these patients with obstruction. And if you find those, you can cut or disrupt the esophagus. If you don't, if the information is wishy-washy, it's important to just continue to observe the patient and keep looking for these adjunctive findings and not jump to doing something that may not be right for the patient. Now, let's talk for a second about hypomotility disorders, the disorders with reflux potential. One of the provocative maneuvers used in that setting is multiple rapid swallows. You give the patient repetitive small swallows and look and see if the esophagus inhibits contraction during the swallows and increases its vigor at the end of the last swallow. Here's an example of a patient with a hypomotility disorder, ineffective esophageal motility. We did the multiple rapid swallows. There was no increase in contraction vigor at the end, so this is no contraction reserve. This is associated with higher reflux burden and higher likelihood of post-fundoplication dysphagia. But we can go one step further and look and see if you increase intra-abdominal pressure, if that pressure bleeds into the intrathoracic cavity. If the EGJ barrier is not strong, then if you increase intra-abdominal pressure, that will transmit into the chest during the maneuver. Indeed, in patients who have hiatus hernia, patients who have a disrupted esophagogastric junction, the likelihood of that happening is higher. We did some studies with our collaborators in Italy, and they found that if you increase intrathoracic pressure by 11 millimeters, that predicts elevated acid burden, or a 78% increase in peak intra-abdominal pressure, that creates a situation that is conducive to reflux. Now, there are other behavioral syndromes that can overlap with the reflux. One is what's called supragastric belching. You can identify this on pH impedance study, where you see a inward movement, distal movement of air with immediate eructation of that air. That's supragastric belching. The air never makes it to the stomach. those can be identified on manometry as well. And the provocative maneuver used there is a test meal. You give the patient a test meal and observe them for 30 minutes. You can also identify another behavioral condition called rumination, where there is high movement of stomach content in the postprandial period. Here you can see it in pH impedance, but in pH impedance testing, you cannot differentiate rumination from reflux. Whereas if you did a high-resolution manometry with postprandial challenge, you can see the R wave of rumination. If you use impedance, you can see stomach content coming up. The patient takes a few swallows and swallows it right back into the stomach. So postprandial high-resolution impedance manometry can complement the evaluation of rumination. Finally, this condition called abelchia, inability to belch. This is a condition that's getting some notoriety in recent years. This is a situation where the upper sphincter does not relax when the patient has an attempt to belch. So stomach gas from the stomach moves into the chest. The sphincter doesn't relax to let them to audibly belch out. And so the esophagus pushes that air back into the stomach. The patient has gurgling sounds in their chest and they're uncomfortable. Here's another example of abelchia. You can see how high the upper sphincter pressures go. The provocative test to be used here is high-resolution impedance manometry, and use rapid drink challenge, but give them a can of soda, give them a can of Coke or something like that rather than water. And what that does is it creates gas, and then you see these proximal movement of stomach content and the patient unable to eructate and having secondary peristalsis for clearance back into the stomach. Indeed, this was reported in the 80s. You can see a cartoon of this here. Fundus distended, air moves up, upper sphincter doesn't relax, air is pushed back down. And this can be treated with botulinum toxin injection to the upper sphincter. So important to identify, this is not an actionable disorder like achalasia where you destroy the lower sphincter, but you do a temporary treatment to reset the mechanism in the upper sphincter. We don't know exactly why people have this, but we know that if you treat them with Botox, they have long-standing benefit. This is my last slide. So in patients with clinically relevant esophageal symptoms and no explanation of endoscopy, that is one of the indications for doing a high-resolution manometry. With the primary position swallows, you can diagnose achalasia. Right? You can diagnose achalasia. You don't need provocative maneuvers for achalasias type 1, 2, and 3. That's obstructive motor physiology. You can go ahead and treat them if you've interpreted the study well. For all other patterns, it's useful to break these patients down into whether they have reflux-like symptoms or transit symptoms, as Dr. Chan talked about. If they have reflux symptoms, the provocative maneuvers are intended to assess peristaltic performance and to decide if reflux is contributing to symptoms. You can also look for behavioral syndromes like supragastric belching, rumination, abelchia. They have dysphagia or transit symptoms, and they have an abnormal supine IRP. You use upright swallows, RDC, time barium esophagram, and flip to make a diagnosis of conclusive EGJ outflow obstruction that could benefit from treatment. For all other patterns, even though the IRP is normal, if they have significant dysphagia and transit symptoms, these same tests can be used to look for an obstructive component. Thank you. You want me to just go ahead and talk about Lyon?
Yes, I think if it's fine, we can.
Okay, very good. Very good. I see people drinking coffee, so they're probably having reflux. So talking about Lyon is probably the right thing to do. I have a coffee too. Okay, I'll have reflux too then. 100 ml of coffee. Yeah, it's like a rapid drink challenge. I beg your pardon? That may not be the best thing to do right now. All right, let's talk about reflux disease and how the Lyon consensus can help. So reflux is something that happens in health. Gastroesophageal reflux is something that happens in health. We all have reflux episodes, and they happen from transient relaxations of the lower esophageal sphincter. This is mostly a postprandial phenomenon. It happens after meals. That's why coffee can provoke transient lower esophageal sphincter relaxations. The problem is, When do these reflux episodes become gastroesophageal reflux disease? There is no gold standard. There is no gold standard for diagnosis of gastroesophageal reflux disease. We use symptom response to acid suppressants as a surrogate. But to actually see manifestations of reflux, you may need endoscopy to look for damage to the esophageal mucosa or changes from reflux. We also use reflux monitoring and demonstrate abnormal esophageal burden, abnormal acid burden, abnormal numbers of reflux episodes in the esophagus. But those also need thresholds that are validated. And that's what the Lyon consensus tries to do. It tries to provide a framework for investigation and the modern diagnosis of GERD. So we have to start with symptoms. We have to start with symptoms. And we use the information we've learned from PPI trials, placebo-controlled PPI trials, to decide which symptoms respond the best to PPIs, right? Which symptoms respond the best. And it's the typical reflux symptoms that respond the best. Heartburn, the number needed to treat for a response, the column to the right here tells you that the number needed to treat is relatively small. And for the most situations, if you treat two people with heartburn, one of them is going to respond. So the number needed to treat is around 2. If you go to the other typical symptoms, regurgitation is a little bit more difficult because regurgitation is not a symptom that you expect PPI response from. If the patient has predominant regurgitation, the number needed to treat is a little lower. Chest pain, some people may complain of chest pain when they're really having heartburn. Others may complain of heartburn when they're really having chest pain. So chest pain and heartburn are interchangeable, especially if the pH test is positive. And in those instances, the number needed to treat for a response is a little lower than where there is no acid burden. But when you come to other esophageal symptoms, extraesophageal symptoms, the number needed to treat for a response jumps up very quickly. So patients with hoarseness, number needed to treat is almost 80. So we use this information to determine how best to evaluate these patients with esophageal symptoms. So these are some of the troublesome symptoms that can be suspicious for GERD. The initial approach for typical symptoms, heartburn, acid regurgitation, chest pain, can be an empiric trial of anti-secretory therapy if the patient has no alarm symptoms, because the number needed to treat for a response is relatively small. Also, there are many patients with typical GERD symptoms. You cannot test all of them. So a pragmatic approach is to use a PPI trial if there are no alarm symptoms. But if you need to test them, these are the tests you would do. You start with endoscopy. You can use one of the forms of pH monitoring and sometimes manometry. For atypical symptoms, you're probably better off using pH impedance over wireless pH testing. We'll talk about that in a second, but this is the complement of tests. And you can see that for each of these, the starting point is an endoscopy. You have to remember some of the confounders here. For typical symptoms, it's generally behavioral syndromes like supragastric belching and rumination. For atypical symptoms, pulmonary and ENT disorders need to be excluded. So it's very important for the person who treats GERD to understand what the esophagus looks like. And it's very important to recognize a normal appearing esophagus because that's the most common finding in gastroesophageal reflux disease. A normal endoscopy is the most common finding. And then you can find one of these grades, LA grades of esophagitis, peptic stricture, Barrett's esophagus. So among these, LA grades B, C, and D, peptic stricture, and Barrett's esophagus represent conclusive evidence of gastroesophageal reflux disease. You have these features, you don't need to test them with any other adjunctive means, start treating them. If the patient has a normal endoscopy or has LA grade A esophagus, that's when you need further testing. So in the absence of GERD evidence on prior testing, if the patient is symptomatic, we call that unproven GERD, and we study them to decide if GERD exists. Most of the time, these are patients who haven't responded to your PPI trial. And you have two options. You have wireless monitoring. I don't know if wireless is available in India, not available in India, or pH impedance monitoring. And the idea is to identify or rule out GERD. I'll just tell you briefly about wireless pH monitoring, because when it does arrive, it's a very useful tool. You can do it during that index endoscopy if you bring the patient in for endoscopy off PPI. So that's what a wireless probe looks like. This is the equipment that we use, wireless receiver, a handle, and a catheter, which has the probe at the tip. The probe has a little well, and that's connected through the catheter to suction. And when you apply suction, a little bit of esophagus gets pulled, mucosa gets pulled into the well, you fire a pin, and the probe stays in place. It stays up to about a week, 10 days, and you can record for up to 4 days, 96 hours. There is a second company that makes it now, Alpha One. Library makes it. The original company is Medtronic. Advantages: catheter-free. Patients can do their normal activities, not feel impaired. You can have prolonged recordings. Disadvantages: single recording site. So if the patient drinks orange juice all day, you may think they have GERD, because the probe cannot differentiate between retrograde and anterograde movement. It can fall off. It's higher expense because you need an endoscopy. But if you time it right, if you're doing it with the index endoscopy and the patient is scoped off PPI, that can be useful. So how do you use this? So if the patient has typical symptoms, you do an upper endoscopy off PPI, and you don't find erosive esophagitis, you place a wireless pH probe, and you see physiologic acid exposure all 4 days of recording, that patient does not have GERD. They probably have a behavioral or a functional syndrome. You can stop the PPI. On the other hand, if they have LA grade B, C, or D esophagitis and or elevated acid exposure on more than or equal to 2 days, so the threshold here is 6.0, they have GERD. And so you need to escalate GERD management, use lifestyle measures, and sometimes combine behavioral therapies because some of these patients may have overlap syndromes. Everything else in between, inconclusive GERD. And these patients may need treatment both from a GERD perspective as well as from a non-GERD alternate etiology perspective. And we'll talk a little bit about how to differentiate these syndromes in just a minute. If the patient has advanced grade esophagitis, LA C or D esophagitis, or if they have bipositional reflux, both in the upright position and supine position, especially in the context of a hiatus hernia. Those patients are difficult to manage with medicines alone. They may need surgery. Now, pH or pH impedance catheters are placed based on manometric localization of the upper esophageal sphincter. This is a pH catheter. This is a pH impedance catheter. These days, when available, pH impedance catheters have supplanted pH-only catheters. But the idea is you have a pH measurement site 5 centimeters above the lower esophageal sphincter. This is what the catheters look like. This is what the receivers look like. That's what it looks like when it's placed. And the measurement, the analysis software looks the same for the 3 companies, the major companies that market them. Advantages: this has been around for years and years. You have the capability of looking at the bolus with impedance, no dislodgement. Disadvantages: patients hate it. You have a catheter sitting out of the nose, patients go home and just sit. They don't do anything. They don't do their normal activities. And you cannot get data longer than 24 hours. Now, the problem with pH impedance monitoring is the analysis softwares don't always identify the reflux episodes correctly. Sometimes they overcount reflux episodes. So a few years ago, we got together and decided what a reflux episode should be. The Wingate consensus. You can see these listed here, but the most important of this is the lowest row here. Automated analysis is not reliable. The interpreter has to look at every single episode identified by the automated analysis and decide if that's real or not real. If you do that, and you have reflux episodes that are more than 80, and the patient does not have supragastric belching or rumination syndrome, those patients will improve if you treat reflux mechanically, right? These are reflux episodes, and you treat them mechanically, as in fundoplication or magnetic sphincter augmentation. Values less than 40, normal. So reflux episodes are accurate if pH impedance is utilized and can predict outcome, but there are problems. You have to have good expertise in interpretation.
Baseline impedance low can sometimes reduce your detection of reflux episodes. Baseline impedance is actually a very useful metric because low baseline impedance tells you that there is longitudinal damage to the mucosa of the esophagus. And this is a normative study from a few years ago showing you that the 5th percentile value of baseline impedance around 1500. So that's what's adopted as the threshold below which baseline impedance tells you there might be mucosal integrity damage. Values above 2500 are considered normal. And in this study from Italy a few years ago, you can see that in patients with normal acid exposure time, the value is much higher than in patients with truly abnormal acid exposure time, when it was lower than 1500. And in healthy controls in the same study, the value is closer to 3000. So those thresholds have held. It's easy to calculate. It predicts outcome, useful when AET is inconclusive. What about manometry? So manometry, this is a graph that tells you acid burden in terms of reflux episodes, PSPW, which I'm not talking about today because that is obsolete from the Lyon consensus, acid exposure time, and baseline impedance. And with Chicago 3.0, we had a category of manometric diagnosis called fragmented peristalsis. That went away with Chicago 4. And so these curves have stabilized a little bit with the new criteria for ineffective esophageal motility, such that there is a progression of acid burden from normal through ineffective esophageal motility to absent contractility. And if you look at the acid burden with the Chicago 4.0 IEM, it's much higher. What does this tell us? This tells us that these hypomotility disorders diagnosed using 4.0 are adjunctive evidence for reflux. But one of the more important reasons to do manometry is to rule out achalasia in patients with reflux symptoms that are not getting better, because sometimes you can make that error of missing achalasia and thinking that a person with achalasia has reflux because they can have regurgitation and retrostromal burning in addition to dysphagia. So this is the Lyon consensus figure for unproven GERD. So conclusive evidence, like we talked about, the endoscopic findings, as well as pH or pH impedance showing elevated reflux burden. Important to note, evidence against pathologic reflux, acid exposure time less than 4, but there is no endoscopic correlate for evidence against pathologic reflux, because in normal endoscopy, you can still have reflux. If the patient has borderline or inconclusive evidence, then you need something from the adjunctive row to increase your confidence in presence of true reflux. Or if these adjunctive evidence is not present, then those patients may be managed similar to patients without reflux evidence. Now, a few months ago, actually a year or two ago, we created the Lyon score, a score based on the Lyon consensus, where each of those parameters was given a score. And when we did that, we could actually phenotype these syndromes using the score. And the median scores were very different. We used a developmental cohort from the US and Europe, and then we validated with a European and an Asian cohort. And the important point here is that using the Lyon score, we could predict outcome. The higher the Lyon score, the better the outcome. What this means is that the more evidence there is, just like with obstruction, the more evidence there is for reflux on testing, including endoscopy and pH impedance, the higher the likelihood that the patient will improve. Now, when GERD evidence is present, we have documented that, and the patient is not getting better, then we test the patient to decide why their symptoms persist. You only have one option there, pH impedance testing on therapy. And the idea is to identify or rule out refractory GERD. And so the Lyon consensus provides those numbers too. If on PPI, these criteria are met, that fulfills diagnosis for GERD that is refractory to whatever treatment the patient has been offered, and you have to escalate or go to the next step. On the other hand, if you have normal metrics on therapy in patients who are symptomatic, that means the GERD is controlled. Again, we have borderline and supportive evidence. So let's talk for a second about inconclusive GERD. Inconclusive GERD, that category in the Lyon consensus, this is off PPI, that's on PPI. What you're trying to do here is to decide if you have confidence in true GERD enough to offer the patient something permanent, invasive management or escalation of therapy. How do you get there? You use these adjunctive metrics. Hiatus hernia, low MNBI, high reflux episodes, and we have a score based on manometric characteristics called Milan score, and recently we introduced the Lyon score. Need to remember that each of these has confounders that might alter how you interpret this. On the other hand, if you have low confidence in true GERD in the context of borderline or inconclusive evidence, these are the characteristics that would lower your confidence, then you would treat these patients as a disorder of gut-brain interaction or a functional disorder, but also need to remember that GERD can coexist with disorders of gut-brain interaction. Important to personalize treatment to each patient and address their fears and concerns. Sometimes they tell you they're taking their PPI, but they may not be. They may not be taking it right. Important to incorporate lifestyle and behavioral options. And one of the things I like to talk about is that never order a test unless you know what you're going to do with the results. These esophageal tests are not to be interpreted without context. So I only order these tests if I know exactly what I'm going to do if it's abnormal and what I'm going to do if it's normal. So what is actionable GERD in 2024? The modern definition requires evidence of conclusive reflux-related pathology on endoscopy and or physiologic testing and the right symptoms. And why is this important? This is important because if somebody has actionable GERD, if somebody has conclusive evidence of GERD, you can escalate your management to permanent treatments, which are more likely to help than hurt the patient. Troublesome symptoms alone are enough to start medical management in the absence of alarm symptoms. But if you're going to escalate beyond medical management, you need to have conclusive evidence. These are the typical symptoms, the atypical symptoms. The more atypical the symptom, the less the likelihood of GERD. And the reason for testing there is to rule out rather than diagnose GERD. And the more atypical the symptom, the higher the need for upfront testing for management. And that's it. Thank you very much.
Thank you so much, Prakash. Dr. Chen, you can also come. We can have some questions here. So I'll start off one question from my side, Dr. Chen. You both can please take a seat. So we do a lot of manometries on patients who already had an intervention done in the foregut. For example, they may have undergone a fundoplication, and nowadays usually they have undergone a poem, and they come back to us with repeat symptoms. So one of the caveats with Chicago initially was that it can't be used in a patient where you already have an intervention done. So is this something that we are looking forward for the next iteration, that how do we classify findings in such patients?
Yeah, so that's an important caveat with Chicago classification, right? It's supposed to be for patients who have not had surgical intervention, and that's how the metrics are. And I think that's going to stay, most likely going to stay that way. The one that has been developed, that has recently just been published, targeting these post-surgical patients, is the Padua consensus that focus on patients of anti-reflux surgery to have different sets of criteria and help you determine some of these EGJ metrics. So that just came out, I think, a couple months ago. And so that will be the one, hopefully it will be further developed for these post-surgical patients compared to Chicago being for sort of native esophagus.
After that. So I will tell you that the term that is coming out of that is called PFOO, P-F-O-O, PFOO. That is post-fundoplication upflow obstruction, right? The patients who have dysphagia after fundoplication may have PFOO. And you may have the same findings as EGJ outflow obstruction, but with compartmentalization. That might mean that the patient has a tight fundoplication. And there are also entities that are the opposite of that, right? A separation between the LES and the diaphragm, which tells you that the wrap has slipped or is distorted, is no longer functioning. And then finally, you have a category where the wrap
is doing what it should, yet the patient's symptomatic. Those patients probably have functional symptoms.
I think the worst ones that we see here are when you have an ecclesia who's undergone a myotomy, a Heller's myotomy, along with the fundoplication, and they come back to us with dysphagia. That's where challenge lies, whether it's a wrap causing the problem now or it's some remnant myotomy, and that's where we are not too sure what to do with them.
See, in those patients, the one metric that is not very useful is the IRP. The IRP is one metric that is not very useful. The provocative maneuvers during manometry are useful, but more useful than that are the barium, the timed upright barium, barium pill swallow. And in the US, we've been using functional lumen imaging probe a lot, flip a lot for those patients. But the first step in these patients, before you go too far, is just take a simple 20 millimeter balloon and just drag it across the wrap. Sometimes these patients have some structural elements, some adhesions and things like that outside on the wrap. And if you just pull a balloon through and they get better, you could just leave them be and you'll save them a lot of testing.
Yeah, I think the other thing is it's sort of the timing of the symptoms as well. So if patients, you just did a Heller, you just wrapped them and they're just not getting better, they could be related to the wrap, it could be related to adequate myotomy. But if they did well and they've been well for a long time and they come back years later, then maybe it's more likely some type of adhesions, right? And you have to think about that.
So you already mentioned in your talk, but can you be more clear that when we should do 24-hour pH impedance test in patients who are continuing PPI? Definitely we stop it 7 days before, but in those in whom we should do on PPIs 24-hour pH test.
That's a very important point. The patients in whom you would do a pH impedance study. You can't do a pH study on PPI. That's useless. You're giving them an acid suppressant and you're trying to measure acid. You're not going to find any. All right. So the test of choice there is going to be a pH impedance. The patients in whom you do a pH impedance study on therapy are the patients with proven GERD. So sometime in the past, they've had erosive esophagitis, or they have evidence of Barrett's esophagus, they have peptic stricture, or you've done a pH study of PPI and demonstrated abnormal acid burden. And now you've treated them and they're not getting better, right? You've treated them with PPIs or whatever you've given them, they're not getting better. Those are the patients where the reason for testing is to find out why they're not getting better. And that's why you would do testing on PPI. Now, the more common scenario where you do a pH test is you've tried to treat the patient, they've not gotten better, but you have no prior evidence of reflux. Those are the patients where you're trying to decide what do they have, and only about a third of those patients will have reflux. So in those settings, you do pH or pH impedance testing of PPI. If they have atypical symptoms, isolated atypical symptoms, they have hoarseness or they have globus or they have cough, those patients have a very low chance of having true reflux. Isolated, not cough plus heartburn, but just cough. And in those patients, also you would do testing of PPI because you're trying to decide if they have reflux and if you're going to have them invest in taking a PPI long term.
Any one of you can answer. Both of you have explained very nicely for the general practitioner how to interpret the manometric findings in your day-to-day practice. But the question comes when one of these manometric findings says fragmented peristalsis. How do you interpret these patients? Because they have some vague symptoms. You have done an endoscopy. Endoscopy is normal. Do a manometry. They have fragmented peristalsis. Rest everything is normal. What do you do about these patients?
So fragmented peristalsis is actually now part of ineffective esophageal motility. So when you think about ineffective swallows, it's either weak, failed, or fragmented. It will be counted in there. So I would treat them like patients with an ineffective esophageal motility finding, which, as we know, as we just talked about, the clinical relevance is unclear. And for these patients, I think if it partly depends on what their symptoms are too, right? If they have a lot of perceptive symptoms, heartburn, I would definitely try, empiric PPI, evaluate for signs of reflux. That would be the way I would go. If they have transit symptoms, then really look for that obstructive physiology. Do additional testing, provocative testing, make sure there's no signs of outflow obstruction. And if they are normal, then they are probably not related to that fragmented or swallows or IEM. You may treat for functional dysphagia.
And any role for calcium channel blocker in these patients?
Calcium block.
Oh, no, I
No.
would not.
Thank you.
So the Chicago 4 parameters and the provocative test mainly came for the solid state catheter. But in India, at present, most of us are using the water perfuse system. So do you think these provocative tests, the parameters are the same, and how good are they in comparison to the solid state?
I think you can still get a lot of information from that. For example, when you do these provocative measures, you're really stressing your esophagus, and there's still metrics you can look for, like maybe relaxation pressure, to see if there are signs that by stressing the esophagus, that you might see like a non-relaxing LES, for example, that you might bring it out just by doing this rapid drain challenge, for example, because the IRP, and it's sort of trying to represent whether or not there's really real relaxation.
See, I would say that don't get hung up on numbers. If you're doing provocative maneuvers with water perfuse, look at the pattern, because just based on how water perfuse manometry works, you have to have the patient balanced, right? The level of the catheter has to be balanced. You calibrate it according to where the catheter being level. So the moment you put the patient upright, you've lost that. And so what you're really looking for is pressurization of the esophagus. And if you see pressurization, don't look at the IRP. It's not going to be reliable. Look at pressurization. And pressurization, if you do a rapid drink challenge, correlates with IRP, right? But you're most likely going to need to corroborate that with another simple test that's available around the world, barium. You just need to corroborate it with barium. And so if the way I approach this is, even with solid state that we have, the more evidence you have for obstruction, the more likely it is that there is true obstruction. So if the patient has dysphagia, right? If the patient has a borderline IRP, the patient has positive rapid drink challenge, the patient has an abnormal barium, I'm there. They have obstruction, right? If they have only one or two of these, then I may go further and give them a meal. And you can do that with water perfuse.
Yeah.
Give them a meal with the catheter in place and see if you can see pressurization. If you don't, then the dysphagia is probably due to something else and not a motor disorder that you can actually impact with therapy.
Thank you.
Okay,
Can I ask
to
a
close
last-
now
yeah.
because there's a live session coming up, which will be on endoscopy. And thank you both, Prakash as well as Walter. We had a small manometry and pHmetry session, but that is wonderful for all of us. We learned a lot, and there were focused people sitting here. So I'm glad that you could come along. Yeah. Dr. Rupra, I wanted to say something. Okay. Thank you very much. Yeah.
Thank you.
All of us. Thank you.
And moderators for the nice session. So we'll start with the live session now. नहीं इसके बाद एक बार चालू करने के बाद. So I invite the moderators and chairperson for the first live session. May I request Dr. Ajay Jain, who's the moderator, to come onto the dais. Chairpersons are Dr. Mayank Kabrawala, Mayank, Dr. Naveen Yadav, Naveen, Dr. Arvind Gubbi, please, Dr. Ashish Joshi. Ashish, you are there? Mahavir, you can replace him. Dr. MP Sharma, please. And Dr. Haribhakti Sevadas has she come? Dr. Dax Khurana. I hand over the mic to Dr. Ajay Jain to start the proceedings.
Good morning, everyone. So, are we connected with the hospital? We'll have the live session for the whole day, and there are a lot of cases which has been lined up, which will be telecasted live from Kalla Hospital. And meanwhile, by the time we get connected, if there are any questions related to the topics, you are most welcome, because there are 4 experts sitting with me to answer your question. I think we are connected. Can someone give us the history and clinical details of the first case, which is going to be demonstrated live? Can someone check this too?
Hello. Hello. एक बॉक्स भी देना है वाइट बैलेंस हो रहा है जो दोनों वाइट बैलेंस कर देना कर दिया था नोट क्या क्या बोल रहे सॉफ्ट कैप है सॉफ्ट डिस्टल
There is no audio. We are not able to hear you.
ब्लैक कैप हो तो बहुत ब्लैक कैप है सॉफ्ट ब्लैक कैप
Moinish, good morning.
ब्लैक कैप मंगवा दो ऑडियो का भी तो करना पड़ेगा नहीं उधर से इधर और इधर से उधर इधर से उधर जाएगा Doctor? Hello.
He runs the show here. He is the guy running the show here.
Hello. ठीक है. Thank you, sir.
Anesthesia में one man show है यहाँ पे.
इधर से आएगा. पहले
Hello. Just hello. Simply. आ गया ये लाइव.
ये ऑन है.
We are not able to hear you.
Hello.
Yeah. On.
Good morning, everyone.
Are we
Am I audible?
Yes.
Yes. Good morning, Moinish. Good morning.
Dr. Ajay, can
Good.
you hear us?
Yes, we can hear you. Are you able to hear us?
Yeah.
Good
Very
morning.
well.
Good morning.
Good morning.
Very good morning, everyone. Maybe start the session today morning with the Ganesh Stuti. Vaktundaye Mahakaya Koti Surya Samprabha Nirvikne Kurumadevo Sarvakaryeshu Sarvata. We are working with patients and the patient safety is first for us. So therefore we requested, and I will just introduce you to my team. And this is Dr. Pankaj Rimal. This is Dr. Pankaj Rimal. He is the backbone of this hospital. We have Dr. Alok. We are working for 20 years together now. He is so-called an anesthetist, but he is now a gastroenterologist as well because his IL intubation rate is 99%. Then we have Suresh, he's our third year PG. Then we have Shreyans, who's our third year PG. We have Sankalp, and Sankalp has really worked hard to get all these patients in place with all their PSC investigations in place. Then we have Deepanshu, Akshar, and Naveen. So now I hand it over to Dr. Malay Sharma and Dr. Abhinav Sharma, my best friend. He's been very helping. He sent his own best technician here to help us. So over to Monish.
Thank you, Dr. Kalla. Thank you, Dr. Nijaman, and giving me the opportunity to be the opening batsman of your workshop.
So you're Virat Kohli.
And I've been aided by Dr. Abhinav. Dr. Alok is the anesthetist. And I've been asked to demonstrate image-enhanced endoscopy, the NBI for the esophagus.
Yeah. So this lady is a 60-year-old with dyspepsia symptoms, and her upper GI endoscopy showed a tongue-like velvety projection suggestive of Barrett's. So Monish will be demonstrating image-enhanced endoscopy.
So before I start, I must tell you the equipment. I'm using Olympus X1 CV1500 system, and this is EZ1500 scope. And this scope has an optical zoom also, has a texture mode, EDOF mode, and these are the latest from the Olympus. And can I have a cap? So for image-enhanced endoscopy, it is always advisable that we use a soft black cap, which really helps to enhance the magnification and to optimize the focal length. So before I start, I must tell you that I have my own preference. Different people have their own different techniques of doing endoscopy. I usually like to start with an NBI mode. And I like to spend few minutes, less than a minute, examining the oral cavity and pharynx. As you all know that the cancers of oropharynx are diagnosed usually very late. And these areas are usually examined by the ENT surgeons and physicians. But as gastroenterologists, with this technology in hand, we have an opportunity to diagnose very early cancers of oropharynx in carcinoma in situ. And as you know that these cancers, if diagnosed early, will have good prognosis. And majority of these cancers are diagnosed very late when they have already metastasized. So I start with the NBI because NBI, what I look for is a brownish spot, which is a cluster of speckled capillaries, which is angiogenesis in the oral cavity. So when I start, I have a good look at the palate, both the hard palate as well as the soft palate. And in NBI mode, if you see, the mucosa would look bluish white or a greenish white. And if I give you a view of the white light, this is how everyone is used to of a white light image. But I personally feel that while entering, it is So this is the, if you can all see, this is the soft cap, black cap, which we can apply at the tip of the scope, and this would help us in basically focusing the lesions well. Yes. Yes. Do you always attach a hood to your endoscope? Not routinely, but definitely in most of the high risk cases where I believe is an alcoholic, chronic smoker, or has a long history of dyspepsia, elderly, where I feel that will be able to get some, or if a previous endoscopy is available where a lesion has been seen and you want to really characterize, I like to use these caps. So if you see that I am entering the oropharynx, and this is the soft palate, the uvula, you just spend few minutes looking for some brownish spot here. And you can, in less than few seconds, you can see the buccal mucosa, you can see the hard palate, you can see the soft palate, and you'll be able to see for any suspicious spots here. So gradually you go down the oro, you reach the posterior pharyngeal wall, and this is the tonsillar area here. And towards the pharynx, again, you're basically looking for anything abnormal, the collection of, speckled collection of capillaries which are there.
Whenever you encounter these cases, you use defoaming agent also?
For the, yes, defoaming agents we use, especially for the esophagus and thing, you can just ask the patient to drink some water beforehand, because it usually will clear them of this saliva which we are encountering. So here you can see that we are examined the posterior pharyngeal wall, but I'm yet to see the laryngeal inlet. And here if you see that varying caliber of IPCLs here. So this is the left piriform sinus, this is the right piriform sinus, and you can appreciate these IPCLs here, which are normal. So normally, in a non-magnifying endoscopy, you are unable to recognize these IPCLs. So important thing here is that by using NBI and with magnifying endoscopy here, you can see that you can appreciate these fine IPCLs in the mucosa. So gradually then you go down from the pharynx, you cross the cricopharynx and enter the upper esophagus. Can I have the water jet, please? So water jet is very important here to clear the esophagus of all the saliva before you start to go down. So clearing of the esophagus again is the most important step, that hurriedly you should not be just going down towards the G junction. So as you all see that esophagus, oropharynx is lined by stratified squamous epithelium. It doesn't have any glands. So what you are going to see, there is no pit pattern here. What you are going to see is the microvascular pattern. And as you go down, what you are going to see are these branching green veins. Can you see these branching green veins? So these branching green veins are above the muscularis mucosae. And from these branching green veins, you can see the small brown dots. Can you appreciate?
Yes, sir.
So these are the intracapillary papillary loops, IPCL. And these IPCLs are very important. And in cancer, as well as in inflammation, they get dilated, they get tortuous, they increase in caliber, and they are of various forms. This is what we have to look here. While we are going down, we have to look for an abnormal brownish patch. And what you see here, if there is some abnormality in the mucosa, these green branching veins will disappear in that area. You won't be able to see these green branching veins. So that would make it a suspicion, and it would look brown if there is an early squamous cell carcinoma, which will be suspicious, and there would be a demarcation line. So important features would be looking for a brownish patch, brownish spot, absence of these greenish veins, dilatation of these IPCLs, and presence of a demarcation line. That mucosal abnormality would be either depressed or slightly elevated, and you will be able to distinctly differentiate it from the normal mucosa. So as you go down, you see certain glycogen deposits, like this deposit where you see these whitish. Can you appreciate this? So these are the glycogen, normal glycogen deposits which are present in the normal esophagus. And as you go down, slowly you continue washing and slowly looking for any abnormal brownish patch on all the walls of the esophagus. And gradually as you go down, you reach the G junction. So G junction is very distinctive. There is a sharp contrast between the gastric mucosa and the esophageal mucosa. The gastric mucosa on the NBI would look brown. As you can see here, there is a sharp contrast because the density of vessels in the gastric mucosa is very high. So that is why it gives a brownish appearance as compared to the esophageal mucosa, which appears bluish white or a greenish white. So there is a great contrast. So on this great contrast, we can see that there is an abnormal squamocolumnar junction here, which seems to have migrated proximally into the esophagus. So before we assess the Barrett's segment, we have to look for three important morphological landmarks. So the first important landmark is a diaphragmatic pinch. The second important, this is the diaphragmatic pinch, which is there at 36 centimeter. And important thing here is to remember, and this is for all the residents, that you assess for Barrett's and esophagogastric junction on withdrawal once you have deflated the stomach. So once you have deflated the stomach, you are coming back. That is the time you have to look for these landmarks. So three important landmarks are, the first landmark is, so I'll switch it to the white light here. The first landmark is a diaphragmatic pinch. So if we see here on deflation, the diaphragmatic pinch is almost at 37 centimeter. And then we have to look for G junction. So what is the definition of a G junction? We can see G junction by two parameters, the top of the gastric folds, and number two is lower end of the palisade veins. So here if I see I have deflated, and the other important trick here while you are evaluating the G junction is that you have to minimally inflate. Don't overinflate. If you overinflate, that is also will lead to wrong assessment of all these parameters. If you see here, the top of the gastric fold, so this appears to be the top of the gastric fold here. So this G junction, this is almost at 36 centimeter. So 37 centimeters was the pinch, 36 centimeters is the top of the gastric fold. So that is a difference of 1 centimeter. So anything beyond 2 centimeters, we call it as hiatal hernia. The third important landmark is the Z line, which is a squamocolumnar junction. And if I see here, the squamocolumnar junction is coming almost at 34 centimeter here, 35 centimeter. So this is almost 1 centimeter tongue of proximally migrated columnar mucosa in the lower esophagus. And by definition, we call Barrett's esophagus if it is almost more than 1 centimeter proximal migration of the G junction. So we will call it, since it is less than 3 centimeter and there is only one tongue present. So this is a short segment Barrett's, where we further classify it according to the Prague classification, that from G junction you have to see the length of the maximum tongue and the circumferential component. Since we don't have a circumferential component here, this would be C0 and M1 according to the Prague classification. So once you are done that, yes, this is a Barrett's esophagus and this is a short segment Barrett's which is present at the lower end, then you have to further characterize and see and look for the mucosal patterns and the vascular patterns. So these patterns usually on the white light, what you have to do is in any Barrett's, you have to look for first any mucosal abnormalities, any nodule, any protrusion, any ulcer, anything in the, and usually if you find any mucosal abnormality, you have to biopsy that and you have to look at with more clearly with image enhanced endoscopy. So after you have seen on white light that is there any abnormality on red light, you go and switch on to the NBI mode. And on the NBI mode, what you are looking for are the mucosal patterns and the vascular pattern, surface pattern and the vascular pattern. And here if you see I have magnified, the mucosal surface pattern becomes clear. So what are the various surface patterns? There are 4 kinds of surface patterns which we see on the Barrett's. Either we call this as circular, which is type A. Type B pattern is ridged, villous or straight. And C pattern is again absent pattern, and D we call it as irregular or a malignant pattern. if you can see here, there are two kinds of pattern. We can see a circular pattern surface. Can you appreciate, Dr. Ajay? And at the bottom, you can see some linear pattern also. So this is a type A plus type B pattern you can see in this Barrett's. And also we have to look for any irregularity in the microsurface and microvascular pattern. So it appears that all this pattern looks very much, the surface pattern looks very much regular. And then what you have to see is for the vascular pattern, and the vascular pattern is again divided into honeycomb. As we see here that around the pits, you can see these brownish vessels, and or these can be leaf-like. As we see here, these can be spiral vessels or coiled vessels. So these are the four different patterns of micro capillaries which are described in Barrett's. And if we see that what we are looking basically is for irregularity of microsurface, irregularity of microvascular for any dysplasia which is not there. So in this particularly short segment Barrett's, we don't find any evidence of dysplasia. And depending on the findings, you can take biopsies which can be guided by the image-enhanced endoscopy in Barrett's esophagus.
Do we have a depressed area there, sir, in the center?
We have a depressed area here. It appears to be there is some adherent mucus here. So we are unable to see beneath this mucus.
If we encountered such a situation, can we use defoaming and antimucolytic agent?
That we see, yes. Now you can differentiate here that we see a area at the bottom which shows some demarcation line. Can you appreciate? As compared to the surrounding, the central depressed area. Probably I feel this is a site of a previous biopsy which has the biopsy been taken previously here? So this could represent a previous endoscopy and biopsy, I personally feel. Has the biopsy been taken here in the previous endoscopy? So even if biopsy has not been taken, we can probably, since we don't see any specific surface pattern which appears to be absent, and we don't see any dilated microcapillaries, it appears to be a slightly area which probably I personally feel has been biopsied earlier. That is why we see a depression here. So in the lower esophagus, you can also see these intrapapillary capillary loops which are not dilated. And in a patient who has a reflux esophagitis, you may see these dilated and tortuous IPCLs which are type 2, type 3, and here you can see these IPLs. Can you appreciate? They are a bit dilated and can you appreciate? So slightly dilated and longitudinal IPCLs we see here. Yeah. So we are using a mucolytic to remove this mucus which is adherent to the depressed area which we see in the short segment Barrett's.
If you encountered a well-differentiated brownish patch, would you still use Lugol iodine or just image-enhanced?
You see, image-enhanced endoscopy usually is sufficient, but to delineate the margins before doing an ESD, I think Lugol's iodine, not for diagnostic, yes. And here if you see that we can see some dilated IPCLs in the lower esophagus. Can you appreciate these? So normally these IPCLs are 10 microns and not seen on a non-magnifying endoscopy. You can only appreciate And in a case of reflux esophagitis, you have more increased density of these type 2 IPCLs, which are slightly dilated, elongated, and they appear as an inverted Christmas tree appearance. You have linear rows of these IPCLs. That in a case of a non-erosive esophagitis, also you can appreciate and tell on NBI that this patient has a significant reflux. So, any questions, Dr. Ajay? Yes. Daksh.
EMR and ESD.
Yeah.
With the image enhanced endoscopy, do you still take a biopsy and are you bothered about the submucosal fibrosis that it creates and for a future therapeutic procedure that is planned?
I think that is again a very good question, Daksh. So there are, I can say, two views on it. If you see actually the Japanese, they usually do not take biopsies. They are 100, these findings are almost 100% specific when they diagnose early squamous cell cancers. But if for medical legal purposes, for convincing the patient, for confirming, if you are taking a biopsy and you decide, so probably a single biopsy, use a pediatric biopsy forceps rather than a big biopsy forceps, and that will prevent that submucosal fibrosis. But if you're, sometimes the patient is not convinced, he would like to take an opinion, for that, definitely you have to take a biopsy sometimes. And for Barrett's esophagus, yes, you have to take a biopsy and confirm dysplasia, and then do EMR or ESD, whatever is indicated. So I think for Indian setups where you have to confirm before you advise a patient a surgical EMR or ESD procedure, you have to confirm. But certain cases are very straightforward, and you know that your findings are 100% specific for diagnosing early cancer, you may not take a biopsy. Huh? Okay. So they have taken a biopsy from this Barrett's. So probably this is a site and a scar of previous biopsy. So any other questions? And yes, Dr. Ajay? Slightly, yes, you're absolutely right. Not a right, because that is just at G junction where the biopsy has been done.
Previous biopsy actually showed gastric type of mucosa.
So important here is that whenever in a Barrett segment, you take a biopsy, how do you know that from where you are going to pick specialized intestinal metaplasia? So the mucosal patterns which I described, if you take it from the circular pattern, you are unlikely to get specialized intestinal metaplasia. So it is important to visualize ridge pattern, villus pattern, or a straight pattern from where you should be taking. And as rightly said by Dr. Ajay, that it should not be near the G junction, it should be taken proximal to that for demonstrating specialized intestinal metaplasia. Yes. We can use I think this is a short segment Barrett's. I know the risk of dysplasia is very low. Rest of the Barrett's which I see is absolutely having a regular microsurface, microvascular pattern. So probably I will not do a chromoendoscopy or acetic acid chromoendoscopy in this patient. If it would have been a large Barrett's segment, or there would have been some abnormality mucosal, definitely I would have done in that case. So the probability of finding dysplasia here probably is very low.
So we have an interesting case in other room. I think we should shift to other room. Here, I think you demonstrated it. Yeah. Thank you.
Thank you. Thank you so much. Thank you.
You don't require it as it is, any antiperistaltic agent, if the patient is having a good sedation. Sir, I have been using this system very newly now, and I didn't had any problems in without anything, sir, in that manner. Sir, this is a new system. We are just basically detecting out things. The time will. The studies are there, sir. The detection false positivity rate is absolutely as with the lower GI1. And it is said, by the systems studies that the accuracy is roughly around more than 90%. This is what the fluid is inside, and so you have to suck it before getting the real picture of the stomach. And this is the second point which we are going to take, which will give us the stomach's greater curvature, and at the same time, you can see the angulation is still not proper, hence we are not getting it. So the only system, the problem here is that you need to have a very clear vision and certain areas of angulation which needs to be there as it is. So it's a 7-point check program. Normally when we do an endoscopy, we just see like this and go away. But with an AI system, you have to be a little bit more patient. And at the same time, you have to keep on finding out the real area which will give you the area of a greater curvature as well as the area of introduction. It is not yet giving us the real picture out. aa gaya. So the angulation is the has to take care of. You can see the picture now, and it is ticked by a green line in the box given.
So we just saw this a red area, and this was not, we didn't get any signal for that.
No signals for that.
We should have got it.
Now this is the incisura system where you can see again the green light has come up. The angulation was perfect, so we have got it. Now this is the pylorus, as we all know, and we have to be a little bit away from the pylorus in order to have the angulation coming up properly. So here is the pylorus, which has given you again a complete picture. Now once you retroflex the scope, normally we see the retroflexion. We inflate a little bit of the stomach in order to see the lesser curvature. So the 3-point check program has been done. We are still left with 4 points. And
fluid will interfere.
The fluid interferes, of course, it has to be a very clean stomach, so we are sucking it. Of course, in a normal case, in a high volume center when endoscopies are done like this, normally within this time, one endoscopy is already over. But when you do an AI, and if your residents are really, have been doing it at any center, and if the boss is not around, he can check it out and find out whether this endoscopy has been done completely or not. So I have to still suck in, in order to get the lesser curvature point coming up. So can I have the air on other than the, yeah, I can get it now. So this is how, which we see, we still don't, give me the air, please. The air go high. The fluid is obstructing the way in between. Okay. The inflation is a little bit creating a problem, but I think, we should be able to get away with it. And yes, of course. This angulation, in fact, is there, and we have seen basically just below the cardia what exactly is there. So this 4th point again has come up very nicely. And now we are going to inflate a bit to see not the pylorus, we are going to now see the lesser curvature up and the cardiac. It has come up now. So it is a complete point check program here. And you are left with a little bit of a thing. And that is the last part of the greater curvature at the lesser curvature, which is a complete checkpoint that you have done the procedure incomplete. Fluid is obstructing away. We need to clear stomach. Otherwise, this gentleman has got an absolute clear thing coming up, so not a problem at all.
So what are you actually looking at? What are you trying to find? Red areas?
We are trying to find out if there's any lesion. Fortunately, this gentleman doesn't have any lesion as it is, and hence, you are not able to get any disease process to say in this person.
They say look for orange color. So orange will pick up the neoplastic lesion. Violet will be inflammation. That's
Absolutely.
also LCI imaging.
Undoubtedly, it is that so.
And
if you see a good purple imaging, it basically shows that there is possibility of some malignancy down inside. So now, when all this is done, this basically the tick which is there in the box on the right hand upper corner shows that the study has been absolutely complete, and this gentleman, of course, has been seen in completion. This system shows us only about the esophagus and the stomach right away. The Barrett's is to be added in it, and of course the duodenum still cannot be seen. Just to complete the study, we are going into the duodenum to show you that the system 760 series undoubtedly is a good scope, and you can have everything in completion out.
So you saw some red areas. I want you like to interrogate them further with, if you find something, then you use the BLI to evaluate
In fact, if I use a BLI here now,
focus on the red.
Yeah, I'm just going to focus on this red area. This doesn't make much of a problem as it is. If you see here, it's basically, if you go through the Janet classification, you don't get anything, which is significant, even on zooming the scope up. And this is what you basically wanted, sir. And I don't think there is anything in this patient to suggest any early malignancy or whatsoever. Hence, of course, I'm going to start with a white light. And if you can go with this, you get a complete 7-point check program, and you do a complete endoscopy, and obviously there will be no chance of missing any lesion if we use such systems coming up. And of course, a little bit of upgradation will definitely come in near future, and this is going to be a good armamentarium tool in every endoscope suite. So this probably gives us now a complete checkout, and I don't think any questions, sir.
Chairperson? Yeah.
The chairperson, sir.
BK, I am Dr. Nijavan.
Sir, yes, sir. Morning, sir.
Now we are shifting to the other room as the other room is ready and your case is on completion now. Thank you.
Yes,
so
sir.
much.
Thank you, sir. Thank
you. Yeah, now the case will be presented and it will be followed by the live.
Case of a 35-year-old male, he is in history of returning burning from the last 1 year. The endoscopy was registered on actually in large proximal gastric body polyps. We are not able to hear you. Now getting the voice? Yes. Okay. So we are demonstrating a case of a 35-year-old male. He's having a history of retrosternal burning from the past 1 year. The upper GI endoscopy was done, which was suggestive of neck ileus, Gehill's grade 3, and a large proximal gastric body polyp. The plan is for image-enhanced endoscopy and followed by a polypectomy. This is the imaging picture of this patient. Now the case will be demonstrated by.
The case will be demonstrated by Dr. Ashutosh, followed by polypectomy by Dr. Sulfur. Go to room number 4.
Good morning. Can you see me?
Yeah. Over to you.
Okay. So I've been asked to demonstrate this polyp, but as I told you earlier, every gastroscopy is an opportunity to look for early gastric cancer, not only for polyp, but early gastric cancer. So can I get some endo view?
So in our unit, we generally perform endoscopies without sedation. That's why we ask the patient to drink the preparation 15 minutes, 20 minutes prior to the procedure. Okay. But if we are doing the case with anesthesia, that's not something that possible. So in these situations, we kind of spray the mixture of simethicone and N-acetylcysteine. So with all this froth here, it's very difficult to kind of see what's there, the mucosa. So he's kind of spraying the solution.
So we are uncomfortable if we always give endo view or simethicone to all our patients before endoscopy. At least 20 minutes before endoscopy, we give. So let me suction as patient is under anesthesia. Let me suction all the fluid. And how to suck the fluid, everybody knows. Scope position should be in the 5 to 6 o'clock position or in the retroflex position. But I think this position is good. So I am suctioning all the fluids from the stomach. This endo view, we are suctioning. Now, can you tell me in which part of the stomach I am? Anybody who can tell? What is this part of the stomach? Give me some endo view, more endo view. I need more endo view.
You can have water irrigation too.
Okay, water irrigation. I'll take less than 3 minutes to finish. Can you tell me which part of this stomach is? The idea is, I used to tell this one is antrum. No, we are wrong. This is called anterior part of the antrum. So when you start examinations, start from the antrum. Which part of antrum this? This is called greater curvature of the antrum, then anterior wall of the antrum, then lesser curvature of the antrum, then posterior wall of the antrum. So this is like, you just look at my hand, I'm doing nothing. I'm just moving my hand. This is
So it's kind of a circular motion.
motion.
That he's
doing nothing.
It's
then we're doing this scope. So 4 images taken. 1 image, 1, 2. No. Here. What you have done? Yes. You don't do anything from here.
No, I think the release button here is a different one.
Or
okay. Can you switch off the NBI?
so you don't do anything from here. I'll do. So start from the antrum. This is greater curvature of the antrum. This is the anterior wall, lesser curvature, and posterior wall. Then come to the lower body. This is lower body. Again, greater curvature, anterior wall, lesser curvature, posterior wall. Then mid body. This is called SSS protocol.
And it's very important to kind of insufflate the stomach when you are in the mid body so that it just expands the folds of the greater curve. and so that you can see the areas within the folds well. Otherwise, if there is a lesion there hiding, it's
So this is mid body again. Greater curvature, anterior wall, lesser curvature, again posterior wall.
Now this is
Now you can
where,
see
yeah, all the folds are
all
expanded.
the folds gone. I've insufflated the stomach little bit. Now I'm going to the cardia. So cardia has 4 parts. You can see anterior wall, again greater curvature, anterior wall, lesser curvature of cardia, and posterior wall. 4. Or you can see the polyp here. In other way, you just see my hand. I'm doing nothing. I'm just, you can see whole of the stomach. I'm doing nothing. I'm just moving my hand,
Rotating.
just rotating. You can see all the parts. Now you can push the scope little bit. You can see the mid part, mid body completely. So it is very easy. It will take less than 3 minutes, but you should take, as guidelines say, at least 7 minutes to finish the endoscopy examination. Next comes incisura. This is incisura, everybody knows. So when you see incisura, you should see the lesser curvature of incisura, anterior wall. This is anterior wall of the incisura, and move your hand little bit towards the right. This is the posterior wall of the incisura. So this is called SSS protocol. Start from the antrum, four parts, lower body 4 parts, the mid upper body 4 parts, cardia 4 parts, anterior, posterior, lesser curvature, greater curvature. Incisura is APL, anterior wall, posterior wall, lesser curvature. Mid body on the retroflex view, anterior wall, posterior wall, and lesser curvature. Now, as I can see from this white light examination, you see nothing. You see like nothing means there is little bit of atrophy. This is called Kimura Takamoto classification. You must stratify your stomach examination, like which are the high risk patients. If you see atrophy in the greater curvature, then it is severe atrophy. But I think this is some mild atrophy. This is C2 atrophy. Usually atrophy starts from the antrum. This is closed atrophy C1. Then this is C2. And if it extends to the cardia, this is C3 atrophy. I don't think any, this atrophy is located in the lesser curvature of the incisura only. But I can see from NBI examination, this is classical of intestinal metaplasia. Let me demonstrate. I've used a soft black hood. You see still nothing is, you can see not much.
Dual focus. Now he put the dual focus, it's on. Now you can see the micro structural pattern very well here.
So in antrum, what is surface pattern? Surface pattern is crypt opening and marginal crypt epithelium.
Please. Yeah.
Now you can see the beautiful image. This is X1 scope 1500. These white areas are marginal crypt epithelium. And the brownish dot is crypt opening, and all the brownish areas are capillaries or blood vessels. So always look at the surface pattern and vessel pattern. Now with NBI on, you can examine the whole of the stomach. No need to do always white light examination of the stomach. I usually, sometimes if I find time, you can see. Through NBI, you can detect more lesions than white light. It is not always key white light fast, white light fast. Yes, for the beginners, you can do, you can see, I can see every part of the stomach. I can see, you see, I'm starting from the body. Okay. So rounded crypt, this is classical of the fundic gland. Now I can see from where I will reach. You see, I'm just moving my scope little bit.
So one trick with the NBI though is I feel like the second generation NBI scopes.
You see, underwater immersion, you are not going to miss anything. Your early detection of gastric cancer will be a little bit high underwater immersion. You see, I am giving water and suctioning also, because my anesthetist will be panicky if I don't suction. Patient will have aspiration. You can see after endo view, the stomach is so clear, crystal clear image of the, you see.
What would be the pattern with H. pylori infection?
Okay, madam. There are telltale signs of H. pylori infections like hyperplastic polyp, diffuse redness of the stomach, raised erosions, and sticky mucus. Here when I entered the stomach, there were sticky mucus, which I have to remove it. I call it, they are like very stubborn. This mucus is sometimes so stubborn, you cannot remove it. If you try to remove the mucus, you see here there is some blood vessels which are more prominent. You see this image. Can you appreciate the image of these blood vessels? This is not irregular blood vessels. Now let's move forward. I am going towards the So in my unit, we always do such type of examination to see, you see. This is, I think, pylorus we have reached. Antrum and pyloric mucosa are ridge-shaped and tubular. Can you see this mucosa is ridge-shaped and little bit elongated. So this is, we are in the antrum. Just visualize this mucosa for 30 seconds, not more than that. But now look at this mucosa. You see, this is body. This is rounded.
So it's very important to know the normal before
So normal.
knowing the
Then
abnormal.
you see so stomach examination should be done. In the beginning, you can use white light. You see,
That area
Sonmun is pointing to
right.
some area.
in the right. Okay. Sometimes we see this vascular abnormality, like only vascular without any demarcation line. And that's something because of inflammation. So we don't take biopsies from those lesions.
As I told, retroflex and suck all the fluid.
Put up the dual focus. So I just wanted to point out one thing is the NBI in 190 series or less than 190. That's the first generation, I guess. They are dark. And sometimes if you think that doing a stomach examination with NBI, that's difficult because everything looks dark. But this is something second generation NBI with
I think this is third generation NBI, but I must say even 1200 scope is much better than 1500 scope. But this image quality is very good in 1500 also.
Ashutosh, are you getting my voice? And Dr. Nijaman here.
Yes, sir.
Yeah, now we are shifting to room number 4.
Okay.
There will show AI used in colonoscopy.
Okay, sir.
Thank you so much. Thank you. We'll come back to you when polypectomy is ready.
So
right?
this is the polyp.
Yeah, we'll come back to you.
Okay,
yeah.
sir.
Now over to you, Anil. To room number 4 for AI in colonoscopy.
We are changing the guards here. So while Dr. Anil is showing us the colonoscopy, I thank all the moderators and chairperson of this session. I invite the next set of chairpersons and moderators. May I request Dr. Lalit Simbi to come on the dais as a moderator. And I request Dr. Ashish Joshi, Dr. Dhaval Vyas, Dr. Mayank Amekha, Dr. Sukrat, Kapil Jamwal, and Dr. P.K. Agarwal. P.K. Agarwal is already there. So come on to the dais for chairing this session. Go ahead, Dr. Anil.
So as the chairpersons are having the chair, I take that opportunity to just explain a little bit about this multi-light Fujifilm technology with LCI. And
your audio is not very clear.
Okay.
Yeah, we are getting it.
Mic in the hall. Again, we are audible. Is that better?
Yeah, little better.
Chairperson, please.
Abhi?
Yeah, little better, but
After this case,
Okay.
Change the mic.
Mic is
Just
okay.
hold on here.
Increasing the volume.
Yeah, just changing the mic. Give us a minute. Give us a minute.
Am I audible now?
yes, now.
Great. To the chairpersons, to the hall?
Yes.
Thank you. So right now, I'm going to demonstrate in the use of AI in the colon to detect the superficial neoplasia, early superficial neoplasia. Now this, right now I'm in the ileum, and this is a 72 years old male, and let us say we are doing a surveillance or screening colonoscopy. So we use generally the white light for going up and coming back to scan the colon completely. Now, the idea of AI in colonoscopy is detection and diagnosis. Detection means enhanced detection, more detection that our eyes, examiner's eyes may fail to see those polyps. So, and once we find the lesions, then go and characterize them. We have other means of characterizing them. We can characterize them with use of IEE, but then let us see how AI in addition can save us time, finding more lesions, detection, and characterizing more lesions, and quickly and faster.
Presently, where are you, sir?
So right now I'm the ileum, and this is we have white light. This is the white light, and this how it looks in LCI or linked color imaging. As you can see, this light is a very bright light. This actually uses short wavelength to show the surface better. The red lesions appear more redder, and the white appears whiter. So it brings out any superficial flat lesions, small lesions, and which somebody can miss using the white light in a casual manner. So
even the blood vessels are seen much clearer, and if sir sucks a little bit, you can even see that the blood flow in it.
So the BLI or blue light is functionally similar to NBI, where this is the without magnification. This is the and this is the magnification. There's a bar coming up with a continuous magnification. We can go closer, and we have a hood, distal hood, in front of the scope. So now I will pull back. So to scan the, are we on?
Are we on?
Yeah.
Oh, yes.
To scan the colon using the CAD-I, which is the proprietary software. So this is CAD off, now CAD on. I'm coming back. So we have to do nothing in the ileum. So as I pull back, using the LCI light to help the AI, because as I said, LCI is the real detector of lesions. That is an extra feature with this system. So I'm in the ileum. So important thing is you always feel the colon should be very, very clean. I call it sparkling clean. to really do a great job to use the AI. Otherwise, it can turn out a waste of time. So we have some extra fluid here, but generally the preparations, I would say, is okay. Let us see. So coming back from the ileum, CAD on, CAD switch on, and using the LCI on the right-hand side, you can see on top. And as I fall back in the cecum, and we start sweep the colon quickly. So that's the cecum for you. So now, if it detects anything, so somebody was in the audience was asking about sensitivity, etc. Now, thing is, as for practical purposes, when it sees some lesion, some superficial lesion, there will be two indicators. One would be a detection box, which will encircle the lesion, and another will be a beep coming at the same time.
That will tell if you're having a lesion there.
Okay, so right now, and sometimes you can see that detection box over small elevations. So I think this part, and carefully, now insufflate, please. Yeah. So sometimes this little stool, etc., can interfere, and they can show a signal over this. So in which case you just wash, and
the preparation is very adequate.
I think more or less good.
The preparation is very adequate.
So let us see if there is
any lesion in the ascending colon is being looked for. We haven't got a beep as yet. Even in the LCI, can't see any lesion as of now.
So these are the areas which can act as blind areas, and that's why if is anything wrong with the preparation, will just you can miss some polyps there. And some like here I got a signal, but just the mucosa got sucked in as I was sucking the fluid.
And
so
hence it was just false
alarms, false signals. You will have to go and wash, like one here. Now this again, I don't think this again mucosa got sucked.
So the sucked up mucosa basically gets elevated, and the signal comes like a false adenoma there.
Looks like, yeah. So this is the problem with extra.
So one has to
actually, we
get
should be
it
avoiding
careful.
suction. We should be avoiding suction as far as close to the mucosa. So I don't think that's anything. So it inherently is trained to pick up flatter lesions, smaller lesions, which can get missed.
Which are usually missed in white light or by normal colonoscopy.
So no signal here. Okay.
So no signal as yet.
Hello.
So,
yes, sir.
Yeah, Anil, are you getting my voice?
Yes, sir.
Yeah, very nice demonstration. We are shifting for polypectomy, and we'll come back to you for a while.
Okay, sir.
Yeah, we'll come back to you later.
Sure.
In the later part.
Okay.
Okay. So shift to room number 1.
We'll be almost
4,
completing, sir.
Where Dr. Sunmoon will show us the technique of polypectomy.
See me?
Yeah, you're on, Sunmoon.
Okay, so this is the polyp.
What you are injecting, adrenaline or saline or something else, you should say.
So this is the polyp. First is when you see the polyp, you have to describe where is it located. So it's at the posterior wall in the proximal part of the stomach. So just after the G junction, I could see it. And the size is around, I would say, 10 millimeter. And after that, it's kind of on a fold. And once I apply the NBI, and then always take a picture just with NPI, a little bit far, and take the picture, freeze, and take the picture if you like it, and then unfreeze and put the dual focus on just to see the microsurface pattern here. And you have to also control your scope with patient's breathing. Here it is. So this pattern, it's pretty much appearing as a fundy gland polyp. It's kind of a little enlarged crypt.
Is it fundy gland or hyperplastic polyp?
I think it's more kind of fundy gland
Why?
because with the white light, this is NBI, but with the white light,
it's the kind of same color. Generally, hypoplastic, it's more reddish, and they're more kind of inflamed appearing, but it's the same color, and you see very little blood vessels in it. They're little like lacy blood vessels. So I would expect this as a funny gland polyp. So for polypectomy, this is the unfos. So it's a good position. My scope is straight, so I can do the polypectomy this way, or I can also do retroflexion here. And as you can see, it's behind my scope, so it's yes.
You are getting my voice?
Yes. Yes, sir.
We are shifting for a minute to the other room to show a polyp on the AI.
Okay.
Right?
Okay.
I'll come back to you in a minute.
Sure.
Right?
Sure. Okay.
Okay, over to room number 4. Dr. Anil. Yeah. Yeah.
We see
Anil,
on
you're on.
AI.
Right, sir.
There are 2 to 3 sessile polyps and a big large polyp also. Just a second, sir, it will be demonstrated. We have already done it on the picture on the right-hand side of the screen. You can see the polyp already there. That you have to go in.
Yeah. Just trying to, there's a polyp behind the fold, I guess.
Yeah. Here it is.
The small polyp here.
So there was a signal about a polyp, behind the fold. Now this is being demonstrated, yeah. Behind this fold, yes.
That's difficult. These are polyps which are difficult to show. And we have to try to get it end on. Are we getting any signal for this? Although, now we got a detection box, but because we are not really end on to it, so we have to be end on for characterization. So
here it is.
So this is one of the limitation actually. Yeah. I don't. Well, let me see.
Yeah.
That's why. Yeah. It's okay. I think try to get end on. Okay, let me try with this. Then we do this fairly end on.
Just here it is.
So go to
Here
BLI.
it is. Yeah. And you can see the box on the right-hand side, which gives the green signal.
There is a green visual assist box, circle, and there is a 3-step confirmation in the white, 3 white lines. And there are 2 in the map there. You can see the green polyp indicators showing, and there's actually written below that is a hyperplastic polyp.
On a BLI, it is correct.
And characterized on BLI. So we find, at the same time, we can actually now we can use our own training, and here it is. So what do you think? Is it hyperplastic?
This is a zoom image. There is not much of a...
Thank you, Anil, for a nice demonstration of the polyp on AI. Thank you.
Thank you.
Now we are shifting to room number 4.
Yeah, it's performance.
Okay. Room number 4.
All right. Welcome back.
Yeah. You're wrong.
Okay, so this is the polyp unfos, but I just want to make sure how this polyp also appearing retroflex. So if this is the retroflex view, it's behind the scope, but you can also rotate your hand here, and I can see that I can approach the distal the distal margin of the polyp better with retroflex, and I would prefer this position for injection because in unfos, if I inject here, then with unfos it will come towards me, the polyp. So, and I would prefer that. Okay, so needle out. Okay, so when I inject, so make sure it just little out from your scope, not too much, otherwise you will lose the control. And when you put the injection needle, just little stab, okay? Then inject 1 cc, 1 cc, okay? How much? 2?
2.
Stop, okay. Needle back, Okay, I think that should be enough injection here. And then I come back to my unfos. And as you see that it's kind of nicely lifted and it's almost like towards me. So I can take the snare.
So
at this
you want
time.
to bring the polyp towards you always.
Yeah, that would prefer. Otherwise, sometimes this is not a very big polyp, but if it's a large polyp and it's going away from you, then that's something can cause partial resection. So I generally don't put adrenaline. I just inject normal saline because it's cheap, it's easily available, but you can put a little bit of dye in it. I generally never put adrenaline. Okay, so this is upper scope. So all my devices coming at 7 o'clock. So I would prefer the polyp or any lesion at 7 o'clock. So this is a very good position. Open the snare. Okay, when you put the snare, just make sure it's around the polyp nicely. And I would see that, okay, it's good margin here. Okay, close slow. Close, close, close. Okay, nice. Close. Okay, tight, snug. Okay, so it's tight. I would just lift the polyp a little bit away from the muscle. And I generally do.
Setting is okay.
What's the setting here? Okay, so either you can do endocut or you can do forced coag. So I'm doing forced coag here because it's a stomach. So you just have to do a controlled nice closer. Okay, so 1, 2, 3.
1, 2, 3.
Okay, good. All right, so it's all out. And now
You want to clip this area or you don't want to clip this area?
In the stomach, I generally prefer clipping because stomach is vascular. And here, after removing the polyp, I always look at the margin just to make sure there is no residual here, which I don't think so. So it's an unblocked resection. Unblock is very important to have a complete histopathological diagnosis.
Easy clip.
So now I would clip, there is no bleeding or anything here, so we're good. So I will just take one clip here. I think one should be enough.
Strap laga do, suction kar lenge.
Hello.
Yes.
Yeah, very nice demonstration of doing the polypectomy.
Thank you.
Thank you so much. And now we are shifting to room number 1.
Okay, sir. Thank
you. They have picked up polyp with some displays here on the end.
Flip out.
So shifting to room 1. Yes, Anil, you are on.
Rotate the
Can hear
clip
us
a little bit.
as well. So this is a demonstration of a polyp, which is neoplastic, and you get all the signs. You get the position map, shows you that this is the polyp being scanned. This is the right lower corner, and it's yellow, meaning yellow visual circle, and the 3-step pattern is complete, and it's written below is neoplastic. So it is characterized too. So this is an example of neoplastic. The earlier we showed was hyperplastic.
Now it even gives you the area where the polyp is, whether it's on the upper hand corner, the left hand corner, the right hand corner.
So,
and on BLI also it can be seen very clearly. Sir, BLI dikha dijiye.
Okay. And this is, yes, sir.
We have just called this specialist Surmoon to kind
Yeah.
of show the polyp. So she will let us know
Yeah.
whether something needs to be done for this polyp.
Okay. So I'll stop the cat. I will just do IE. And she showed us wonderful pictures yesterday.
Wonderful demonstration.
And
this is the one, Sir, zoom out from
so I just keep on light. Yeah. So normal. Okay.
Put it on the LCI now.
I think
sir.
even in this you can describe it like color normal to the similar to the surface. It's not very brown. It's not very brown. You can.
You generally look the brown color
Yeah.
in NBI. What is this? This is white light or?
This is
black?
white light. This is white light.
So what?
Yes, sir. इसमें सर ये LCI है, फाइस नहीं इसमें, ये और ये फाइस नहीं है इसमें, फाइस बंद कर दिया ना.
Okay, so this is good. So now you see brown.
Now you see the brown, and you
You can freeze it. Yes.
you can freeze it and you can see the brown color, and the brown is from the vessels. It's not from the inflammation. So because inflammation also look red in the white light and brown in the NBI. So make sure the brown color is from vessels. So you can see some nice brownish vessels, and the pits are pretty tubular.
Yeah.
And also some variable size
Yeah,
here.
yeah.
And the vessels. So it's, my thing is, this is probably high confidence tubular adenoma.
2A, 2A, I mean,
This will be somewhere around between 2A and B.
This is Janet, I would say 2A.
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 And you can see some interlacing pattern changes. At the same time, there are tips in between.
That's called valley sign.
Yeah.
And that's something very specific for tubular adenomas, but not sensitive. The sensitivity is around only 40–50%.
It characterizes to be a little bit, towards the neoplastic side as per the AI is concerned.
So I would do cold snare. Yeah.
You'll
Can you change just the volume of the endoscope is speaking from behind? Because we are not really.
In fact, we are just asking Dr. Sunmoon about whether we really need to go do a biopsy beforehand, or we should go ahead and do a direct snaring of the polyp.
So it's a 2A polyp, so cold snaring.
Yes. So this is definitely a small polyp, around maybe 8 mm. So I would never biopsy a small polyp, never. So always do snaring. It's easy. It gives a complete histopathological diagnosis. So biopsy would never. Biopsy causes, first of all, it causes incomplete resection, and it makes the next resection very difficult. So always cold snare or resect the polyp as much as possible.
Thank you, Anil and company. Thank you for the nice demonstration.
Thank you, sir.
Thank you, sir. Thank
Differentiating
you.
benign versus malignant polyp.
Yeah.
Thank you. Now we are shifting to room number 2, where there is a case of
If you are not at the right and correct angle,
carcinoma
then
esophagus,
so you have to be.
and we are going to demonstrate histology to be taken by crush method, followed by boogie dilatation by a different method, ultimately SEMS. It will be done by Dr. Anupam, and we are going to present the case.
This is a case of a 53-year-old male. He presented to us with a history of progressive dysphagia since last 1 month. The upper GI endoscopy showed a lumen occluding ulcero-proliferative growth starting from 38 centimeter and going up to GE junction. The CT thorax was done, which was suggestive of circumference wall
So,
thickening
sir, we will
involving
be
the
using
lower
9 or 10.
esophagus. The plan is for crust cytology, followed by boogie dilatation and followed by esophageal SEMS.
Yes.
This is the endoscopic view of the ulcero-proliferative growth. We were not able to cross the growth.
So,
And this is a CT imaging showing a circumferential thickening involving the lower esophagus reaching up to GE junction. So now we'll proceed with the case.
Yeah, over to you, Anupam. Yeah, Anupam, you're on.
Okay. So, good morning, everyone. So, as the case has already been shown to you, the clinical details. So, what we are doing, so initially we will assess the site, as well as we will take the crush biopsy for the crush tissue examination, so that we can prove. So, this is the first thing we will do, and then subsequently, what we will be doing, we will be slightly dilating, because that growth is a lumen occluding growth. We are not able to negotiate across that growth. So before placing stent, we will dilate. So, but we will not dilate with the routine dilator, we will use a different over-the-scope Boji dilator. So that is our plan. So as you can see, we are right now at the lower end of esophagus, and you can see there is a growth which we can see at approximately, as I can see, it's roughly at around 35 centimeter. So this is the growth which you can see, and the patient is currently having dysphagia of grade 3 or 4. So our plan is right now to take biopsy from this to prove that this is malignancy. So the biopsy will be sent to Dr. Anuj, who is our pathologist. So he will be examining those biopsies. So can we have the biopsies from those this biopsy forceps? Yes, sir. Regarding the differential, so can I have the higher volume? I cannot. Differential. So obviously, sir, on just based on examination, my differential will always be for this patient malignancy. This is actually a proven case of malignancy. We are just demonstrating how we can fasten our diagnosis method by crush cytology. But looking at this thing, actually, I don't think anyone will think of any other possibility in this scenario. If this so tuberculosis, yeah, that can be looking at the overall scenario. If we'll see that can be capped, looking at a patient who is having significant weight loss, fever, and other possibilities, then obviously you can keep that possibility. But just based on appearance, we cannot say that whether it is going to be malignant or non-malignant, but most likely, yeah, yes, sir, absolutely. So can we have? Open, bite. So it is always better to take single pieces rather than multiple, though there are multiple or multi-bite biopsy forceps which are available. We can always use those. So here is Dr. Anuj, who will be examining these crush cytologies. Open. Open. Bite. So do we have that contrast? Contrast. Therapy needles. I think we need to have audio for the pathologist. Audio, sir. What was the question?
We're not getting any audio from the pathology.
Audio is not audible actually. Could someone check the audio for the pathologist? So regarding the dilatation part, sir, as you asked, so routinely we don't dilate, but you must know if you are using the standard uh, stent. So the sheath diameter is actually roughly around 6 to 7 mm. So you need to have a diameter of at least 7. So if you are able to pass your thin scope, it is fair enough to just directly put the stent sheath and you can directly put the stent. Otherwise, in rare scenarios, you may need dilatation, but the dilatation is sufficient up to 7 to 8 mm. That is okay. This much amount of diameter is sufficient to place the stent. So routinely we don't dilate, but yeah, in rare scenarios, we need to dilate the stricture.
We need the audio and the video from the pathology. They're not getting either of them. We are only seeing the endoscopic video. Audio video, दोनों भी जा रहा है. Can we have the room video and the audio from the pathology?
There seems to be some issues with the audio video. They are fixing about that.
Am I audible now? Hello, am I audible now? Oh, okay, okay.
Okay, you can.
So, we are talking about the crush cytology, which we are doing here in suspected malignancies. So, the way to take the crush cytology is that the moment the tissue is removed, it is put on the slide, slightly scraped with the corner of another slide, and then it is pushed from one end of the slide to the other, so that we get a spread of the cells on the slide. And these slides are air fixed and they are wet fixed in alcohol. And then we use a very rapid HE method, hematoxylin eosine method, which is taking us around 3 minutes. And within a matter of 5 to 7 minutes, we are able to tell the endoscopist that the lesion which he is dealing with is malignant. And usually we prefer to take imprints where the suspicion is of a lymphoproliferative disorder, because the lymphoid lesions are less cohesive to each other. So the moment you will touch the tissue on the glass slide, we will get an imprint of those lymphocytes. But if you are suspecting a squamous cell carcinoma, then just taking the imprint will not be enough. We will have to crush the tissue slightly, because these squamous cells have intracytoplasmic desmosomes which are connecting the cells to each other. So these are not so friable as the lymphoproliferative disorders. So the imprints are more valuable when you are dealing with lymphoproliferative or suspecting a lymphoma. But if you are suspecting a squamous cell, then along with the imprint, it is the crushing of the tissue which is going to give us the report. And we are using a very rapid HE method, which is a 3-minute stain, and another 2 to 3 minutes to screen the slide. And by 5 to 7 minutes, we are able to tell the endoscopist what the lesion is precisely. Is it benign or is it malignant? And by now we have around more than 1,000 cases where we have the data. And we have developed a checklist of how to define whether these cells are malignant or benign. So we have about 15 points, which we quickly go through to decide this is a malignant lesion or a benign lesion. So we'll just get you back to the report in about 2 to 3 minutes.
Thank you, ma'am.
So by the time our pathologist will be looking after the tissue, so the next step is we have already identified the proximal margin of the lesion. So now the next step before going for a stanting is to just identify where you want to place your proximal end of the stand. So there are multiple ways people have described. People have placed those stands only under the fluoroscopy or under the combined vision of fluoroscopy and endoscopy. So one method which we use, either we place marker on the body of the patient externally that can easily be removed. The another way is to place contrast in the submucosal tissue. So from approximately 2 to 3 centimeter before the lesion, so at this end, you can just place some amount of submucosal tissue, which can, submucosal contrast, which can very well be seen on the radiology. So what is the benefit of that contrast? It actually moves with the body movements also, which is not true for particularly when you are using the external. When the patient is shifting from one position to another position, those external markers may not be truly valid. So that is one thing, but that's not most of the times fail. I mean to say most of the times these external markers also does well. So right now, what technique we are
apply certain clips also.
yeah, definitely, sir. You can apply those clips also. So any kind of external marker which is visible radiologically, you can do. So in this, what we will be doing, we will be injecting some amount of radiopac contra. So just put out the needle, pick out the needle. Okay. So just inject some amount of contra. Okay, but fine. So we have to confirm on radiology whether the contrast is in the submucosal tissue or not. So can we have the fluoro? So obviously there is no visible blab we can see. So I'm not confident right now whether we have injected at the right place or not. So we will just see, confirm under the fluoroscopy. So obviously it doesn't look like it is at the right plane. So just take out the needle.
Solves the purpose.
Yeah, it solves the purpose. Just inject. So this you can see we are injecting, there is a blab and fine, that's enough. So this amount only small, just 1 to 2 ml is sufficient to just mark. So this is our proximal marker where we will be placing the proximal end, and then distal we have to see on endoscopy.
Dual knife
Further. So the next step, what we'll be doing, we will be dilating this growth or narrowing the newly launched dilator over the scope dilators. Can we have those scope?
So how much do you propose to dilate?
Sir, actually the sheath which we typically have is roughly around 7 to 8 mm. So 7 in most of the scenarios, because these are friable
Gloves,
7
बड़ा
mm
है
is
कुछ
okay.
large
So
size
most of the
रहता
times
मेरे
we are
को।
able to pass
छोटा मेरे को बहुत
our
pain
ultra
करेगा।
thin scope. We typically don't
8
need any
नंबर
kind
है
of
तो 8 दे
dilatation.
दो।
But
8 है?
the stricture is very
8
tight, like
हो तो मंगवा लो
anesthesia.
एक बार
And in those
चेक कर लो
scenarios,
ना।
you may need to dilate.
बंद करो, माइक बंद करो। Somebody check audio. माइक बंद कर दो। Dilatation, we are using this overdose for bougie.
So can we have that sample? Yes. Can we just focus on this? So before going for bougie dilatation, I'll show the bougie. So these are the new bougies. These are mounted over the scope. You can see. So what actually these are? So these are the newly modified form. The earlier, these are from the Ovesco. Okay. So these are from the Ovesco company from the Germany. So what these are kind of dumbbell shaped. So these are having two different diameters for dilatation. So it comes in the size of 7, 8, 8, 9, uh, 9, 10, then 11, 12, then 13, 14, 15, 16, 17, 18. So these are kind in sets of two diameter these come. So you can see there is some amount of dumbbell and there are three markings over these dilator or bougie. So what are these markings? The first marking is for the first diameter or the dilating diameter. The second marker is the depression. It means it is slightly dumbbell shaped. So the dumbbell is actually the second marker. And the third marker is the second dilator. So the first marker, the most distal marker, and the most proximal marker, these are the two dilating segments. And in between is the relieved, or you can say the slightly lower amount of diameter. So it is visible on the endoscope also, you can see. And there are three pores. So those pores are to facilitate the water, basically, or air, or if you want to place a guide wire. So that is the beauty of this bougie. You can also place a guide wire while you are performing the procedure, or when you want to place a guide wire. So particularly if you are using a thin scope where you want stiffness, you can always use a guide wire through the channel. But what is important, you can only use guide wires 0.025 or 0.035, but not the standard steel guide wire or metallic guide wire with a coiled spring tip. Those you cannot place. So now we will be doing the dilatation and
We'll break for a minute. The pathologist is ready with the slide.
Yeah. Oh, okay.
Can we move to the pathologist, please? Yeah.
Are we not getting the audio? Not yet.
Coming. Okay. Can we proceed, or they are showing pathology? Okay, they are with the pathology.
Just increase the volume.
Hello, hello. Audible now? Volume बढ़ा दो. Okay. So here we have changed the slide after we prepared the crush smear. And this is for the purpose of demonstration here. So what the focusing on my screen here, this is a cluster of malignant cells. And these are the squamous malignant cells. So the criteria, the 5 criteria of malignant cell is, number 1 is the variation in their size. So you can see the variation in the size of these cells. This is one cell. This is the nucleus. One cell. Look at the different shape of the nuclei here. They are all different shapes. They are hyperchromatic. Some are elongated, some round.
Can we zoom in on the pathology slide?
Yeah. So I will start again. So this is a cluster of the malignant cells which we have focused from the slide, from this crush smear which we just prepared. And this is a whole cluster. So look at the irregular outline of this cluster of cells. There is so much pleomorphism in these cells. The cell shapes are different. There is abundant cytoplasm, which is a criteria in squamous cells. Their nuclei are so different in shape, which is called nuclear pleomorphism. They are hyperchromatic. You can see the dark color around them. Their chromatin is irregular. You can see the clumping of chromatin at different places. And the spindling of some of these cells, which is indicating the squamous cluster. And on one of the cells here, we are also able to see a mitotic figure. Now the background, if I try to show you, the background of this is showing necrotic material, and it is also showing a lot of nuclear debris around. So this is another cluster of these cells. Again, you can see somewhere you can make out the squamous sheet, the syncytial appearance. You can make out the hyperchromatism, the pleomorphism. Here is a mitotic activity. And therefore, immediately we give the endoscopist the report that this lesion is likely a malignant lesion. Not likely, this is definitely a malignant lesion, so that they can proceed with the radiological correlation, and the patient's stay in the hospital gets reduced, and the further treatment plans can be made immediately there and then. Also, it helps the endoscopist to decide whether adequate tissue has been taken. Thank you. And the whole process took 5 minutes.
Yeah, hi. I mean, this is Dr. Komal, my wife, and the force behind me. So I purposefully came in to show that these are the procedures which we have been doing for last 2.5 decades, and she's been a great help to me. So I would like this hall to give 3 cheers to her, because she's one person because of whom we are here. Thank you so much. So over to Pankaj for the next OT.
We can continue with the dilatation. Over to room number 2. Yeah, Dr. Anupam, you're live.
Sorry?
Yeah.
Okay.
You're live.
Okay, sir. So you can see there are multiple markers which you can see. So there are 3 markers. You can see one is at the proximal end, then one is the middle, and the distal one is faintly visible. So the distal one is the dilating diameter, first dilating diameter, and the proximal one is the second dilating diameter. So these are the two, and you can see through the scope, actually, you can see the amount. You can see that now I am feeling the resistance and there is a growth. So obviously, whenever we are dilating, you can see I can slightly with a rotatory motion, I'm trying to enter. But since this is a ultra thin or slim scope, it is difficult sometimes to keep the or transmit the pressure. So in those scenario, what you can do, you can always use the over the guide wire. So there is a port and through which you can always place the guide wire distal to the lesion, and then you can dilate over the guide wire to provide some amount of stiffness.
I think we are in the structure. You're not yet crossed it.
Yes. Yes, I agree, sir, that in the malignancy, typically you should not use these kind of dilator. It is better to use for the short strictures where you know the anatomy. Those are the perfect candidate for putting those kind of these kind of.
So you can use the dye for any help, right?
Yes. So just let me. Stand. Sorry, sir. Stand. If they are planning to do the surgery, and then obviously you have to pull the gastric pull-up you have to perform then sometimes. So that's why people usually avoid. So I'll just try to negotiate. It's obviously difficult. So what we can do, we'll just No, sir. I don't think it is going easily.
Where is coiling up?
Yes, sir. Oh, it's coiling in the esophagus itself, sir.
Anupam, we are now shifting to room number 4.
Oh, okay, sir.
Where Dr. Pankaj Desai is live, and he is going to show us an EFTR, and I would request versus ESD. Yeah.
So this is a case of a 44-year female patient. She is having symptoms of abdominal fullness and bloating since past 6 months. Apogee endoscopy was done, which was suggestive of a small subepithelial lesion with surface ulceration in the proximal gastric body. And there was another subepithelial lesion, which was 20 to 20 mm in the distal gastric body.
SG will be better. Yeah, balloon se zyada. So we will use the standard.
EOS was also done, which showed a hypoechoic submucosal lesion with an intact muscularis propria. So it was a probably NET. The plan is to go for ESD versus submucosal tunneling endoscopic resection. Change the slide. So this is the endoscopic image which we have demonstrated, and next is a endoscopic ultrasound image showing the lesion. Now we'll proceed towards the case.
With you?
Pankaj. Yeah, hi Pankaj, Ramon.
Hi, Lalit.
Good morning. Yes.
Is that you? Yeah. Okay. Good morning and thank you, Dr. Mukesh, Pankaj, Shrimal, and the entire team here for this kind invitation and the honor. And you can see, you have heard the history, you have seen the lesion. This doesn't appear too small. This is quite a big lesion, and the location is almost at the incisura here. You can see it's on the posterior wall. And what we have planning, because we just saw this is not mobile. This is fixed to the gastric wall. So probably this is going to be a full thickness resection.
Very much looks like a gist here.
So I have Amol here, who is there to help me with Dr. Nirmal Singh Mali, who is also going to guide me, because this is not going to be easy. I know. And Mukesh has found out a good case to spend. So let's see. What we have done is, as such, for this lesion, you don't need to mark, but sometimes what happens is when you inject, the lesion may get lost. So we have just marked with a soft coagulation here. And the plan which we have made is probably we'll inject all around and put an incision first on the gravity side, that is this side. Because once we start dissecting from here, the tumor will fall down, and then it will be very difficult for us to go below. So the plan is put the incision below, and then we'll start dissecting from the top. Right, Amol? Any suggestions?
I don't know whether you are able to hear us.
Yeah.
Why not EFTR?
No, this is a EFTR, but this is going to be a freehand EFTR. This is going to be a free. You can't use a inject. Not lifting.
Diameter of the gastric lesion, which is amenable to EFTR.
Madam, by guidelines, usually 3 to 3.5 centimeters is what has been recommended. But even up to 5 centimeters or larger have been resected. There is data to support that. We also have some experience of removing larger lesions. So it depends basically. Now, what I would like to point out, that how Pankaj has marked very close to the lesion. Now, these tumors do not require a very wide margin. And the other thing, what is important to notice is, once Pankaj is injecting, you can see that the marks are moving away from the margin of the lesion. So the incision actually could be even inside the markings,
absolutely,
rather than outside, which is the conventional teaching that we have to put the incision outside the markings. Because it is important to reduce the bulk of the lesion. Because even a 3 centimeter lesion, if you take too much of mucosa and submucosa, what is going to happen is that the bulk will become larger, and then delivering these lesions out of the G junction will become a problem subsequently. So that is how you have to plan the procedure in a better way. You should limit the amount of mucosa that you are going to this thing. Now this is on the posterior wall, so performing a stir kind of a procedure here would be difficult because gaining access into a tunnel will be difficult. But if this was in the lesser curve or a little bit more proximal, then maybe stir would have been an option here.
Right.
Perfectly right.
Yeah, so
Lesion seems to have injured it quite well.
So we are hopeful, but what I felt was that it has elevated more on the sides rather than in the center. But we have to dissect. So what I am doing is I am starting from below here. And these can bleed because these are
Yeah, they are quite vascular.
very vascular.
Yeah.
So we have this plane here in glass, please.
For any form of FTRD, this is going to be a much bigger lesion because this appears to be, I believe, 3 centimeter plus. What about gastric, Dr. Mole? Gastric FTRD?
So, Dr. Mali, this is not, meaning, let us make this differentiation between EFTR and FTRD. Yesterday in my talk also I mentioned this, that FTRD is a device. It's a device-assisted full thickness resection. The procedure actually is EFTR, endoscopic full thickness resection. And FTRD device in this kind of a situation will not be useful because the lesion is quite hard and it is quite large. So the largest amount of lesion that we can do on the gastric aspect would be about 1 to 1.5 centimeters, not
sure,
more
you
than that.
can go and come back. This is going to take time. So
we are shifting for just 2 minutes in room number 2.
CO2.
Where Dr. Anupam is ready with the placement of them.
They'll come back over here.
We'll come back in about 2 minutes.
To just show. Okay, so this is perfect. Okay, so
we can see tattoo also there.
yes, are we online?
So are we audible?
Yeah, you are audible.
Yeah. Okay,
So we are ready for deployment.
Dr. Anupam, you are live.
Okay. So we are now ready for the deployment. We have negotiated that thing and we have placed negotiated the structure, and then we have placed a guide wire across the structure into the stomach. So this is the third or another technique which we will be showing, that is a combined fluoroscopy and a under the vision or under the scope vision, endoscopic scope vision deployment. So what you can see under the fluoroscopy, you will see that. So
Can we have fluoro?
Okay,
Fluoro on
so
the screen.
our endoscopic marker or endoscopy, the distal tip is there at the marking where which is what we got using a contrast. So you can see the both markings are at the proximal end, and then the stent distal tip is also at the same place. So we are using both the endoscopic marker as well as the radiology. So you can see the endoscopic vision air.
Vision.
Can we have the air?
Please switch to endoscopy, yeah.
So you can also see that the distal tip is visualized or the metal stent is visualized. And now we will start deploying the stent. So the growth was roughly around 4 centimeter as measured on the endoscope. So we have used, I think we are using the 10 centimeter one. Okay, so we are using a 10 centimeter stent for this. So this is the this is a distal release stent. So what we are doing, we are now started deploying the stent.
Fluoro.
So we can always use fluoro to confirm the position.
Fluoro दिखाइए.
So you can see the distal end has now opened. And now we will just move towards the proximal end. Just slightly more above. So now you can see our distal end has, proximal end has also deployed. And if you'll see, it is exactly correlating with the dye which we injected. And there is also a narrowing which you can see at the site of growth. So obviously we are having sufficient above margin. So roughly there are approximately 3 centimeter of margin above the growth, and then you can see that there is sufficient margin or residual stent at the distal part of the growth, beyond the distal part of the growth. So now we have completed our deployment, and now we will pull back the.
Great. That. Thank you, Dr. Anupam. Now we shift back to Dr. Pankaj.
Thank you, sir.
Okay. Thank you for an excellent demonstration.
So there is a narrowing actually. How? There is a narrowing actually, sir. Usually,
Pankaj is trying to coagulate.
Open.
Here on Pankaj.
Catch.
Yeah. So this is important because these GISTs are pretty vascular and they have feeder vessels coming from the submucosa and also from the deep. So sometimes you can have brisk bleeding in the stomach, but one has to be patient and coagulate and use the coagrasper efficiently. You can see that the bleeding has stopped. Hi, Saurabh.
So a quick question. We are planning endoscopic full thickness resection.
Yeah.
Not doing ESC.
No.
Is there any utility of the submucosal injection, or why not just freehand cut through the muscle?
Well, Saurabh, the thing is, very often the muscle attachment is much narrower as compared to the head of the lesion. And in order to reach to the muscle attachment, some amount of submucosal injection is useful and it is desirable, because then you can get a mucosal flap on all sides and get to the center of the lesion and then divide the muscle as less as possible. That is the reason we would do this thing. The other thing is, if you do, you try and cut without injection at all, then these submucosal bleeds are going to be really challenging to identify and control. So for that reason also, if you have an injection, then that is useful. So we usually will tend to inject, will create a mucosal flap, because that is what was going to be useful for us for the closure also.
Yeah, so I think we have reasonably controlled it is going very vascular, yeah. We'll see now what we can do now.
Fortunately, it is in a location where the blood is not pooling there. So
That's right, that's right.
that is a good thing about it, because otherwise you can't see anything.
Inject. Yeah.
Other thing is, Pankaj, would you want to use an IT knife here now?
We'll see, I think we'll just read the capsule
Right.
and then we will decide. There's a little bit of mucosal left here, so I'll just try to complete the inject, please. Needle.
The other thing that you can notice is, because of the location of the lesion, Pankaj is unable to go close to the lesion. Whenever we are using a needle type knife, it is important that we have to dissect from as close as possible.
That's right.
And if you are away from a distance, then control of the instrument becomes more difficult. And in that situation, sometimes an IT knife is going to be more useful. So I agree with Pankaj that once we have the mucosal incision and reach the capsule from one side, then we'll probably have to shift to an IT knife too. But here you can see, Saurabh, that there is quite a bit of submucosa which is free over here. So if we were to cut vertically at this point, then we would dissect and divide too much of muscle, unnecessary. And that is the beauty of doing an EFTR enucleation kind of a thing, because it becomes much less organ mutilating as compared to wedge resection or a stapled wedge resection that the laparoscopic surgeons do. So the organ deformity is much more reduced. And that is the true advantage of an EFTR in this kind of a situation?
I'm getting a little plane here, so I think we can just keep on
Continue,
using that plane to go up.
Maybe a little bit of ooze that you
Yeah.
might want to control there.
Back, Neil. Little back. Inject, please. Right. Okay. So what I am doing is, as you can see, I had a little ooze there. So what we did was retracted the needle back, and then I used coagulation just current. So we are, again, there is a little bit, I think there is a big vessel. We'll use a coag grasper. Take a coag grasper, please. You can see this is a big vessel here. Take it out. So we'll pre-coagulate with a coag grasper rather than getting a massive bleed and then doing it. I think we are getting a reasonable plane below the tumor. So hopefully, he has the
Muscle
defect in the center.
It's a simple clip. Standard even TTS clip.
That's right. Lalit, as Lalit was saying, we got a good lift. No, keep it. Barabar side one. Rotate to the left, please. Left. Catch. Stop. Open. Yes.
Now that you've got a very good thing of resection and from the lower
Catch.
end.
Yeah. Yes. Open. I think we'll follow this plane as far as we can get beneath the lesion, and then we will see. Yeah, and catch, please. Open. Catch. Stop. Yeah.
Large tumor beta vessels. Does it mean that the bulk of the tumor may be above the plane?
Not necessarily always, but yes, majority of the times the tumor would be around. Open. Back. Okay. Wait, there is another one here.
Sukrit, so these are submucosal vessels which are feeding the tumor. But for MP layer lesions, there is usually also a feeding vessel from the serosal aspect, or maybe some more feeding vessels from the serosal aspect, in addition to these submucosal vessels. So that is something that one needs to be watching out for, because when you do the myotomy or get into the muscle, those are the vessels which can sometimes bleed, get divided and retract on the serosal aspect, and that can become challenging sometimes.
Okay. Really? Oh, see that even after coagulating, it has started spurting, no problem. Gasper fast is a very big vessel.
So, really very vascular lesion.
Stomach itself is a very vascular
Open.
organ, and these vessels
Yes.
also have, these tumors have plenty of blood supply.
Right.
Open. Catch.
So, Dr. Amol, any way by which one can reduce these number of feeding vessels? So, for example, dissecting a little in a superficial plane, maybe SM2?
No.
No. In fact, the more superficial you dissect, you will find more vessels. You will encounter more vessels. And these vessels have to be divided at some point in time. Right. The main thing is, when we dissect, Pankaj did manage to identify some of the vessels very pre-coagulated, but sometimes even after pre-coagulation, what happens is you may not get the complete vessel sealed off, and then you can have a bleed like this. And sometimes, the knife swing just takes the knife into the vessel, and you might get a little bit of this thing, because he has to work from a distance. The longer the distance from the lesion and the longer your knife is outside, the swing of the knife tip is more, and then the control is less. The closer you are, the knife control is better. Use grasper only.
Grasper. थोड़ा inject करने का तो मुझे. Give me a. Let me just inject and keep the coax grasper ready. That's the capsule probably, I think.
No, that is the muscle down there. Capsule will be on top.
We'll just inject here and then we'll lift it. Let's see. Inject, please. Yeah, I'm getting a lift. Let me just dissect on this side where there are no vessels. Needle, please. See, there are again big vessels here.
Yeah, there are going to be a leash of vessels on all sides.
Among the NETs also, do you get this kind of vascularity?
Yes, NETs are
NETs,
more
but-
vascular
yeah,
probably,
but
and this would be an
vascularity is a little bit different, because NETs are predominantly in the mucosa and submucosa, and there is adhesion to the muscle. Here the lesion is arising from the muscle, so that is the main difference. So you will get vascularity, but the vessels usually tend to be a little bit smaller, unless there is muscle invasion from the NET.
Inject.
Then you can have very large vessels sometimes.
Inject.
Once I remember, we had a NET, gastric
Grasper.
NET that we were resecting, and we had a spurt like we had just now. It was in the fundus or the proximal body, and it took us almost 45 minutes to control the bleed. You know, because there was so much of pooling that is happening that it just becomes impossible to identify. Then you just have to be patient. Talk to your anesthetist and get the pressure down so that you will see the bleeding spot, and then you try and do that. So you have to do multiple maneuvers and try and do that.
Okay. Injection again. This is a game of patience, perseverance. Just keep on finding the correct planes. That is very important. Yeah, it will depend. See, probably in the center, see, again, there is another vessel.
Pankaj, I think patience, perseverance, and expertise.
That
So,
is-
so,
that-
so all three.
Expertise will come after patience and perseverance. See, there are so many big vessels. We are coagulating one, another one is creeping down from below. And these are huge vessels. So we will try to see, we try to stay as away from the muscle. Rotate, please. Slowly. Rotate,
Patience,
rotate,
perseverance, and precision.
But, yeah. Catch. And I'm trying to hold it above the muscle tangentially because I don't want to injure the muscle. Then again, we will see.
A little bit of muscle which is getting stretched over there, I think.
So, we will,
And
so very likely we will have a small defect, probably.
small defect over there.
This is lifting up. So I think we.
Pankaj, at this point, would you like to use fraction?
For tumors, I think gravity is helping me.
Here,
quite a bit.
gravity is helping, but
Mucosal,
otherwise,
yeah, we would definitely think of traction at some point if we are not getting to go below this plane here. Yeah, but
even for fundic, lesions like this, sometimes what we do is we apply a clip on the mucosal aspect.
Right. These are heavy. So what happens
Yeah.
is traction might not be
The clip
effective.
slips
The
off.
clip
If you
will keep on slipping.
you can't put a clip on the tumor itself, but you put it on the mucosal flap.
Absolutely. You see the vascularity.
But you can
Inject.
go below that.
Yeah, I'm just trying to. find out the planes, Nigla, please.
Pankaj, at what point do you want to go to the other side and start dissecting, or you want to continue in this plane only?
See, I am getting a good plane here. So I think as far as possible, I'll keep on doing it in this side. And then once I'm pretty sure that I cannot still push this beyond, probably we'll start from here like this at the margin.
Yeah. So at this point, Lalit, now this lesion is at such a location that it's not very easy to approach by retroflexion. So the primary direction of dissection is going to be in the forward direction, in this direction only. I think Pankaj will have to go laterally and try and get it. There may be a vessel there. Okay.
Yeah, that is a vessel. I'm just
Doesn't the lesion continue to kind of fall back and
inject.
Yeah, but he's made a mucosal incision all around.
See
So
what I'm doing?
that doesn't matter.
Anti-gravity. So I don't think that is a problem now. If the lesion is falling on me, it is a problem. Because then I will not be able to get below it. So I'm trying to do it from the anti-gravity side so that the lesion is going away from me, not falling on me. Yeah, there is a big vessel. I'm just clearing it from the side slowly.
Very large vessel.
Very big one. So parallel to the muscle, needle out. Needle. Inject. Okay, needle. And liberal injection. This is the case where probably the new Orbe flex knife would come in handy. Because here also this is good. We can do a dissection injection with the hand, but sometimes when this is too adherent, I'll take a grasper here.
Yeah.
I think that's a central feeder
That
vessel.
is a central feeder vessel, and probably that is where the attachment also may have
We'll
been
try
there.
to just clear it off from the muscle first.
So Pankaj, when we're using co-grasper, so do you always have to catch, or we can just with the closed itself, we can use the cautery and take care of the vessel itself?
I think it is better to catch it.
Because in Japan, many of the times they do just keep the closed one over it.
Yeah, but it will, yeah.
That is okay. But
Okay.
this size,
Right.
should catch and
Catch. Okay.
We're using a soft coag at around 50 for effect 4, 80 to 100 watts. That is what I'm using.
Right.
Open. Then again, we'll just come back, see how it has been cooked.
Very nicely.
Open. Yeah. Yeah, we'll have to catch.
looking at the size of the vessel, the pressure within the vessel is going to be quite
Very
different. So probably need to.
हो जाएगा. So what I did is I just cut it with an endo cut rather than using the knife. Now you can see it has been taken care of well, right?
Perfect.
And now come back and we are seeing, just we will try to see how much is left and we are getting it. Yeah. And the muscle is quite intact here. So
Right side, Pankaj, I think a little bit we have opened up the muscle over there. I shaved the muscle. I would say
yeah,
this
that
more
is
like
type
a
1. This is
ESC. This is not an EFTR. This is more like a
Intram-
endoscopic submucosal excavation, as we call it. So here you can see that the muscle has been shaved off at around
Right.
6 o'clock, 3 o'clock, that part. So the lesion is arising from the most superficial part
layer
of
of
the
the
circular muscle.
inject.
So it
Right.
is not going
Deep.
Deep into the muscle, yeah.
more of an endophytic kind of a lesion.
Okay.
It is lipoma.
No, no, it is not. It is very hard. It is not a lipoma for sure.
Yeah.
No, no, no. It is not a lipoma.
This is almost done. Pankaj.
Yeah, so let's hope.
Just that
Needle.
submucosal, with probably a few vessels may be remaining there.
We might end up doing an ESE. Yes. Endoscopic.
Yes, madam.
Decide on which time to.
Again, there is.
Well, most of us, madam, would prefer to use a needle type knife like a dual knife. I think most of us are quite familiar with the needle type knife. But if one cannot dissect from very close, then sometimes an insulated tip knife, IT2 knife is also useful. And that is what many here probably Pankaj and I were discussing that we may have to shift to an IT knife at some point. But so far, I think
And now
it's
we are
not
seeing
been
the whole
required.
tumor now. See, you
Yeah.
are seeing the
So
whole
the entire tumor has been lifted up now.
Yeah, yeah.
So now all that remains is the submucosal attachment over there. And there may be some vessels over there. So one has to be careful.
Very beautifully in a very short period of time.
I'm not trying to touch the capsule. Since now we have the entire lesion, so I'm going from one end to the other.
Left side, you just have to take the mucosa fully.
Yeah, we'll just see. We'll do it. Needle. Can we just clean this and give? Just clean it.
Yeah, clean the.
Just clean it and come back. Yeah. So we can just have a look from behind. It is not very easy to go behind. See, Lalit. So if I want to dissect from here, the entire lesion is giving, and now the lesion is because of the gravity,
It is
it
getting
is going
lifted
away
up.
from
Yeah,
me.
it
So
is getting lifted up.
I am very happy getting it out from here. So probably.
Yeah, what you may want to do, Pankaj, is at this point, divide this mucosa, take this mucosal incision.
We'll do that.
And then continue your submucosal dissection from right to left. I think that might be because otherwise you're going to undercut into the mucosa.
Yeah. Inject this. Let's see. We'll just inject and then needle. Inject. We'll see the incision is here. So we'll just needle out, please. Yeah. Now.
Now it
fine.
is. Now it is.
Again, the same thing here. We'll just needle out.
Part of the mucosa.
Yeah, so we'll just take the mucosa along initially. Yeah. Needle, inject, please.
So the mucosal incision, how much ever we try, very often it is not
Pankaj,
uniform.
we would be shifting to the hall for the oration by Dr. Ranveer Sood.
Okay.
So we'll be back after some time.
So
this
maybe
should be done in about 5-10 minutes
this
more.
will be finished in 5 minutes. If you want to wait,
Okay.
In 5 minutes, yeah.
We can
hopefully.
extend it for 5 minutes.
I think we are almost there. Needle out.
Gravity is playing a very,
Very important
very
role.
great helper.
Carry on, but Pankaj, we are waiting for you to give.
This is,
I
I think,
think-
where we can use a IT knife now. Inject.
So Sood sir also will be keen to see it getting finished off before the oration.
Needle.
So would be using now IT knife or?
We'll see.
Short of this thing to change the knife now. By the time he changes the knife, I think the lesion will be out.
क्या बात है क्या बात
Yeah.
I think masterly disposition of a which is a very difficult case but made to look so simple. I think credit goes to both Pankaj and Amol.
Yeah, I think it is always a teamwork in such cases. You have someone to talk, someone to guide you.
Yes.
Because these are not easy. You always, there are areas where we can get stuck. You need some other independently thinking mind who can just guide you. Because what happens is sometimes you get very preoccupied.
Yeah.
Yeah.
So we initially thought it might take 1.5 to 2 hours and getting finished in, I believe, in less than 30 minutes time. So this is great. So big round of applause.
Thank you. Thank you. Right now you can go. We'll just do some hemostasis and I think we'll see.
May not even require closure.
Yeah.
It's कमाल यार तो बहुत ही
Thank you. Thank you. Coagrasper. Coagrasper.
I think
2-3 clip लगाए दे.
Fairly remember the first endoscopy workshop held in North India. One of that was in Jaipur, and that was in 1990. But after 92, he had been regularly organizing at Gangaram Hospital, and he has been spreading the endoscopy, newer procedures, newer techniques, newer things to come. And he made all of us to learn all those things with his smile, with his affection. And I can say that he has been the beacon of light in the arena of endoscopy in India. I welcome Dr. Henry Sood to give us a inspiring talk to all of us, that how all of us can join together, keep our egos down, building a successful team and expanding our GI practices. Because in today's era, जैसे कहते हैं ना सबके सब मिलके साथ चलेंगे तो विकास सबका होगा. ये विकास की कहानी जो इन्होंने शुरू करी थी गंगाराम हॉस्पिटल में, और आज एक इतना बड़ा एम्पायर मैदानता में इन्होंने खड़ा किया है, ये आसान नहीं है. आज हम सब इनसे सीखेंगे कि हमें कैसे अपने दिलों को मिलाकर आगे बढ़ना चाहिए. Let us welcome Dr. Henry Sood. Give him a big applause.
Thank you, Dr. Rai. I think if somebody has to learn the art of inflating egos, then you have to learn it from Dr. Ramesh Rai, because he can make an ant into an elephant. So, but you know, what I'm going to talk today is how not to let your ego come in when you are trying to build a team. So, you know, part of it is learned knowledge. Part of it is I have learned over the years, because I had the privilege of working in a very congenial environment in Sir Gangaram Hospital with very accomplished colleagues who we came together, we built up a department. It was possibly the first department of gastroenterology outside, academic institution and apart from AIG at that time. So let me share my experiences with you and tell you certain things. Many of these things do not apply to each setup because I even see significant differences in how the mind of the team members works in different parts of the country and the different ethnic groups, different cultures. So one has to, modify according to the area one is working in. In our Hindu mythology, we always thought that Shakti comes from having multiple hands. And Durga's, image was not created. She did not have so many arms. It was that she was embodiment of Shakti. And it was that if you get together, if you have more hands to work with together, then you are stronger. So that is the concept of team. When you talk of a medical team, and particularly in GI, there are two ways the team gathers. One is we are, there are these very accomplished people sitting on a table. They start chatting over a couple of drinks, and after their senses are partly numbed, they say, "Okay, chalo yaar, इकट्ठे होते हैं, एक hospital बनाते हैं." So that is grouping. That you combine your efforts, you try to create a setup. But this is very frequent. It is what I call group practice. Is that it provides very good service to the patient. But let me tell you, because all of these are accomplished people, they all came together, and each one of them has their own aspirations and individual egos. The excellence in delivery of care is not the aim. So that is very rarely achieved, but you give moderately, you give good care to your patients. Another problem is that entire spectrum of the specialty is not covered. Why it's not covered? Because there are certain parts of the care which are not so remunerative. I would like to do my OPD. I would like to do upper GI, lower GI. I like to do procedures which are quick and remunerating, like but I'll not like to delve into things which will take much longer time. I'm not like Pankaj Desai who can do this large just in half an hour. I might have taken 3 hours to do it with the many years of my life decreased. So I would like to avoid that. So that entire spectrum doesn't get covered in such a group practice. Another thing is the system is not agile to adapt to the evolving technology because they all have been trained already to a significant degree. So they are not very keen to get trained into new technology because now the cost of getting trained, retrained is much higher because they will have to get out of their present working scenario. They will have to, sacrifice that kind of income. Say for 3 months, they have to go somewhere. I don't think, many of them will be willing to do it. However, the other way of creating teams is actually creating is what we say greenfield teams. That can only happen in an institution which has a bigger, bigger concept, bigger ethos, and it is you're starting a department, and one team leader has been selected or 2 team leaders have been selected. Then you start getting people who are motivated colleagues, and then you try to evolve a team. They will have different periods of their growth already. Some of them will be just beginning, somebody will be at mid-level, somebody will be at a mature level. And you do a SWOT analysis of your strengths, weaknesses, opportunities, and threats, and then try to see the framework of your practice, and you decide how many people you need and what kind of people you need. This is very important that the leadership of this team must clearly define the aims and the vision and with the team so that the team is very well aware which way are they heading. You can't have सेनापति telling you कि चलो चलते हैं, but you have to tell them कहाँ चलते हैं, क्या किसको जीतना है, whom to attack and what to do. So you have to have a very clear, direction. Then you have to help your the various members of the team acquire specialized skills. That's why it is important to take people who are relatively fresh. They are, hungry for acquiring new skills. They are courageous enough to get into new, areas of GI, and so that they can accomplish complete spectrum of gastroenterology. See, core therapy, I'll come back to GI endoscopy now. Core therapeutic GI endoscopy team is not only trained endoscopists. It also means very trained technicians, trained nurses to assist you. And leader has to create a team, and not only create but retain the team of highly talented and diverse individuals who may have come from different areas, who can adapt and then excel in various evolving technologies and techniques. And of course, the endoscopists have to be well versed with the image enhanced endoscopy, interventional luminal, interventional EUS, ERCP, cholangioscopy, bariatric, and third space, and anything which will be coming later. They will have to get trained into that so that they remain on the cutting edge of technology and have the complete spectrum of the services available to the patients. Now, there are two ways we acquire this talent. One is when you're starting an institution, now you are deficient of one particular area. Say, I don't have a third spaceman. And I find that in Delhi, there's somebody who is very renowned, who is a very good third space person, and he's also has significant charisma and patient and clientele, and I acquire him to come into or acquire or induce him or lure him into coming into the team. But there are disadvantages. It comes at a very significant cost, which is not only financial. This is major cost is ego conflict with the rest of the team members. Because there may be a person in your team who was aspiring to be that person tomorrow, but now he or she thinks that you have brought somebody and the chances of that person evolving has gone down. This has a demoralizing effect, and person thinks that no, I'm left only to bread and butter, upper GI, lower GI, and somebody else will be doing the more glamorous thing. So this becomes very demoralizing. So this has to be very carefully thought of, because many corporates do this to enhance their financial streams quickly, but this is not a very good way of building teams long term. The other is that you create homegrown talent. It takes time to evolve, but more cohesive for teamwork. And I personally will feel that the leaders should look at identify people who are ready to spend and sustain their interest in a particular area, and provide them opportunities for skill enhancement. But the more important thing is the expectations of such trained individuals should be very clearly defined in the beginning. Because what happens? You have now invested both time, money, effort into training a person, thinking that that person will complement your team. Now his valuation has risen. Now somebody comes and poaches that person. So you have to very clearly define to that person that, this is the cost which entire team has borne for you, and you need this is what we expect from you before the person embarks on this, upskilling journey. It's a very famous saying that coming together is the beginning, keeping together is progress, and working together is success. So it is basically working together which is very important, because that longer you work, the longer you are successful. And this came from none other than Henry Ford, who had very successful company himself. For a leader, it's very important to spend time and effort in understanding, producing, and evaluating the team. Just getting people and then, having one dinner at your home, welcome and cheers, and then everybody does what they like, is not the way the cohesive team will be made. Teams should not just evolve, but be created and molded to achieve specific objectives. So it is very important that we continue to do that. And the real challenge is to transform a team of experts into an expert team. And again, the emphasis has to be on team. People who are, they may be very skilled people, but they're not team players. They are useless for in a team because they are going to be, they're going to be high performance outliers, and they are not very good for cohesive team working. The problem which I alluded to briefly was the long-term retention of an upskilled person. This is a major challenge with all of us and the teams. And I think the most important first step is that choosing the right team member to upskill. Cost of training is to be emphasized, as I told earlier. And then transparency of additional business acquired because of this upskilling and proportional compensation provided to that person should be very transparent. That, person may feel that I went to Mayo, I learned this, I did this, but he has done only 4 cases in the last 1 year. And that added this degree of, money and reputation to the institution. So person should understand that there is going to be a proportional compensation unless he works hard to propagate his or herself. Then long-term, retention plan like ESOPs and other innovative plans are very important. In fact, Mukesh shared with me one plan which he has for his team members, where what he does is that he pays them a particular sum of money as their guaranteed money, and the additional money goes into a bank account, which is not immediately available to the person, but is available to them after 5 years. And at the end of the 5 years, there's a substantial sum of money which they get. That's like a reverse ESOPs, that you actually collect their own money and give them, and they contribute part of that money from the institution itself. So there is an incentive and disincentive if a person leaves midway, that they're going to lose substantial sum. Another very big problem in making a successful team is that what do you do with a negative outlier? Everybody is going in one stream, but there are going to be people who are thinking differently. So in every team, there is usually one member or more than one member which is spreading negativity and doubts. And this is very important to identify, that their basic, they thrive on, providing a negative commentary on the organization and the leadership. And one thing is very certain, you can never please a negative member. A person who is negatively thinking can never be pleased or appeased. But however, good leader can marginalize such member and minimize the damage being done to the team. It is best that that leader has one-to-one conversation with such a member, or let other team members have a conversation with this kind of member, because that team is going to lose much more than only the leadership or the institution. So they should have a conversation with him in a very engaging manner, and talk frankly to such person and find ways he or she can actually positively contribute to the team. Let me tell you, somebody keeps commenting, yaar ye kuch nahi chal raha, ye endoscopy mein ye nahi hota, ye time pe nahi aate. Make him the in charge of that. Ask him to, now you have good insight into how the working is. From today onwards, you are the in charge of this, and you take care of it, and let's see, and I'm sure you can improve the things. If that works, then that might work, because there was a system in the class that the person who used to be who created maximum ruckus used to become the what do we call it? Monitor, class monitor. So same thing you can do with such a negative thinker, and you may actually get positive, output from such a person. But in medicine, we are very, if you have seen the history of all the institutions, very few doctors have been chucked out by doctors. Mostly it is the administration which takes them out. But I think as a team leader, one should be very clear of an exit plan. If after discussing with the rest of the team and things are not improving, person is not ready to positively contribute, we should have a clear exit plan instead of sinking the entire team. So it is very important for us to do that. Now, the biggest challenge is for the leader of the team. That is how to create opportunities for the training and skill enhancement. He or she has to draw a business plan to optimally utilize these skills ultimately. fulfill financial and professional aspirations of the team members, and create a mutually beneficial, low conflict environment. That is very important because as people grow in stature, their egos swell up, then the conflicts become more and more, and the outputs become less. So leader has to be chosen carefully, that there has to be clear attributes for a leader. He or she should have a vision and direction, and he should align individual goals with the team and overarching institutional objectives, because this should be clearly identified that this is a corporate hospital. Its ultimate aim is to make money, and their main emphasis on patient care and some part of education and research. And that's what is the overarching institutional aim, and we are working in that institution, and that is we are going to do this bit of these three components of the our work. Then there has to be motivation and inspiration element in the team leader. We should foster the enthusiasm, recognize and reward achievements. This is very important. A simple pat on the back and recognition of a positive thing or a new procedure done or a excellent work done helps that person achieve more than just ignoring कि ठीक है यार उसका काम था कर दिया और क्या इसीलिए तो है. So I think it's very important that we recognize and reward achievements and encourage positive attitude towards challenging. If somebody resolves difficult situations, I think that is a very important attribute to that person, and that team member should be encouraged for that. Communication by the leader with the team is the most important. The leader must share information, listen to the members of the team, provide feedback, and this promotes understanding and collaboration. I think every team must have periodic meetings. That is where I think I lack, many of us lack, because we don't find time, we don't meet each other. Then we only meet when there are complaints. And there are undercurrents of, disobedience or undercurrents of dissatisfaction. Then only meetings are held. But I think it is very important for good leadership to constantly communicate with the team and understand their point of view and incorporate in the entire working program to minimize any misunderstanding. Leaders should have the qualities of conflict resolution. This is very important. They should identify personal conflicts. Persons may not have professional conflicts. They may be personal conflicts with each other. They may be at the family level, at maybe cultural level. So one leader has to be very much aware of this, and be able to evolve a mechanism to resolve it, facilitate discussions and find solutions amongst the team members, ensure harmony and cooperation by various means, and these things can go beyond the working environment. The delegation and empowerment of the team members is very important, because many leaders tend to be, in full control. They micromanage everything. If I don't do third space endoscopy, I would still like to decide which knife to buy, which equipment to buy. I have no knowledge. So I should be asking the team member who is skilled in that what are your requirements, and be in charge of this, take over this charge, you own it up and do it. So that is very important for encouraging your team members and to make the subspecialties, the areas in the specialty grow. Identify training opportunities, as I told you earlier also, and these will keep on changing, and provide mentorship to achieve full potential to your team members. And this has to be proactive, not passive. That somebody, the team member comes to you, sir, wahan par ye program chal raha, main jaya hu. In fact, it is the leadership's role to find out how can you enhance somebody else's potential by involving them in a training program or or some other way. Team bonding is very essential, and I learned it from my mentor, Dr. Sama. He used to periodically hold parties, lunches, and dinners at his farm. And initially we used to think that it's just to show off his farm and, wealth, but ultimately it turned out to be a very important exercise because that's where the entire family is bond. And I tell you, if your team members have bonding beyond the place of work at the family level, those team members will not leave. Because there are three other people in the house who are telling, क्या कर रहे हो? वो तो बड़े अच्छे आदमी है, उसकी बीवी बड़ी अच्छी है, ये है, हम तो बच्चे इकट्ठे जाते हैं उसी स्कूल में. I am telling you, this is a very important factor. We should learn from this and promote team building activities beyond work environment, encourage collaborations. Now, different team members, you should try to find how can they collaborate. One is interventionally US, the other person is very good at writing, papers. Both can collaborate and, contribute to each other's growth. And that way they will be having much closer working and a more congenial environment. And then very important when you're working in a team that you must set standards and accountability. Many times we are very loose on this. And this has to be set by the leader by example. If you are going to have a meeting at 9 o'clock every day for the department, the leader has to be there at 9 o'clock. It can't be that he's the one or she's the one who is not there and everybody is expected to be there. That will never happen, let me tell you. And this has to be, we have to set standards and goals. The leader has to be adaptable and open to change and navigate new challenges. This is a very important factor because as we grow older, we become more rigid in our thinking. And if the leader is not capable of changing, it's a very, very poor situation because your competition is changing. And hold team members accountable to achieve their goals. Goals are not necessarily financial. Goals are whether they have been able to fulfill their aspirations. One very innovative idea I had when I was building my team, which I never implemented, unfortunately, was to make every team member write their assigned progress report for the next year. Put it on paper that what I'm going to achieve in next 1 year. And then let that same person come back with the square stick that I have achieved this, I have not achieved this, I have not achieved. Then the leadership should sit down whether he could not achieve it because of lack of provision of infrastructure and or equipment or opportunity, or it was that the person did not perform enough. So then discussion can happen and things can improve. The decision making has to be dynamic and forward thinking because nothing is static. If the leader is not capable of forward thinking, that ship will always sink one day. And balancing strategic thinking and taking insights from the team members is very important because the leader must understand that the other members who are growing, they are possibly more, they have more insights into the future, the way things are, because they are interacting with the younger minds. They are more technology savvy, so should take their opinion very importantly. The Stanford University leadership model defines traits of the leader, behaviors of the leaders, and goals. The traits they call think and feel. It should be visionary, should be curious, open-minded, empathetic, and courageous, ethical, humble, trustworthy, and resilient. All the factors which I mentioned earlier. And behavior-wise, that is, the person should be able to, what he says and do should be inspiring, creative, collaborative, analytical, decisive, and action-oriented. And there should be multicultural perspective in achieving goals and commitment for greater good of the entire team and driving meaningful results and not looking at only money or this thing. One should be actually adding value to the team members and adding value to the entire organization. One of the difficulties is the insecure leader. Because I always say a leader has to become Sarthi, not a Ghoda of the Rath. Because unless they become Sarthis, they will keep on competing with the other Ghodas. And they will never be able to lead. So insecure leaders who are kind of insecure or egocentric, they basically sabotage themselves. Because if the leadership is not progressive. They're not, they are competing with their own colleagues and own people, members of the team. They're basically bringing down their, team members, their enthusiasm, and so they can never progress. And the leader has to earn the right to be heard by his team by listening to them and seek to understand the situation before making a judgments about it. This is a very important thing that the leader must learn to listen to the team members who may have a better understanding of the situation. And always don't push people, lead them. Then only they will, follow you, and then only you will be able to get them in to achieve their goals. And control is never the aim of a leader. It is the progress of the entire team which should be the aim, rather than controlling the team. And Charles Darwin once mentioned, it is not the strongest species that survive, nor the most intelligent, but the most responsive to change. The evolution has taught you, and I think this is true for all the teams. Unless they're ready for the change, they will never survive. To improve your practice in general after making a good team, you still need certain things. Patient care protocols have to be in place. Competence at all levels, and both technical and behavioral skills is important. Certain teams are, technically very strong, but behaviorally, they think they're quasi-gods, and they don't bother about how they talk to the patient, and that they're not successful teams. All endoscopists, nurses, techs, GDAs, administrative staff, all have to, imbibe these ethos. We must establish protocols for patient experience from appointment to discharge. Many times the patient's endoscopic procedures are done very well. But, like Pankaj did an excellent procedure, but this patient is lying in the ward now for 3 hours. Nobody's bothered to see him. He has hematemesis, and the patient collapses. And all that effort, patient will only say, "Doctor Saab ne kiya, to patient ho gaya." And it was all because somebody was not looking at, and the entire chain was not, sensitized to the care of the patient. Reassess protocols and sensitize all involved. Protocols to handle adverse events should be clearly defined because these are very important when you're doing high-risk procedures. There are 5 fundamental components of a successful endoscopy team. Proper training and credentialing of the endoscopists. You see, one problem which I face is that if a person is trained in a more complex procedure, if I'm trained in ERCP, I think I have the right to do EUS also. I may not be knowing ABC of EUS, but then they will, the person will go pick up the scope and see, after observing a couple of EUS, will start doing it with missing half of the information. I think credentialing by the leader is very important, that who does what. Technical and patient care support from nurses and other staff should be integrated into it, and identifying strategic partners in your institution is very important. When I say strategic partners are anesthetists, interventional radiologists, the administrative staff. They're very important for your growth of the department. And recruiting multidisciplinary collaborators like GI surgeons, pulmonologists, and others who are oncologists who are going to refer you patients should be practically part of your team. You should consider them and behave with them and treat them like your team members. And you should always have a business plan and detailed budget so that you can always get the best of the equipment which is available, and you can keep your department upgraded. In the end, build a team so strong that no one can point out the leader. They should all be people of significance and not pygmies in front of the leaders. Thank you very much.
You all will agree it was an excellent oration. It is basically the lifetime achievement of Dr. Randeep Sood. I have seen him when I was a young boy, and still he is young and doing the same way he was doing before. So I'll call upon Dr. Dadi to carry over the proceedings and everyone to stay on the dais and Dr. Rai to come up, please.
Requesting Rai Sahab and chairpersons to felicitate Dr. Randir Sood. A token of appreciation. Sir. I think we can ask everyone to give a standing ovation to Dr. Randir Sood. Everybody should stand up. Thank you very much, everyone. Now, I think I request all the chairpersons to stay on the dais for a very for the next. Yeah.
Thank you, everyone, for gracing the occasion. Thank you so much. Thank you. अब तुम next के लिए बोलो ना, important event. Now we have another important event of this workshop, that is the release of an endoscopy book, and for that I'd like to invite on stage Dr. Randir Sood. Please be on the stage. Dr. Vivek Saraswat, please on the stage, sir. And Dr. S.P. Mishra. I'll take few minutes of everyone. Before that, those people who actually were with me for making this book, my G6 members, Dr. Anurag, actually basically they are the section editors of the book, Dr. Sunil, Dr. Rai, please. And Dr. Amit Mathur and Dr. Mukesh Kalla, they are also the section editors. They are not here. Then I'll call upon my sub-editor, Dr. Anant Gupta, and academic editors, Dr. Gaurav Gupta, Dr. Mukesh Jain, and one of the very important person, one of my residents, Dr. Anirudh. I'll tell you a short story about this book, that we G6 members were having a meeting, first meeting of this AEW-4 at Ramgarh. I think it was 7-8 months ago. And then I told them that we need to have a book of endoscopy, which should have everything in that, because you have endoscopy books on therapeutic endoscopy, on diagnostic endoscopy, on accessories. So you'll have different books and different things, and I wanted to have everything in one. So all G6 members supported my idea At times, I discuss with my resident, they used to ask me small procedures, from where to get these procedures. And they are not written in all the books, but the experience of the authors. So then it was difficult to choose the authors, but what I did was from north to south, east to west, of all endoscopists of India with a great experience in their respective fields are the authors of this book. And almost, I think, one-third of these authors are still here in this workshop. Then choosing the topics was also a problem. So very small topics were also chosen, like, how to have an endoscopy fluid, then how to disinfect the endoscopes, then how to have a green endoscopy. So all those things were also included. How to take consent, proper consenting, we don't know, the legal aspects, the futures of the endoscopy. So there are around 60 chapters in this book. And compiling 60 chapters from authors was a Herculean task. And for that, actually, I had my right hand, Dr. Anand Gupta, with me. So he works with me all the time. So any problem I get, I used to tell him that this is the problem, and then those problems were definitely distributed to all my academic editors and section editors. Then came the problem of, all authors. I am very thankful to them. They're sitting in front of me, and I'm very sorry that I bothered them day in and out. I used to have a small chit I used to write, and those reminders, and Dr. Sood also remembers that. So, and I'm so thankful that from my bottom of the heart that no author said no. And, I started with Dr. Nagi, Dr. Randhir, Dr. Amit Maidev, Dr. Mahesh Goenka. They are my actually, mentors also. And none of them said no. They said that we will write. So that was the first step, that even such senior endoscopists of the country could take out time for me for this book. And then various authors were included for the book. Then it was very difficult. The timeline was 6 to 8 months only. And within that time, such busy authors did a great job. And the chapters are small. They are like 4 or 5 pages, and with the key points and how I do it. The name of the book is How I Do It by the Experts. So I like to, Dr. Randhir, actually we planned for this, so kindly, yes. मैं आता हूँ सुनाने. And Dr. Saraswat and Dr. S.P. Mishra, please.
I think when Sandeep was saying that he had to keep persuading people to finish the chapters in time, he pointed at me because I possibly said the chapter last, but he was very persuasive, and but the concept was so good that none of us said no to him. And I think it is going to be very useful for residents, because it could be simple, not too much of data or referrals in referrals in that, and it only gives you practical points of how I'm doing a procedure. So you could simply flip through one referral book and go through various procedures which you want to do. So it's going to be of value. Thank you, Sandeep.
Well, congratulations, Sandeep and the entire team. It's a wonderful book. It's a bit heavy. And everything is heavy. So, but most of the experts have given their own personal how they do it. And that is of great help because endoscopy or gastroenterology is all about innovation. You have to think there and then how to do it. So that's very important. I wish you can put it up on the web also so that everybody gets the benefit of it. Thank you very much. Congratulations again.
Well, congratulations, Sandeep and the entire team. Sandeep is consolidating a new niche for himself, and which is in compiling, editing, and publishing books. I thought the progress in gastroenterology that he came out with when he was president of the ISG was exemplary. And on those same lines, this endoscopy book and a couple of other books that he's brought out, I think are valuable additions and high quality additions to the library or to the shelf of every endoscopist, every gastroenterologist. So I think the whole concept and the idea was excellent, Sandeep. And as SPS said, making this available hard copy as well as in a soft copy form to users in at least in our country or whoever are interested would be a great way of spreading this information. Thank you. Congratulations again.
Thank you, sir. Actually, publishers, Evangel, have taken the responsibility. So initially, it will be a hard copy because if they give the soft copy now, then the whole purpose is lost for them. So there will be some time for before the soft copy is released. So thank you very much. Thank you, everyone. Thank you.
Now we are going back to the pre-lunch live session. May I invite the moderator for this session, Dr. S.P. Misra, sir, please. Dr. Misra, sir, please come back to the dais for moderating the live session.
These actually three books will be on the registration counter. So everybody who wants to see that book, they can see there. And all endoscopists of India will get this book in the near future.
Hello. Dr. Rajmani, Dr. Saroj K. Sinha, please. Dr. Sivdatta Padhi, Dr. Siddharth Wable, Dr. Aminuddin Khilji,
Good afternoon, Dr. Dadich. Can you hear us?
Dr. P.K. Agarwal, please.
Amit,
Yeah, can you hear us?
can you hear me? We can't hear you, Amit.
Dr. Amit, आपकी आवाज नहीं आ रही. Over to you, Mr. Ji.
Okay,
Dr. Amit, we can't hear you. Amit, आवाज नहीं आ रही है.
आवाज. Just a minute. Now can you hear us?
Yeah, better. A bit.
Okay, perfect. So we are back live and just wanted briefly to show you a glimpse of the last procedure done by Dr. Pankaj Desai and a very excellent closure. So a wonderful procedure demonstration by Dr. Pankaj Desai. Pankaj, are you here?
Hello. Can you hear me?
Hi, Pankaj.
Yeah, hi. Yeah, you can see that what we have achieved is we used two actually clips from Microtech that were 20 mm. And we could approximate the margins quite well. In this sort of cases, I don't think you need a airtight closure because the muscle is intact here. What you require is reduce the dead space and just approximate so that the exposure to the acid in the stomach becomes less. And this will ultimately heal. And I think we could achieve it very well with only two clips. So I think it's good for the patient. We can save on the cost as well as get the desired results. So thank you everyone and thanks a
Pankaj,
lot.
this was
Thank you, Dr. Pankaj. A
in a
big round
routine
of
case, will we
applause
have
for it.
some problems? This was a lot easy. It's good luck for you.
So we now move on to
Yeah,
room
thank
number
you.
3. We now move on to room number 3 where we've got a very interesting case. And I would request Dr. Shreyans to kindly present the case.
So this is a patient, female patient, 44-year-old. She presented to us with a history of intermittent pain abdomen from past 3 months. She was evaluated outside and a CT scan was done, which was suggestive of left hepatic thickening, for which was suspicious for mitotic etiology. She had an exploratory laparotomy outside, but the operation was closed that time. They think that it was infiltrative disease, so they closed the operation, and at that time biopsies were taken. However, it was inconclusive and it was found to be a normal. So the patient is currently asymptomatic from past 1 month. She had an absolutely normal LFT. The follow-up MRCP was done, which was sort of isolated left hepatic duct stricture in a thickening. So in view of this indeterminate etiology, we are going to proceed for a diagnostic ERCP followed by breast cytology and a cholangioscopy and spybite biopsy if needed. So this is an MRCP image.
We move to room number 3. Dr. Sanjay Kumar, Dr. Sanjay Rajput, and Dr. Khanna are there. Dr. Sanjay, you are live.
Hello, everyone. Am I audible there in the hall?
Hi, Sanjay, you're audible.
Yeah. So this is, I hope history has been told to everyone.
We can't see anything because the camera is just behind the image intensifier.
So, camera?
Okay,
Oh.
we see.
Hope, Mr. Sir, you can see me now.
You can see you. We're
Yeah.
not seeing the endoscopic image now.
So we have this case which has been diagnosed on MRCP as left hepatic duct stricture, and our plan is to do.
Endoscopic image.
Previously, the history has been told.
Yes.
Yeah.
Sanjay, but the only thing is why did they think it's inoperable? That we don't know that.
Yeah, we are not sure. So with me, I have Ramveer who will be assisting, Dr. Sanjay Khanna, Dr. Sanjay Rajput, Dr. Veera Loza. So we have a big team. So what we have done in during this time is that we have already done a sphincterotomy, and we are actually ready with the spy scope to enter and show you what is there in the stricture. इसको बड़ा कर दो.
ERCP images बता देते हैं सर.
हाँ, अरे. Can you show the fluoro image जो अभी था दिखाओगे?
Endoscopy, fluoro, both.
Yeah, this image. So when we injected the contrast, you can appreciate that right system is normal,
We can't
but
see
left
we
duct
can't
is
see
dilated.
anything.
Can you see the fluoro image?
No, we can't see anything.
Please show the fluoro. Can you see the fluoro image now?
No, Sanjay, we can't see, unfortunately.
Give us a minute, actually. There's some problem with the fluoro image.
So we are waiting. Send the fluoro image there. They are not able to see this.
If only we can see the spy images, that will be good. And good enough, I mean.
उससे कोई फर्क पड़ेगा? फिर हमारे लिए पोजीशन आउट हो जाती है ना.
So Sanjay, it's very important to know why did the surgeons think that it's inoperable? Something about outside. He saw it from outside, not from inside.
पंकज ये इमेज आ रहा है क्या यहाँ का वहाँ नहीं?
नहीं आ रही दोस्त यहाँ कोई इमेज.
वो कैमरे से ले रहा है. कैमरे से ले रहा है वो. आप दिखा रहे हो डॉक्टर मिश्रा?
Yes, we can't.
Can you see the fluoro image now?
No, no, we can't see anything.
So show with this camera. Dr. Kalla, you need intervene. You need to intervene. ये इमेज भी नहीं जा रहा हॉल में.
That's what Randhir said some time back. Yes, now we can see it. Sanjay, we can see everything now.
Now it's okay. We got it.
Yeah. So now you can see that we had already injected contrast, and you will appreciate that the right system is normal. But in left system, there is mild dilatation and some irregularity. There could be some filling defects also. So this is what we want to ascertain further by doing a cholangioscopy in this patient. So
Hello.
Make the endoscopic image bigger. Okay.
The CVD looks a little prominent because the scope diameter, if you see on the image, and
Yeah,
the
we'll see that also.
CVD diameter almost matching. So
It was reported as normal on MRCP, and apparently CBD diameter is normal, but there is slightly dilated left system. So now we already have a wire into the left system. I am taking out the cholangioscope. The technique to hit the papilla with the cholangioscope is that you don't generally use the elevator. Otherwise, it spoils the scope. The best is to have the wire in. You can sometimes do a freehand cannulation with the scope also. It depends on the position. So now you can see the cholangioscope is there, and I'll just use the up knob to bring the cholangioscope to the papilla, and now I'll enter. You can pull the wire a little bit. Normally we don't want to use much force. It should go in with the change of position.
So Sanjay, is it wise to do a balloon sphincteroplasty?
It is not required in every case, but if you have difficulty, you can certainly do. Normally, the diameter of spy scope is 10 French. So it's about 3.5 mm. So not difficult
if you do a bit, then your spy scope will last a bit longer. We can't see the endoscopic image. We are just seeing the room image now. Spy image, please.
we need endoscopy image as well as spy image.
अप डाउन को अप कर लीजिए पूरा
तो spy में
नजदीक चले जाइए.
Can we see the endoscopic image so that the youngsters can know what are the difficulties and how to solve them?
Dr. Sanjay, we don't have any image in the hall.
Elevator.
इसी को zoom कर दो. The monitor is getting behind the image.
Shall we do a plastic?
कर लीजिए एक बार पूरा बाहर निकाल दीजिए सर.
सेक्शन तुमने हटा दिया ना, सेक्शन नहीं कर पा रहा.
तभी है ना. तभी ईपीटी एक्सटेंड करने को बोल रहा था उसमें. नहीं बाहर है.
थोड़ा सा बाहर आया. I will go in again.
मैं सर के साथ नहीं.
Sanjay, what is the problem? You have a guide wire inside.
Yeah, it's
not able to railroad it.
Yeah, we have done a sphincterotomy, but
Yes.
perhaps it is little inadequate.
Yes.
So the scope is not going. I think
That's-
I'll take your
that's a teaching
suggestion.
lesson for the youngsters here.
Yeah, the way you had suggested, perhaps in some cases we have to do a sphincteroplasty. I'll just try once, otherwise we'll do a sphincteroplasty. The procedure will be much easier.
That's better, I think. And then the scope also lost a bit longer.
Yeah.
Otherwise you break the fiber.
In fact, we are using the scopes not once, we are using them several times. So it is always wise to look at the longevity also.
You see, you can see a lot of puckering on the spy scope now.
वो PIP में फ्लोरो आएगा ही चेक कर लेंगे.
संजय निकाल लेते हैं. So I'm just taking out this and we'll do a sphincteroplasty. Can I have the? Now I roll. Ramir. So this is the scope which we are using is a TJF 190V. So it has an advantage that it holds the wire in place. It has a groove for the wire. So that is an advantage to exchange the accessories quickly.
Sanjay sir, there's a question for you.
Yeah.
What is the life of this spyglass colonoscope? Like how many times it can be used, a single scope?
See, normally if you are doing a diagnostic scopy, nowadays the present DS2 spy scope is a bit sturdy and we are able to do 6-7 cases with one scope. But if you are doing large stones and using laser also, usually I think it would last for 2 to 3 procedures only.
It depends how you use it basically. If
Dr.
you,
Sanjay,
if
we would
if
be
your
moving for
fibers,
some
laser
time in
fibers
room number
outside,
4.
not damaging the tip. That
And I would request the resident to kindly present the case for room number 4.
Okay.
But it's meant for one-time use.
So we are demonstrating
But ideally, it's meant for one-time use.
Hello, hello.
Yeah, go ahead, go ahead.
So we are demonstrating a case of a 71-year-old female. She's having a history of chronic constipation and intermittent pain abdomen. She's having a history of chronic constipation and intermittent pain abdomen from past 8 months. She had an colonoscopy done, which was suggestive of a large sigmoid colon subepithelial lesion, possibly lipoma. Transcranial endoscopic ultrasound was also done, which showed a hyperechoic lesion arising from a submucosa, possibly lipoma, and a CT scan is also available, which showed a hypodense lesion in the sigmoid colon. This is a CT demonstrating hypoenhancing lesion seen in the sigmoid colon. Now I'll proceed towards the colonoscopic image, so showing a large lipomatous lesion, and this is a US image. So we are moving towards the case.
The question pillow sign was positive. Hi, Amol.
Yes, sir. Yes, sir.
We can't hear you, Amol.
Let's see.
Yes, that's better.
This is better?
Yes,
Okay.
absolutely fine.
Are you getting the endoscopy image?
No.
Okay. So hopefully you will get it in a moment. I have Pankaj with you.
Yeah, we
and the
can see.
anesthesia team over here. And
We can see the endoscopy image.
at the outset, let me congratulate Dr. Kalla, Dr. Nijavan, and the entire team for this fantastic workshop. So I put the scope inside. I'm using the HQ gastroscope, the 1500 gastroscope from Olympus, with a distal cap attached. Since this is a sigmoid, if it was in the right colon, I may have used a colonoscope. But just left side lesions, I find it better to use a gastroscope because just makes the instrument exchange much more easier. So I'm at around 20 centimeters.
Is it a double channel scope?
No. This is a regular
Single
gastroscope. Regular 1500 gastroscope, the X1 scope. So I'm at around 20 centimeters from the anal bulge, and we can see the subepithelial lesion with a little bit of redness, and possibly there has been some intermittent intussusception that may have been caused by this lesion, and which was probably the cause of the patient's pain. Of course, elderly patients can have constipation even without, but that is how it is. So a few differences from what Pankaj showed a little while earlier. Now we are in the sigmoid colon, and let me tell you, sigmoid is one of the most mobile organs in the body. So getting a good position and maintaining a good position sometimes can become difficult. And the other thing is, gravity is a very minimal help over here because the sigmoid moves with gravity, and then your lesion also moves with the gravity. So fortunately, this lesion over here, it is in the anti-gravity side, meaning it is not pulling up too much of fluid. So that is how it is.
But you are reaching the upper end very well.
I'm reaching the upper end. I went proximally, but I have to loop the scope a little bit and go proximally. So that is how it is. So I may have some challenges in the scope tip transmission, the force transmission to the scope tip when I'm dissecting, but let us see how that works.
Yeah, because in such, if the mucosal lesion is there, what we would like to do is go beyond, do a
Yes, good.
retroflexion
Retroflexion and
start from
and
there,
start
but
from
here it is going to be very
In the
difficult.
sigmoid retroflexion is very difficult. दबाना मत इसे. अच्छा. The other thing is, presently I'm going to maintain this at this position only, and I'm not going to mark because in the colon the wall is very thin, and even marking can cause a full, deep, cautery injury. So I'm going to inject, and then we'll make a mucosal incision and see how it goes. So
Amal, the plan is start from the anal side.
Yeah, what
Make a sort of tunnel
Yeah.
across and then do the dissection by the side.
More than a tunnel, Pankaj, it would be more like a pocket, I would say.
Pocket. Okay.
It would be. So what I'm going to do is I'm going to go as deep as I can get over here, and you can see how the lesion is moving continuously. So that is the challenge sometimes. Hold here. ऐसा पकड़ो.
And the lesion is a lipoma?
It is a
Looks
lipoma.
like a lipoma. Needle.
It's a huge lipoma, and I think it is causing intussusception recurrent by the look of it.
Okay. Enough. So let us see what we have managed to do. So the main injection is also coming more proximally, Pankaj, you can see, rather than distally. It is not going around. What I'm going to do is I'm going to try injecting on the other side also over here at the edge, and let us see. Pakdo.
Yeah.
ऐसा टेढ़ा करके दो.
It would be good if we could get a incision on the other side, on the oral side, but very difficult. This is a good area.
Needle. Okay. करो. नहीं, wait. Back. मैडम जी आप इस तरफ आ जाएंगे.
इधर है.
क्योंकि उस तरफ से पकड़ नहीं पाओगे आप. आपका समझेगा नहीं क्या पकड़ना है, कैसे पकड़ना है, कैसे पकड़ना है. पकड़ लीजिए. देखो.
Scope stability in the sigmoid is very difficult. And you can see it is just going by the side. Slowly you are getting here.
Okay, enough.
Maybe I think you can just
I can just
on the
inject
top
on the top
and and just start your dissection.
Because otherwise there's going to be too much of injection all around. And
That's
that
right.
might make things more difficult.
That's right.
Needle.
I think this is good.
Needle. Okay, enough.
Okay.
Right.
Enough.
It's not lifting that much.
Yeah.
That indicates that there may be some
Fibrosis.
fibrosis.
I agree.
Because of intussusception, because as it keeps prolapsing, you can have a. So
Yes.
we don't need a very wide margin over here. We can go very close to the edge of the lesion, and we will make a mucosal incision and try and get in the submucosa.
And you are using a dual knife
Yes.
with a 1.5 mm tip. That's
Yeah, so
colonic.
ideally I need the 1.5, but I believe the 1.5 is not available from Olympus just now. So we're using the longer one, but that can become a little bit more tricky. So with the knife.
That's right. Yeah. Just take out little. Yeah.
Yeah. So, मैं बोलूँगा आपको छोड़ना है.
He is using an endocut Q with a effect of 2, cut duration 3, cut interval 4. And can we just change it to precise segment? Soft coagulative. Precise कर दो ना.
नहीं, हाँ.
हाँ, okay. And he is using a precise sect for coagulation at 4.5.
Dr. Amol will be moving briefly in room number 3 for some time there.
Sure.
Dr. Sanjay, you are live?
Yeah. So meanwhile, are we on?
Yeah. Yes, go ahead.
So we should always listen to the wise men. As Dr. Mishra said, that sometimes you need to do a sphincteroplasty before you go in. We did that, and now we are inside. And we are just moving in. We haven't gone in yet. We thought we'll go on live only. So we are moving in the bile duct. This is the left, this one, right side, you can appreciate the cystid duct. Right. Our wire is already in the left system. This is the left system where you can see some blood coming out. So here we are likely to find some abnormality. Yes, you can perhaps see something there. Dr. Sanjay Khanna is with me. He is pushing in the fluid also so that we can see very clearly. I think there is a mass there. I'll try to go in beyond this.
Can we take the wire of action? Wait.
तो अंदर चले जाने तो जाएगा नहीं.
Yeah.
Clot. Now we have to ascertain whether this is a clot or a.
You can remove the endoscopic view. Spy view is important.
Are you getting the bigger spy image?
Yes, yes, we are getting it.
So you can very well appreciate that this is clearly something obstructing our way. It could either be a clot or more likely to be a mass.
This is a mass.
So yeah, I'm going in.
You can push this
You can see a bulge, tumor bulge.
Yes.
So now we have crossed that area and we are deep into the left system. We are flushing so that we can see more clearly.
Sanjay, is there any chance of inducing cholangitis?
Yes.
By the spine?
Yeah, there is definitely a chance. Patient has already received antibiotics, and with cholangioscopy, even in the best of hands, best of centers, the rate of cholangitis is not less than 15-20%. So we have to cover them up with good antibiotic. Depends on what procedure and how long you have kept the scope in.
And how much water you instill?
Yeah. Especially cases where we do a lot of irrigation, large stone cases. Yeah. Now we'll take out the wire. So cases where we do large stones, we have to irrigate a lot of water. So in those cases, we actually prefer to intubate the patient because the risk of aspiration is also there. So Dr. Khanna has taken out the wire now. Can you show the fluoro image for a moment just to see how deep we are?
Fluoro, can you have the fluoro image?
We're getting
we are there. This is there. That was the old image.
Dr. Sanjay, you have crossed the lesion.
Yeah, we have crossed the lesion. We are in the left system.
Yeah.
And you can see the spy image again. Here the mucosa is normal. When I am coming back, we'll see the
So
tumor
for the
again.
audience, the extreme right lesion from your side is the other room, not this lesion.
So we are
That's the,
intrahepatic.
that's the lipoma.
Lipoma?
वो दूसरा हमारा
वो चल गया.
विजन उसका
Oh, अच्छा अच्छा.
Sanjay, presently the patient is asymptomatic.
Yeah.
So, we need to look at what be the possibility.
Yeah, sometimes what happens in intrahepatic strictures, patients may not be having much symptoms barring mild pain or maybe slightly raised alkaline phosphatase. But we have to evaluate, because if it is a malignant lesion, then you have to be proactively doing something. Yeah.
So Sanjay, but I like to know why it was inoperable, because
No, that was done somewhere else. We don't know why surgeon chose not to do anything about
if
it.
it's not outside, it can be operated.
SP sir,
So we are there.
Dr. SP Mishra sir.
Go ahead. Go ahead, Sanjay.
This patient initially landed at a cancer hospital with a mass in the right hypochondrium.
Okay.
So he was taken up for diagnostic laparotomy. On laparotomy, they realized that the patient has a mass at the hilum. They took a biopsy and they closed, presuming it to be inoperable.
Okay.
But approximately 2 to 3 weeks later, he came back without any symptoms, just for a follow-up. On that follow-up, radiology was done, wherein there was nothing available. This lady went to Dr. Govil for a EUS, thinking it to be a mass at the hilum. But he did not find any mass on the EUS. CT was normal. MRCP revealed a discrete stricture at the left uptake of
Mukesh,
the
what
hilum.
was the biopsy? The surgeon took?
Biopsy was negative, sir. Biopsy was negative. PET CT scan was negative. Biopsy was negative too.
Okay.
Sir, but
Potentially this patient is operable.
but where is the stricture, sir? You know, I mean, after coming out, there is no stricture seen.
No, I mean, we have to give time to the cholangioscopy operator to analyze that area
So
carefully.
there's a mass over this.
Because it's a nave biliary system, but we saw a clot there, so there is a possibility that we'll definitely find a lesion out there.
You're right.
आपका स्कोप बाहर आ गया राउट साइड डीसी के साथ ले जाइए अंदर
Oh, that is the problem. Many a times on ERCP, you will get only a structure, with a mass.
Sir, but that mass which was initially seen is no more seen once he is coming back, you know, from it's all clean out there. So probably, as you said, it was maybe a clot or something there.
Dr. Sanjay, we are briefly moving to room number 4. Dr. Amol, you are live.
Chalo. Amol, we can't hear you. We can't hear you.
Now can you hear me?
Yes, we can hear you.
Yeah. So we entered the submucosa and we were actually
show the endoscopy.
Show the endoscopy image.
Yeah,
that's
okay. So we entered the submucosa and there was quite a bit of a surprise here, which we suspected when we had done the submucosal injection because the lesion had not lifted up so well. But now when we have entered the submucosa, you can see over here that the lesion is completely arising from the muscle layer. It is not arising from the mucosa, the submucosa at all. This is not a lipoma. This is most likely a gist.
Just. And you can see tortuous vessels too.
Yes,
Tortuous
absolutely.
vessels. And
See
here
the
you
muscle.
see that the muscle fibers.
Yes.
And can you hold the scope? The scope.
Scope.
So I'm just trying to inject between the muscle fibers over here just for demonstration. I'm not going to do anything. So just, sorry. Barabar pakro, please.
So this is a gist and
Yeah, this is a gist.
And it's moving so much that it's very difficult.
No. And more importantly, inject karo. So see, only this side it is on the outer side it is elevating, but there is nothing which is happening on the lesion side. So we will necessarily have to do a full thickness resection over here if we plan to do it just now. And being in the sigmoid, unless we have something like an overstitch over here, with which we can close the defect, I would not want to do that. I don't think overstitch is currently available here. So because of that, I have already spoken to Dr. Pankaj Shimal over here. I think we will abandon this case. We will not do this case.
Yeah, I think.
But I wanted to demonstrate this. That
such a
this is
huge
not
lesion.
something that we should be doing unless you have the really secure abilities for a secure closure, because otherwise this patient will land up with a colostomy in the afternoon. Nothing, an emergency colostomy.
Dr. Amol,
Yeah.
I've got a question here. When you showed the EUS image, that showed a solid mass-like thing, you know, on the rectal EUS.
Right.
So was that not suspected to be a gist or something on the rectal EUS?
Well, two things. One thing is the EUS was done earlier. So more importantly, what we would always do in this kind of a situation is do a radial EUS. Because very often with a linear EUS, you will not be able to see the attachment, muscle attachment very well. And it is very important to differentiate the muscle layer separately in the entire length of the lesion before we take up lesions for ESD or IEF.
And I think if everyone has seen, when he was injecting, the lesion was not lifting up.
Yeah.
Only the sides were lifting up. That is, we thought it is because of fibrosis, because of recurrent intussusception.
Yeah.
But it has turned out to be, it is arising from the muscle.
The muscle layer. Here you can see that the submucosa we are injecting and then it is straight onto the muscle. So we are not going to be doing this. We will.
Mic on kar do bhai.
Amol and Pankaj.
Yeah.
You go back to your US picture. Actually, it was not showing lipoma.
We have
solid mass.
It was shown it was a hypoechoic lesion. It was not a hyperechoic. US itself had not shown a lipoma. It had shown submucosal lesion.
In fact, Nilay, I had only seen the colonoscopic images. I had
But
not seen the EO.
they showed us the EUS image. If you have a chance, just go and look at it.
Yeah, that's what I said, Dr. Nilay. It was basically more of a solid mass-like lesion being seen.
That's right. That's right. Right. So I think in best interest of the patient,
We will not be doing this.
she'll go for a surgery straight.
Yeah.
So for the audience, discretion is better part of valor. Just because you have a nail, don't stick it up.
Yeah, that's right. That's right.
Have a hammer, everything should do so. Good, Amol. Thank you very much.
Right. Thank you. Thank you,
Thank
sir.
you. क्लोज करने की जरूरत नहीं है, जस्ट म्यूकोसल इंसिजन है यहाँ पर. क्यों पंकज? क्लोज करने की कोई जरूरत नहीं. चलो.
So we are moving to room number 1, and where Dr. Vikas Singla is there. Dr. Vikas, you are live. Just presenting the case. Pankaj.
So,
Zahir, you are there?
yes. So this patient is
Why we are having so fluid running so fast?
this is a 40-year-old male patient with no comorbid disease. He has a long history of dysphagia since 1 year, weight loss 10 kg in last 1 year. Upper GI endoscopy has shown dilated esophagus with prominent tertiary contractions and one large diverticulum just above the GE junction and a small hiatus hernia. So the endoscopy pictures are there. Contrast study is showing a large diverticulum with tortuous lower esophagus and delayed passage of the contrast in the stomach, which is suggestive of achalasia. And we've done a manometry which is showing type 2 achalasia. So the plan is to go for a OMD procedure. Over to Dr. Vikas Jingla in room number 1.
Dr. Mishra, Dr. Nilay, good afternoon.
Good afternoon.
Can you see us?
Yes, we can see you.
So I'm thankful to organizing team for the kind invitation and the opportunity. So we have a case of dysphagia, and we can see there is a tight G junction, very tight G junction, and we are not able to go across the G junction, in fact, very tight, and we can see a long spastic segment. So if we start endoscopy from the upper esophagus, once we go inside, this part is dilated, and then we can see one diverticulum on the left side. It's a shallow diverticulum. I think this can be spared. And then when we go inside, one more diverticulum is there. This is the opening of diverticulum, mouth of diverticulum. And when we go inside, so there is a large, big diverticulum. So this seems to be type 3 achalasia based on the endoscopy. So so here in my room, I have Dr. Alok, anesthetist, and I have Jahir to support. We all know Jahir, excellent endoscopist. I can't ask for a better support. Then I have with me Dr. Nirmaljit, who is again excellent endoscopy and very close friend. So Jahir, what's your opinion? So do you think it's a type 2 or a type 3?
Yeah, I think even if the manometry shows type 2 achalasia, what we need to see is the intrabolus pressure.
Yes.
So the intrabolus pressure, if it's more than 70, I think we should treat it as type 3 achalasia, even though the report, the automated analysis shows type 2 achalasia.
So, but Zahir, with the diverticular just above the LES J junction, will it affect the manometry findings?
It usually does not affect it, but sometimes we are not able to pass the catheter. The catheter tends to coil in the diverticulum. Otherwise, it does not affect the findings of manometry. We can see the spastic segment here. This is the upper diverticulum, and which means that we need to start at least 2 centimeters above the proximal diverticulum to release that spastic segment. Now, the important question is whether a simple poem will be effective in this case, or whether we should really do a D poem and divide that septum.
Yeah.
So, in my opinion, if you have a tight G junction, I think opening up the G junction alone is sufficient, and you may not require a D poem. But some argument in favor of doing a D poem is that in case you have a large diverticulum that may still hold some food even after doing a poem, but the data suggests that poem is equal to D poem in cases where LES is involved. So if this is a jackhammer esophagus or diffuse esophageal spasm, I think we need to divide the septum because LES is not involved. But in cases where LES is involved, like type 3 achalasia or type 2 achalasia, I think dividing LES alone is a simpler and faster procedure. So we'll decide as the procedure goes, and suppose the septum comes in the way and we have an easy access to the septum, we can go ahead and divide the septum. Otherwise, going and dividing the LES along with a long myotomy in the esophagus should be sufficient, in my opinion.
Jahir, I agree with you. This patient has a 10 centimeter long segment on barium. I think myotomy should be at least 10 centimeter. And I think once we cut this tight area, the pressure should come down, and this the effect of this this diverticulum may reduce.
May reduce.
And the direction, I think we can keep direction in this direction. So that way we can see septum also, and we can go on the left side of septum and do it. And I think our myotomy should start above the this
The
diverticulum,
proximal
proximal diaphragm. And above in this area we don't see any tight segment. So this area is dilated. So I think we can start 4 centimeter above this diverticulum.
So because if you start below the diverticulum, what's the problem?
So above,
No, if you start below the diverticulum, what's the problem then?
So I think the pressure in this area is high, and the dysphagia may persist. If you don't cut this high pressure segment, the dysphagia may persist in this patient.
So if you start at the septum, you can do both things together.
Yeah. So in this, the septum is very shallow, sir. So if you cut on the right side of septum also, that should relieve the pressure. This is very shallow, shallow pouch.
Yes, therefore, it will relieve the pressure over there.
Yes, sir. Yes, sir. So this is the diverticulum, upper one. So I will start 4-5 centimeter proximal to this, and we will do a posterior myotomy. We will try to stay close to the septum. So if we have to do septotomy, we have to do tunneling on the left side. So we can see a spine impression, patient lying in the supine position, and we can see that fluid is going down by gravity towards 6 o'clock. So we will inject on 5 o'clock for posterior poem.
Dr. Vikas, what will be the chances of perforation in a patient when you will cut the septum for the diverticulum?
So when we do tunneling, we have to stay close to the muscle of septum. Otherwise, there can be a mucosal injury on either side of septum. So I think mucosa may be thinner inside the diverticulum. We have to be very careful, and we should avoid injury to the. So if the mucosa is intact, there is hardly any risk of perforation.
And if you only do a poem and leave it,
That's also an option, sir. So I think that should relieve the dysphagia. So if at the level of a neck of diverticulum, if we can do the myotomy, that should relieve the pressure. So we'll start injection at 5 o'clock.
and do you think this divertically formed because of the high pressure?
Yes, high pressure, likely, sir. Inject. So we are getting a good bleb there. So there is hardly any submucosal fibrosis. Inject more. So I'm using the up knob. So once the needle is inside the submucosal space and we are using the up knob, that gives a good lift. So lumen is slightly non-dilated. Sometimes entry may become challenging in such situation. Inject more. So we are injecting 20 ml of fluid. So that seems to be a good bleb. So we can see the esophagus is not much dilated. And we are using the TT knife. So first we will make a hole in the mucosa. Knife out. So we have to touch the knife, just touch the knife, never push knife, just touch the knife, and with the coagulation current.
Dr. Vikas, is there any difference by doing a simple cut which you give or the L-shaped procedure?
So we never tried that. So if in this case there is challenge in entering, we may use the L-shaped cut. There's some bleed there.
I think L-shaped cut is a very good idea. I think Dr. K.K. Rawal published.
Rawal has just published it.
Yes. And I've used it on a few occasions. I think it's good for those who are beginning Mohim procedure because it makes entry easy for them. But once you have crossed, say 50, 60 cases, I think the shape of the incision does not matter much. So there are different types of incisions described. One is T-shaped incision, transverse incision, where the closure may be difficult, but inverted T-shaped incision or L-shaped incision is a perfect balance where closure is not difficult and entry is much easier.
Okay. Can we go back to the case Sanjay was doing? Because this will take a bit of time. Can we see what happened there?
We'll shift to the other room.
Yes, that's better.
Inject.
One should just use force.
Yeah, Sanjay, you are
Sanjay, you on.
This area may.
A struggle here because once we showed you the stricture and some irregularity in the duct, left duct, we actually fell out of the duodenum. So we went in again. Now again the problem is that since there is initial cannulation also, there is a very acute angle just inside the papilla. So it was a difficult cannulation.
Okay.
So now we are again dilating and we'll try to.
But why did you fall down into the duodenum?
Sorry?
Why did you fall down into the duodenum? You came back into it.
We have come back already.
Okay.
So now we are dilating again. This step we did not show you, perhaps that is why we fell down. So now we are dilating the papilla again so that we can go in because there is an acute angle here. Once we try to even push the spy scope over a wire, it does not go very easily. This is a little challenge in this case. So we are dilating again to smoothen out the lower area of the bile duct and papilla, and we'll go in again. We'll try in front of you. एक बार थोड़ा सा अंदर रखें, फिर से करना एक बार. हाँ.
What's the size of the balloon, Sanjay?
This is 8 mm balloon, sir.
Only 8 mm. Okay, good.
We actually do not have the other one CREs which we use routinely, 12 to 15.
Large balloon, large diameter.
Yeah, large one is not there, so but 8 should be sufficient for spy, but
I
for
think
the
it should
angle.
be sufficient. The only thing, once you stretch it, the moment you remove the balloon, it just goes back a bit.
Okay. So deflect.
So for large stone, my philosophy is do a complete sphincterotomy and then do a balloon dilation. Balloon
Yes.
only remodels the lower end of the ACBD.
That's
Don't
right.
stretch the fibers.
So slow deflation after inflation. Deflate. This is not deflating. What? Suck करो आप.
फट जाएगा सर. हो नहीं रहा अभी. अब हुआ. चलो राम देखो.
What? नहीं इधर बाहर ही है.
चलो अब हो गया.
एक्सेस तो हुई नहीं ना अपनी इसमें.
आपको
और डायलेट भी कर रहे हो.
नहीं डायरेक्टिंग.
नहीं, we have already
तो
gone.
दोबारा से
We have
अंदर जाने में दिक्कत है क्योंकि नीचे एंगल है.
हाँ.
नाउ प्रॉब्ली अब स्ट्रेटन आउट हो गया बिल्कुल.
Ab जाएगा it's. You can see the inside of the
पैर
CBD
रखना
very
राम.
well.
आयो.
So you can see a well dilated papilla now. The opening is well dilated.
You can see the inside of CBD.
Yeah. So now let's take the spy scope again. We'll be taking a spy bite also if you reach at the stricture.
You can
then-
push a ultra thin scope inside with this.
Yeah, that is direct paroral cholangioscopy.
So large dilation is.
Even that becomes a little difficult unless you
I know
inflate
you
a
have
balloon
to,
inside.
you have to
and
go
keep
only
it.
with the guide wire.
Yeah, over the wire and sometimes a balloon which can hold it there. Otherwise, it tends to form a loop. ऑन करो, फ्लोरो दिखा दो एक बार, वायर का शो द फ्लोरो प्लीज. So the wire is, yeah, it is in the left.
अभी वायर रहने दो, अभी नहीं चेंज करेंगे.
We had an interesting incident last month that one of our biliary stent got deployed within the scope. So actually it would not come out with anything. So we had actually put a spy scope inside to see where it is.
So it was a metal stent?
It was a metal stent. It did not get deployed in the bile duct, some technical failure, but while we were removing it, it got in the, opened in the scope itself.
So what did you do for that?
So we could manage to remove it by putting some large accessory catheter. So it came out from the lower end of the scope.
Okay.
Yes.
Did it damage the scope?
No, it did not.
Anil?
It is still working well.
Yes, you are in.
वायर थोड़ी खींचो. So you can see here we have seen that there is a large well dilated papilla, but still in the lower CBD there is an acute angle. So it creates a problem. We are very in this.
That is the advantage of a large balloon dilation. If you do a large diameter dilation, it remodels the lower part of CBD, makes it straight rather than rhomboid.
So we actually did it with Hurricane. We did not have a standard CRE.
I
think so.
Let's go back to the other case. While Sanjay is trying to get into CBD, can we go back to the other case, please? Sandeep? Amit?
इसको अंदर ले लीजिए सर.
Amit?
वायर करेंगे. अच्छा. वायर बाहर है.
Anybody at the hospital, can we go back to the other case? No, let him go inside, then we'll talk to him.
Hello?
Can we go back to the other case?
Yeah, we are trying to, yes. Now we are shifting to Dr. Vikas Singla.
Hi, Vikas.
Yeah, Vikas, you're on.
No, we can't hear you.
Audio.
क्या करें?
कुछ नहीं सर, वायर डालिए.
Can you hear us?
Yes, Vikas, you're on.
Yes. So we have entered inside the tunnel, and on the right side we can see there is a muscle, and left side is the mucosal left side is the mucosal layer. So I am keeping lino dissection vertical, knife out, and my knife is facing towards the muscle layer. It's superficial to muscle. So my plane of dissection is between the muscle and the deep submucosa. I'm going from one side to another side. Inject. Yes. So I have to be always superficial to the
muscle
layer. Otherwise, I can enter inside the intermuscular plane.
So because what all movements with the scope you are making to make your tunneling much faster.
Okay. So the length of knife is fixed. So what I do, I inject first, then knife out. So I just white part of knife should be just visible, knife out, and then I make a hole in the submucosa, engage my knife, and now I'm using up knob. I'm using up knob. I don't have to use left right knob. I'm using up knob and the left and the pull and push movement on the scope.
Keep muscle on the right.
But earlier,
Inject.
you were very scared of doing a mucosal perforation, but I've seen Zout making 8 perforations and clipping them.
Yeah.
Yeah.
So,
Vikas?
yes, sir. So trick is to stay towards the.
I know it's very safe to be there, 30-degree angle, but even if you make a perforation, you can clip them. After some days, you find a
Yes.
normal mucosa over
Yeah.
there.
So if there is a mucosal defect, we have to close that defect, then we continue the tunnel. Otherwise, with the scope pressure, the size of the mucosal defect may increase.
Yes.
So trick is to keep the knife facing towards the muscle layer.
So
And keep on injecting. Whenever mucosa and muscle are coming close by, keep on injecting.
So,
But the problem is because how do you
Yes.
be sure that you have created a mucosal defect?
We have.
Only when you go from the mucosal side, you can see that.
So we can see a good cushion of some mucosa on the left side, sir.
Okay, that's fine.
Yeah.
No, you're towards the muscle. No problem
Yes.
of.
So we'll go outside, we'll check. In between, we can go outside and check.
No, I'm asking for others. If you create some inadvertent mucosal defect, how do you confirm it from the submucosal side?
So you can see a defect, sir. If there is a complete defect into the submucosa and the going up to the lumen, it will be visible on the in the tunnel.
While Vikas is continuing with the dissection, I thank all the chairpersons for their nice discussion. We can have change of guards here. I request Dr. Misra to stay here. And I thank the rest of the chairpersons. And I request the new set of chairpersons for the next session. Dr. Babulal Meena, Dr. Chaganlal Birda, Dr. Amit Agarwal, Dr. Amit Goyal, Dr. Anil Sharma, Dr. Atul Shinde, and Dr. Samir Mohindra. Meanwhile, lunch is served outside. Anybody who wishes to have lunch first can go and come back quickly.
तो यहाँ तक है, यहाँ तक है ना?
4 सेंटीमीटर और.
Dr. Babulal Meena, Dr. Chaganlal, Anil, Amit Goyal, Shinde, please come.
That's all. So we have gone towards the luminal side. So we are.
Amit Goyal.
So Vikas, what is on?
So we have gone towards the luminal side. We are still short by 4 centimeter. So we have to go, I think, 5-6 centimeter.
You're just confirming where you are.
Yes,
from
sir.
the luminal side.
I will show you.
Dr. Bhusen Pandit around.
I think we are
Dr.
going in
Bhusen
the
Pandit.
right direction.
Okay.
So that's the entry side, and we can see blanching here. And we have done, I think, yeah. So we have done dissection up to this part. So if you have to go towards the septum, we should move more towards the
left side.
Left side. Yeah. I think we are slightly on the right side. So if you want to cover the septum, so we'll go slightly towards the left side. Jay, what do you say?
Yes.
Lens opposition. So we can see lot of fluid inside the lumen because G junction is very tight. So the fluid is not going inside the gastric side. It's accumulating in the esophageal side.
So you want to go to the left side towards the diverticulum?
Yes, sir. Yes, sir. Maybe slightly towards the left side.
Okay.
That way we can enter the, we can identify our septum.
But that will be a very wide submucosal dissection for you.
Maybe wider tunnel, yes.
Yes.
We are switching on to room number 3. We got an interesting finding there. Dr. Sanjay, you are live.
Sanjay?
We have gone into the left duct again.
We can't see the image.
We will show you. There is actually a lesion here. Can you appreciate here? Can you appreciate there is a polypoidal lesion?
Yes, the moment you are entering the first time, we could see the polypoid lesion.
Yeah, this is it.
Yes. This is not the lesion. This is the clot. This is the lesion. So this one.
Can you appreciate?
Yes, we can.
Dr. Sanjay, what do you think on visual impression? It's a benign lesion or a malignant lesion?
We cannot say it's a polyp.
Because you see, it is oozing on touch and the surface is irregular. and some degree of nodularity, and maybe ulceration. I'm not
Only
very
thing
clear.
is that the appearance is more like a polyp, but yes, it could be malignant.
This is malignant.
Because
in my personal impression, it should be a malignancy because
Yeah,
when,
yeah.
when the common bile duct was nave, that time also there was a clot.
This is there.
It's a mass lesion.
Now you can say that it is. You can see that it is more. It's ulcerated also.
And what are the benign lesions of intrahepatic ducts?
No dysplasia.
What?
And papilloma sometimes, occasionally, but most of them turn out to be malignant.
Doesn't look like that.
They're
Doesn't
too
look like
big, too big.
Push. Yeah.
And it looks like a papillary projection also.
Yes.
Papillomatous आ गए.
एक ये, एक नीचे.
So in fact, now you can see many of them. Now we have gone little further.
Can it be intraductal IPMN?
Yeah, it is, and that is IP, MB. Yeah, it is possible. But we did not see much mucus while we were cannulating.
I'm taking the wire out.
Yeah. So this is a very interesting lesion. We'll take spy bite and brushing also later on.
लॉक कर लीजिए, तो बाहर ना आए, थोड़ा पुश कर लीजिए इसको, हल्का सा पुश कर लीजिए. Yes, हल्का सा पुश करके रखिएगा, एयर हटा दो.
So you bite first and then brush, or you brush first and then bite?
We'll first take spy bite, otherwise, it becomes very messy and we cannot take a brush. And we are already in with a spy scope, so we'll prefer to take a biopsy first.
Good. Wire ले लो. Spy bite दे दो. पानी.
Can we go back to the other room, please?
We'll just show you how spy bite functions in a minute or so, then you can leave us.
So first show Sanjay's hands, please. The endoscopy view, please. The endoscopy room view, please. Just zoom it.
We can switch to room number 1.
Now, Sanjay wants to show you spy bite.
Yeah, after he's taken a spy bite, we'll.
Can we zoom the endoscopy room view, please?
Wait.
No, you're getting to the other room. Sanjay.
Endoscopy
Yes.
room 3
Can you zoom it? Can we make it bigger?
This Boston image is, you cannot make it bigger, sir.
Inject.
Okay, no problem. No, earlier we had a bigger image of the endoscopy room.
देखिए, थोड़ा withdraw कीजिए सर. और पानी.
Flush. Yeah.
मैं बाहर नहीं आया अभी.
Spy bite आई नहीं अभी.
आपका पड़ रहा है. सर स्कोप को लॉन्ग लूप लीजिए.
Sanjay, we have been meddling for too long. You like to put in a stent?
Sorry?
We have been meddling for too long. You want to put in a stent after that?
Yeah, we will be definitely putting a stent.
सर आपका ये
In the
जाएगा.
left
आप
system.
लॉन्ग लूप लेना पड़ेगा सर. स्कोप को पुश कर लीजिए. स्कोप को.
Any study showing the stent is better than a stent is equal to or better than a nasobiliary drain for these lesions like the after spy?
No, I think stent is the standard management. NBD would be too temporary.
So then at least you can suck.
Dr. Sanjay, can you push your ERCP scope bit inside so that your position becomes stable?
नहीं जा रहा.
Put your ERCP scope more inside.
स्कोप को लॉन्ग लूप करिए.
Yeah, we are not saying N fast.
We can switch on to OT1 where
He'll remain stable once he's
So
inside.
the angle is
Vikas is there.
angulated. Right.
Because the diagnosis is achieved, in fact. Now it's just about taking a biopsy. We will have the biopsy processed also immediately. We'll let you know what it is. So there won't be any guessing.
करनी करेंगे इसको.
So
Over to you, Vikas.
Mukesh, here also you take a crush biopsy?
Well, sir, yes. I mean, if we are able to take a tissue easily.
Okay. The only thing is the tissue is small over here, very small over here.
Yeah, with the new kind of spy forceps, sir, the tissue, I mean, the volume of tissue is now reasonably okay, sir.
Yes.
कौन सा ही case है?
And then one of our DNB student is doing a thesis on, he's already run 700 cases, imprint versus crush. So we should be getting results by next 6 months to 1 year, some
So-
publication.
That's what Bhabiji said, that imprint is useful for lymphomatous lesions and crush better for squamous lesions.
Right, sir.
Hello, Dr. Vikas. I think we are already seeing a vessel. So how you make a decision, you'll use a coagrasper or you're going to tackle it with the TT knife only?
So if the diameter is less than the shaft of the knife, I will go with the coagulation. We can do force coagulation with the shaft of knife. But
Right.
here diameter is more than the shaft of the TT knife. So better to use.
It's a bigger vessel over here.
Bigger vessel.
So that's better to use.
Vikas, Samir this side.
Yeah.
When you have a big vessel crossing across, like just you did, would you like to do this coagulation at multiple points, closer to the muscle first, then go in the middle, and though, if need be, go to the mucosal side, or single point coagulation is good enough? Because what happens sometimes is you do one set of coagulation on the muscle side and it starts oozing.
Yeah.
So, and plus, when you coagulate, do you cut it always after? Because what we do is we cut the vessel once adequate coagulation has been done. So, do you think it's the right practice, or we can simply coagulate and leave it?
So you can do at 1 or 2 places. So my trick is I grab the vessel, then do the close coagulation. Then if it thinned and white out, then I will cut it. So yeah. Otherwise, still red vessel, I will coagulate at one more place.
Because sometimes it goes inside the muscle and starts oozing, then it becomes the problem.
Yes.
So,
Right. I think we are just going across the G junction.
Because, I mean, most of the people who innovated this procedure are using spray coagulation. If you see YouTube videos of Innov and all,
Yes, sir.
they do myotomy with the spray, they do tunneling with spray.
Yeah.
So what's your comment on this? And I see most of our national faculty who's doing third space all with forced coagulation. Any comment for this?
So the spray is a very high voltage current. So it delivers very high energy. So sometimes there is more charring, and I think there is, if the mucosa and muscle are close, especially in the tight areas, there is risk of mucosal injuries there. So force is a lesser energy current as compared to the close group.
And spray will be more widespread also.
Yes.
Yeah, one of our DNB student who passed out, he did a thesis on spray versus forced coagulation.
Yes, sir.
So we found that the time was less with spray coagulation and the collateral injury wasn't any significantly higher. So that was our observation out of some 70-80 patients.
Okay, sir. So, but I prefer using force, maybe.
I think it's a personal preference.
Personal preference.
Yeah, it's a personal preference. I agree. But I was only saying that I did work with Dr. Inovu when he was there. So he also uses spray only. But I see most of our Indian third space specialists insisting on forced coag.
Yes.
So Mukesh, I think now in the YO3, we have another mode for doing the dissection, that is the precise set.
Yes.
Yeah.
So which I think again is a very controlled cut, comparable to force, but I think you move even faster with the precise set with no or minimal bleeding.
Right.
Actually, precise has very low coagulation capability. So sometimes the small vessel may bleed.
because is there a possibility the patient had pneumatic dilation because there is a very narrow submucosal space?
No, there wasn't any pneumatic
There was
dilation
any
on this patient.
history.
It's a naive patient.
Yeah. So that's why we thought it looks like a type 3 based on the barium and the endoscopic picture.
Yeah.
Right.
For the information for the audience, tomorrow after 2 p.m., we are going to have a session by curator of Urbe. He is going to demonstrate about all these modes, which, when, how, and how much in a personal class, which will be taken at around 2:30 p.m. afternoon tomorrow. So all of those people who are keen on joining this can get their names written on the registration desk, or they can send a message to me, or they can write on the group. This is something which we usually lack.
So in this case, we had two goals. One is crossing the G junction, then searching for the septum. I think now we can see mucosa or muscle are getting very close and the tunnel is getting narrowed. I think we are going close to the high pressure zone.
So here your aim, Vikas, is still going to be going across the LES, or also you are trying to find where the diverticular septum is and possibly trying to tackle both of them during the myotomy part?
Yeah, the first goal is going across the G junction.
Okay.
And then secondly, then after that, we can try looking for the septum.
Okay.
For that, I think we have to do a dissection on the left side.
Right.
Jahir, what do you say?
Yeah, I think doing LES, right from the beginning, because right now, for example, last month there is a multi-center study published which compared poem versus only poem. So the important part is LES involved? Is LES tight or not? If LES is tight, that is good enough. No need to search for the diverticulum, nothing. It's like because we want to demonstrate poem is a different issue. But in reality, in practical, for all practical purposes, this patient is just going to do fine just with a routine poem.
Yeah.
So D poem is for those selected few where LES is not involved, non-achalasia spastic motility disorder, where we have to like include the septum because that may still be. So, because many times what happens is that if the tunnel goes a little sideways, then it's difficult to localize the septum. So, I have changed the practice of dealing only with those diverticulum which are associated with non-achalasia disorders, and rest of them where LES pressure is very high, IRP is very high. I simply cut the LES, and those patients, they do just fine, as good as if you do a poem.
I think we can see some aberrant fibers. It indicate
Yeah, aberrant longitudinal can be seen here, and I think this is the LES, right?
Yeah. So I will look.
Yeah, and the important thing is LES is a 3 to 4 centimeter transition zone. So it
Yes.
means that not a particular point can be labeled as LES. So LES is a zone. It's a 3 to 4 centimeter zone. So sparing LES, not sparing LES, they are all relative terms. Nobody knows how much LES he has cut because it's a 3 to 4 centimeter long. Some of a part of it is intrathoracic, a part of it is intra-abdominal.
Jahir, you can see this part is very tight. Yeah.
Yes, it's very tight, and that's the reason to believe that if
Yeah.
you release this part, even the diverticulum will become shallow.
Yeah. So I have to be very. Yeah. I have to be. So we have to be very careful here. Inject, inject, inject. So
Vikas Bhushan here. Any specific precautions you'll take at such tight areas?
Sir,
More injections or?
I'm injecting more and more solution and cutting fiber by fiber. We can see some septum there, Jahir. Can you see? I think we are close to the septum.
So it's I think you can dissect up and below both.
Yes, yes.
And that will guide you towards
out. You see, I am cutting.
IRP accurately reflect how tight you will be doing the tunneling maneuver of the coin.
So IRP reflects that whether LES is relaxing with swallow or not. So if it is not relaxing with swallow, that means that LES is at fault. So if LES is at fault, then that is the prime target. If IRP is absolutely normal, it means that with swallow, LES is relaxing and you don't need to concentrate on LES too much because that is not the area of pathology.
So someone in IRP of 25 versus 50.
Inject.
Prior to procedure, anticipate longer time while doing the procedure or not?
No. So that is something which I didn't find. Sometimes it's very tough to go even with an IRP of 18 or 20, and sometimes the scope goes very easily even if the IRP is 40 in 40s or 50s. So I think that correlation is a bit poor, imperfect, and that is the reason that it only tells it's relaxing or not. It does not tell you that it's very tight or it's very it's going to give you some problems during poem.
Perfect.
Now the tricky area, I have to go. Yeah.
Yeah, I think we can inject here and see if this expands well.
Yeah, I think we have to go on the right side. Out करो.
He's on the way.
Yes, yes. So I have to stay away from mucosa and very. I think Jahir, this is the intermuscular pain, I think.
Yes, yes,
Yeah,
yes,
yeah.
yes.
So if we go in this area, right side, we will go into
We
the
will go behind the muscle.
we will go in the wrong plane.
Yes, yes, yes. So I think right in the center is your.
Yeah, I think this is the right plane.
Yes, yes.
So here,
Because there is a hypertrophied bundle of muscle there, it's giving an impression as if we have a space behind also. I think as we go forward, clearing in that plane, things will become more clear.
yeah. So I have to enter this
Yeah,
area.
yeah, yes, yes.
Yeah. So trick is
Yeah, absolutely, absolutely fine.
inject,
Yes.
inject. Yeah.
Yes, this is the right.
Knife out. Dr. Bhushan, you can see that we are cutting very small amount of fiber and pulling back the knife.
Absolutely.
So that I stay away from the mucosa.
And he's using endocut at this point of time, which is also very important to note. Huh? Did you use endocut?
No, I use force only.
I think
Yeah, this is endocut, right?
Force.
Doctor,
Right force, yes.
yeah, Dr. Zahir. Vikas.
Sir.
So I was wondering, when you get into this kind of a situation, will it not be wise to do small myotomy and to create a space for yourself?
We can do that, but still we are able to go
As long as you can do, it's okay. Otherwise,
yeah, we can do small superficial myotomy.
yeah. And I mean, there was an abstract which we presented in that Gangaram meeting, which won a prize also. Coincidentally, we were lucky. We use anti-G spray in case if we want to demonstrate anti-G spray, it does really well in this situation.
Yes.
So Dr. Alok Verma is there. He can help you with that in case if you feel convinced with this.
Yeah, nasal spray, I think we can.
Nasal spray. We do it and it really helps a lot.
Yeah. Dr. Alok, can anti-G spray?
Yeah.
Alok?
But I think Dr. Vikas is like, he's a super human being, super endoscopist.
There's the advantage of having people like him.
No, it's all.
He is beyond drugs.
No.
And he's already in a phase of crossing it because
Yes. And the tunnel is getting wider now.
I think when you have stalwarts like he's standing behind you.
I think
Yeah,
Mukesh
holding
has
your
a
hand.
special love for Vikas, I guess.
So sometimes a conical cap from Fuji helps in these situations where you can negotiate that cap. But see, as he's doesn't require a special cap, doesn't require a cylindrical cap will do the job, I guess.
I think you need special friends.
Zahir, for the knowledge of audience, will you kindly tell us that how do you say that the tunnel is over now and there is adequate tunnel done for the patient?
So towards the gastric side?
Yeah, I mean, when we say that, how can we say that when you're doing a poem, we have reached into the gastric side, like the kind of vessels and.
Right. So we can see towards the left, we have palisading vessels.
Yes.
Palisading vessels end at the lower end of gastroesophageal junction. The moment palisading vessels end and we enter into the stomach, we start seeing spindle-shaped vessels. Having said that, in some scenarios where there is a lot of submucosal fibrosis and planes are not clear, you can miss these vessels, especially the spindle vessels on the gastric side. Once you cross it, you find a wider space. That is another hint. Second, we get two penetrating vessels. The second penetrating vessel, they are constant in say 90% on 90% of the occasions you are able to see them. But it all again also depends whether you made your tunnel is at 5 o'clock or your tunnel is at 3 o'clock, which sometimes happens on the way to your G junction. So those two vessels, the second vessel marks at least 2.5 centimeter of tunnel across gastroesophageal junction. The traditional markers that you see, the blanching in a retroflex position, I think it's quite inaccurate because, for example, he just injected here and the blanching has already occurred on the gastric, but still we need to go for at least. Now you can start seeing the spindle-shaped vessel on the right. I think spindle-shaped vessels is a sure shot marker of entering into.
Yes.
So these are now spindle-shaped vessels, and now we are into the wider part of
Yes. Yeah.
a tunnel. So such a tight G junction, and I believe that deep poem, if you do, it will serve a cosmetic purpose. It's not for the like symptomatic relief. Here you see, I guess this might be the first penetrating vessel that you see here. And as per my experience, on 80% of the occasions, after a few millimeters, you'll find the second penetrating vessel.
I mean, is it like coming out and going and checking the G junction if it is adequately relaxed?
I think that's not required, because again, coming out and checking means you are checking the blanching of that works well to some extent in the esophagus, but this solution, what you inject, it reaches at least a centimeter beyond. So if only that blanching is seen as a marker of crossing G junction, I think that may lead to inaccurate measurement of this thing.
So Dr. Mali, these are the small vessel. Here we are coagulating with the knife only and using the.
This doesn't look like a typical bifid vessel which we see the penetrating.
So the second vessel is usually a bifid vessel. The second penetrating one. The first penetrating may not be a bifid vessel, and sometimes we do mistake. We get three vessels instead of two penetrating vessel. We see one more vessel beyond it. So my this thing to identify the second penetrating is second penetrating vessel forms a perfect boundary between sling fibers and circular fibers. And it never happens, it never crosses that boundary. So that is another marker that when you see the second penetrating vessel, yeah, that can be an. I think he has already gone well inside.
Yes. Because we can see spindle vessel there. These are the spindle shaped vessels.
Yes.
On the right side, we can see these are spindle shaped.
So, Pankaj, after, I mean, because of altered anatomy in room number 3, Sanjay and the team were struggling with cholangioscopy, but they finally were able to take out the polyp biopsy, adequate amount, and we're waiting for the cytology report. So, can we switch on to room number 3 for just a moment? Sanjay, you're there.
Hi, so fine. Hello.
Yeah.
So can you see the cholangiogram now?
Yeah, we can see the cholangiogram.
Yeah, there is a dilated duct with a narrowing at the hila. You
Right.
can appreciate that. We have taken a tissue from there and we got a good chunk of tissue. It's almost like removing a part of the polyp. We'll just show you that.
Yes.
So, yeah, can you focus on this? We got 2 chunks of tissue.
Yeah.
Zoom.
Make it bigger, na? सुनो इसको बड़ा करो. Kindly show the picture. The tissue size was reasonably good, and congratulations to 3 Sanjays, Sanjay Rajput, Sanjay Kumar, and Sanjay Khanna for having done this job wonderfully well. Because you know this is altered anatomy and it can be a struggle sometimes. And Mr. Ramveer, I have become a friend with Mr. Ramveer. He's a technician at Sanjay Khanna. But he's too good a guy and he really makes very knowledgeable comments. So we can go on to
नहीं I don't नीचे का end sir आपका mucosal tunneling हुई है. We want a straight and without pigs. 10-15 नहीं.
Yeah, over to you because we are back here.
Sir, we are in the stomach.
Yeah.
And we can see some blanching along the G junction here.
Yes.
So I think we have entered in the gastric side. So the next point is whether we should go towards the diverticulum or we should do just a conventional poem. So Jahir is convinced that we should do a conventional poem only. That should relieve the dysphagia. So what we will go by what the master say. So Dr. Mukesh, you can see this is a high pressure area here.
Yes, yes, yes.
And
Yeah, that's evident.
It's very tight, very tight.
Very
so it's a long segment of high pressure area.
Correct.
So this can never
So
be
if we-
tackled with the balloon, and there is high risk of perforation when we use a balloon here and wait for the obliteration of the waist. And I expect quite a thick muscle in this patient. So sometimes it's become difficult to enter the tunnel. Then one can bring the tunnel in the upper part of screen, and that way the entry becomes easier.
And this has opened the diverticular thing also wide open, I guess. So
So you want to do the deep poem also in this case.
no, I mean that's what I think. Conventional poem.
So in the area of diverticulum, we can see a very high pressure zone. Jai, what do you say?
Yeah. At the moment we cut the LES, we are going to go again and see how things look then. I feel things will look markedly different, and the path of least resistance will change from the diverticulum to, of course, there will be small amount of fluid and all going there, but then there will be so less resistance at LES that food will tend to preferentially go into the stomach and not into the diverticulum, which is now the case, right now the case, because LES is so tight that the food preferentially goes into the diverticulum. But once we change that, the path of least resistance, I think things will be much different.
Yeah, you're right.
Because why can't we see a diverticulum in this tunnel?
Because the tunnel is a little more towards the right.
Okay.
Right. And the diverticulum is maybe a centimeter or more towards the left. And in order to reach the diverticulum, we have to do a little more dissection on the left and then reach the septum and then finally cut the septum.
You see, there was an observation when Vikas was making the injection right at the beginning. So what happened was he injected at 5 o'clock, and when he ended the injection, his needle was at 9 o'clock. But once he made an incision, it was at 3 o'clock. So that is why it has gone into 3. He never observed that his needle, when he injected, the entire bleb moved from 5 o'clock to 9 o'clock. So that is how probably we don't see a septum here.
So if we have to expose septum, we have to do dissect on the left side, and we have to dissect on both the sides of the septum. Only then we can expose the diverticulum.
Yeah, Vikas, Monish has initiated a very good discussion because we have many young people in the line. So when you're making a tunnel, how do you ensure that your tunnel's direction and the line is straight? So you're not lost towards left or towards right?
Sir, maybe you can mark with the soft coagulation because it's a non-dilated esophagus. In that, sometimes this problem may arise. So otherwise, what you can do, you with the soft coagulation, you can mark the line of incision. Out. So you can see it's a very thick muscle.
Another trick is to inject, say, 5 to 7 ml, and just enough so that the lumen, the esophageal lumen, is in constant view. Sometimes what happens is the injection will compromise the esophageal lumen. The bleb is touching the opposite esophageal wall. That may sometimes hinder your direction, but I think the direction is perfect here. I never, in this case, I never intended to do a deep OM, which is I think a procedure more for cosmetic importance in these cases where LES is so tight. So anyway, even if it's at 4 o'clock or 5 o'clock, I don't think that. Sometimes during myotomy, you may find it a little more challenging to keep the direction of myotomy exactly in the center of that muscle bundle. But I think with experts like Dr. Vikas, doesn't matter anymore.
I think it's a very thick muscle here. We are in between the circular and the longitudinal. And when we are doing myotomy, we should keep the plane vertical. So we can see the plane. So this is the longitudinal layer below, and this is above. This is the circular. We'll push our knife between these two layers, and now I'm keeping the line of dissection vertical, so that it cuts the septum vertically.
Because my practice while doing a submucosal tunneling is to stay at 90 degrees along the circular muscle.
Yes, sir.
So that you don't get lost. Sometimes, you know, in my earlier days, when we used to start at 6 o'clock and we used to, you know, by the time you reach the GE junction, you deviate to 3 o'clock, 4 o'clock.
Yes, sir.
So that is what I used to do because we have almost like more than 100
Yes, sir.
young people in the crowd.
So that situation occur when you have a sigmoid esophagus. If it's a dilated esophagus, that problem may arise.
Yes.
So in those cases, one can go perpendicular to the circular muscle.
Right.
It will guide you towards the G junction.
So your choice is to do a full thickness myotomy or a circular myotomy only.
I think both are same. So if you do the only circular myotomy, you can avoid injury to the periesophageal tissue.
Right.
There will be less chance of air leakage, and sometimes there can be nerve injury also. That can also be avoided.
I think Dr. Vikas has published in Video GI recently how to identify and prevent diaphragmatic injury.
Yes. I
think very useful and very educating video.
So if you go beyond the longitudinal muscle, sometimes you can injure diaphragm also, especially at the G junction.
So diaphragm typically looks like a
more
is
pink,
a thick,
more
brownish,
more pink,
dark red
yes.
Bundle, and sometimes you feel that you have cut both, but still there is some muscle left behind. Okay. The moment you hit it, it starts twitching, and
Okay.
you start doubting that what is this muscle like?
Yeah.
Zahir, one question to you. Let's suppose this is not an ecclesia, but it is a jackhammer with a diverticulum. Then you will make a tunnel in the line of diverticulum, or what you're going to do? Let's suppose now it is 8 o'clock. We have gone from 5 o'clock. So what should be, where should be making your tunnel in that case?
So even in that case, it's very important to look at the manometry and see correlate your endoscopy with the manometry. Till what point is the high pressure zone extending? Now there are two variants of jackhammer esophagus. One variant of jackhammer esophagus, which is say 10 to 20% cases of jackhammer esophagus, they have LES involvement as well. And 80% of them, jackhammer esophagus cases, they don't have LES involvement. Now, if there is a high pressure zone below the diverticulum, now the issue is, if there is a high pressure zone below the diverticulum, the moment you cut that high pressure zone, irrespective of whether you cut the diverticular septum or not, it's going to give you relief. Most of the diverticulae, they fortunately, they come at places where esophageal wall is rather weak, and you won't find a outpouching along anterior esophagus. So I've never seen a big diverticulum or epiphrenic diverticulum along the anterior wall of esophagus, which makes things a little more trickier if you are used to posterior poems only. So, for example, in this case, because the intention was, okay, we'll see later on whether we need to cut the septum or not. We never intended always to cut the septum. So our tunnel is a little towards more right. So if we had intentions, then we would have strongly considered making or extending the tunnel more towards left. And it never happens that you don't encounter the septum during. But whether it's required or not, that's being seriously questioned now in multiple studies, that whether a simple poem is good enough, even in cases with the jackhammer and DES. But because jackhammer and DES, LES is not involved, and sometimes the diverticula are very big. So if the diverticulum is more than 2 centimeter, I always include that in non-ecclesia spastic motility disorders.
But your myotomy should extend beyond the diverticulum always.
Yeah, it should always extend beyond, because the high pressure zone is beyond the diverticulum.
Zahir, can you kindly elaborate about blowout myotomy and which, when, how does it happen, and what to do in that particular situation? And how do you follow up these patients post procedure?
Yes. So I think blown out myotomy has been blown out of proportion. Its real impact has not been studied, but what patients come to me, those who have an outpouching, there is no standardized definition for blown out myotomy. And to what extent the mucosa, some outpouching may occur in a large proportion of cases, because that part of esophageal wall is already weakened, it does not have the support of muscle. Should we call that a blown out myotomy? Or there have been few definitions proposed that if you use that definition, long myotomy has been proposed as one of the risk factors for blown out myotomy. GERD happens more frequently in patients who have blown out myotomy, and the reason being that pouch, the clearance of acid is relatively slow from that particular pouch. So to follow these patients, do these patients require treatment? If their ECARD is 3 or less, I don't do anything. You can just follow them quietly. But in some cases, you can find a hypertrophic bundle of muscle just at the edge of that blown out myotomy, and which does suggest that probably the LES myotomy was not sufficient. So in those cases, if the symptoms are or the card is more than 3, I post them for a short myotomy where my intention is to release, to reduce the pressure at LES, and in case I can include that septum, I include that septum as
Airway
well.
pressure okay, no?
Yeah, I'll take 2 minutes. That cholangioscopy patient has been given an answer on the histopathology. We'll just switch over to Dr. Komal for a moment. Before we go back to GJ.
Out.
Room number 1.
Knife out.
Yeah.
खतरा मसल है इसकी नहीं? खतरा की मसल है इसकी यार. इसके
Yeah, Dr. Komal, you're over. Kindly tell us about what was your finding.
थोड़ा साइज बड़ा कर दें सर सामने भी दिख रहा है लेकिन वो थोड़ा फ्लोरो आ रहा है मैं इसमें ही देख
We
लूं।
can see, Dr.
हाँ,
Komal, you can quickly tell us your
कैमरा
finding
किधर है?
because we need to move to other OT.
कैमरा
So
इस साइड
here
आएगा ना?
I have got is adenoma, which has a mild dysplasia. So if you look at this cluster of cells, this is a very regular cluster of monomorphic cells here. They are lying like bricks in a single line. They are not overlapping each other. They are very, very uniform in size.
Okay.
There is no pleomorphism. The only thing is that there is some kind of a hyperplasia here and a very little amount of variation in their size. So this is an adenoma with a mild dysplasia.
All right. Thank you, Dr. Komal. So now we switch on to OT number 2, where Dr.
Yes, sir. Of course, we are going to confirm it with the histopathology. But since we do a overnight biopsy, the histopathology will be ready by tomorrow. So we, in cases where we are suspecting adenoma with just a dysplasia, so we are going to release the report only after we confirm it with the biopsy tomorrow.
Yeah, this was for the meeting, sir. Otherwise, spy by it. Then we had good 2-3 pieces. So we subjected one piece for the crush cytology and we kept 2 other pieces for the histopathology. Right. So we move on to OT number 2, where Dr. Sandeep is ready with endoscopic GJ, USGJ. So we'll come back to you, Vikas.
Sir.
So we go to. So prior to this, we want to present a case.
This is a 68-year-old female. Came with us with progressive jaundice and pruritus since 1 month and recurrent vomiting since 10 days. Upper GI endoscopy, in upper GI endoscopy found duodenal growth with luminal narrowing, and in biopsy we found adenocarcinoma. CCT abdomen and MRCP abdomen suggestive of duodenal wall thickening, dilated CBD and ISBRD and liver metastasis. Now patient's bilirubin is 20 milligram per deciliter and L4 is significantly high 1500 international per liter. So we plan for this patient USGJ and SGS versus TTD. This is endoscopic image. Showed tight stricture at growth and stricture at D1. And this is CT report, CT film suggestive of duodenal growth. This is MRCP suggestive.
So we move on to OT2, where Dr. Sandeep Laktakia is there. He's going to tell us he has already placed the e-pass balloon. So for the information of audience, we have two gastrojejunostomies, one e-pass balloon, one free hand. So you'll be able to appreciate how GJ is done through free hand technique and GJ is done through e-pass balloon.
हाँ कोई बात नहीं, हम 100 तक जा सकते हैं आराम से, और डालो.
Yeah, Dr. Sandeep.
हाँ.
Yeah.
Hello.
Yeah, Sandeep, you're on air now.
Okay, can you see me?
Yes, you will be seen as well.
I got.
We don't know where
Where
camera
to
is.
look at? Where is the camera? Okay. So before we came on the screen, we did a few. Okay. I don't know whom to speak to, so that's why I was. Okay. So before we came on the scene and we did some work behind as a team, I would like to let you know, to save time, what we did. So me, Radhika, Pankaj and the entire team, what we did was intubate the patient. Patient is having duodenal obstruction because of malignancy. She's in a supine position, intubated. The airways are intubated. Then we passed. Okay.
It's done. हो गया? Okay. So they were arranging for quadrille.
So we are using the e-pass balloon or a double balloon, which makes the procedure very safe. I know many people can do EUSGJ as freehand technique and effectively with best results. But if there is a complication of perforation, then that's a disaster. We can manage some of the complications, but if it's a type 3 complication, where means that we have punctured the stomach, punctured the jejunum, but the stent does not get deployed, then it requires often a surgery. These patients are sick, have advanced malignancy, and we do not want a surgery. So that's why e-pass balloon is used, which is a double balloon. This, if you have the fluoroscope image there, can we have a little silence in the room? Thank you.
इनको शांत बिठा दें.
Yes.
ला कर रहे हैं. Okay, I think they have done. They are just attaching the quadriceps.
Okay, Samir, the question was how easy it is to pass the balloon. I think it's fairly easy. It requires a few extra things, which like an overtube, which is the overtube of the short enteroscope, through which we pass a forward-wing endoscope. The whole assembly goes inside like one unit. You take the endoscope tip up to the pylorus, just proximal
सामने
to the
ये आ रहा है, वो नहीं
obstruction.
जा रहा है ना उधर.
Pass the guide wire across the obstruction deep inside beyond the DJ flexure. So that was done with an overtube. The purpose of overtube is to prevent any coiling in the stomach. This, if the cameraman can focus here, I have the Chodiamma. Anyway, I don't know whether you can see. It's this tube is a very floppy tube. If I pass it just over the guide wire, it will coil in the stomach. So the purpose of overtube is to prevent any kind of looping in the stomach. If the camera if the cameraman can focus on these things, there are this oroenteric tube. Radhika, this overenteric tube. This is the overtube. Yes, please. No problem. If the guide wire can go, then we can either put a duodenal stent and do all these things.
So it took about 15 minutes us to get things ready. We are all set now. So I just wanted to show the 4 tubes here, the 4 channels. The 2 orange channels are to inflate the 2 balloons. The middle challenge is filling the area between the 2 balloons, which are 20 centimeters apart from each other. So the loop is trapped between the 2 balloons, and the water, saline, contrast, coloring agent, which gets filled in between. We have filled it with about 80 cc of the solution. This is the guide wire which has allowed us to go over it. Once we have done it, do you have the fluoroscope image there in the room? Samir, do you have the? No. So you can see there are 2 balloons on the screen, which are filled with contrast. Can you see that? Samir, can you appreciate? So that's the whole purpose. So we have trapped a loop of jejunum which is free floating using this device. I'll answer that. Let me just complete and then I will answer so that it makes it understanding for everybody is different in the hall. So the trapped loop is now a fixed loop with a fluid inside, which is like a pseudocyst. We will now puncture from the stomach into this collection using a hot axios 20 millimeters. Now please ask. Okay. So I have a very good position on the fluoroscopy. If you see the fluoroscopy image, the 2 balloons, the one which is close to the tip of the scope is the back balloon, and the other one is a forward balloon. So we don't want a horizontal loop. We want a vertical loop of jejunum. If we get a vertical loop, that's a perfect situation. And this is what we want. It's a C-shaped balloon, reverse C. That's what we want. So that we have a good landing space for the stent assembly to go in. If it's a horizontal and perpendicular to the axis of the scope, then we have a very short landing space of 2 or 3 centimeters, which does not allow, and that is a cause for some of the complications. Clear? So let's move forward. We have a perfect anesthesia. The patient is comfortable. All the vitals are stable. We are all quiet in the room and watching. She has received Buscopan to just paralyze the bowel, which we also use for free hand. And now I'm rotating my EOS scope. You do have the EOS image there? Flora. Radhika, Flora. So now we see a loop of bowel, which is, can you inject some more saline there? So already 80 cc approximately has gone. We can go to 100 to 120 cc. Do you have the pointer? So this is the loop, which is a target. The arrow is pointing that loop. And the movement of the fluid is happening as he is injecting. This is little bit of momentum. The white thing is momentum, which we will traverse. I would also look at Radhika, very rightly pointed out just before, is there colon interposing? Sometimes the colon can be collapsed and can somewhere be here. We may sometimes go through a colon accidentally. So we should remove all the bowels away from each other. Even a collapsed bowel should be seen carefully. Okay, now we're ready. Stent is ready. We all set. Where is the foot pedal of mine? Yeah. So see, there's a very good landing space. Samir, you're happy with that? So if I can measure this.
Can we see the fluoro image?
So we have the landing space from here where the X is there, almost this much. 6 centimeters is a very good landing space. Anything above 4 is perfect. So this is so there are 2 hot axios which are used for GJ, and I want the control on myself. So we use 15 or 20. 20 is better. The wider the stent, the more bigger the GJ is, and better the patient can eat. This has been shown in some of the publications too. I'll now put out the stent out, which is coming on the right side of the screen. If I can get Radhika here. Okay, no problem. So that's the tip of the stent here. I will park it in the D arrow, and you can put some more water there. हाँ कोई बात नहीं, कोई बात नहीं. Yes, please. Suppose if I was not getting the ideal loop, then I would have used compression. Is it blue or yellow? No. So I'll now burn my way in. All set, Chaudhary? Okay, I'm in.
We are in the longitudinal axis of the bowel.
So you saw that I have now gone inside with the assembly. I should have used the fluoro. Okay, that's okay. हटा दो, Chaudhary, हटा दो. No, I am quite deep in Radhika. You see that the tip of my, so Radhika is little concerned, and rightly so. The tip is somewhere here, which is quite deep in. And if I see the assembly, look at this, you see it here with the camera. This is a very short space, so I am quite deep in. I will not deploy the distal flange. So that's the flange which is deployed. Samir, you are happy with that? Okay, I'll pull back little bit, deform the distal flange so that it comes back. Now I will lock the distal flange, deploy the proximal flange in the channel of the scope, which I have done. And then I will now, yes, we will show you. Can you have the bigger endoscopy view? ऐसे यहाँ से करो. Samir is very excited and so am I. And I'll now pull back the scope. Fluoro. So you see the metal tip here?
Yeah, we can.
Okay. So if you have the fluoro on, contrast, we'll see the contrast. Fluoro on, contrast. Adhika? No, it's not frozen. Okay. So if you see the contrast coming through the stent, that means the position is perfect. All done. So quadri setting is very standard that we use for even pseudocyst drainage, and for hot axios, which is 100 pure cut or even more, setting 5, effect 5. This was not very blue, otherwise I would have seen blue color coming out. Now you can deflate this. दोनों deflate. Now everybody wants to see whether the position is correct or not, and so am I. We want to be doubly sure. What we will do is we will peep through the endoscope, through the stent into the jejunal. I think this is NBI mode. That's why it's not looking blue. That's why I said blue color is not coming. Why? Lot of fluid will come out, so I'll keep sucking out, because as the patient gets extubated, it should not cause an aspiration in the patient. Dr. Mishra rightly pointed out that yes, we need to sometimes press the bowel, get the right loop in orientation, in case we're not getting a perfect loop, which sometimes happens with malrotation or some loops. Every duodenum is different actually. After we started doing GJ, we found that there's more malrotation than actually reported in literature. I think about 25% of the patients will have some duodenal abnormality from the perspective of the morphological anatomy. Sorry, sir, I'm not able to hear you well. Can you just...
When patient survival is...
Absolutely. That's a very important point. It should not happen that once we have decided to do GJ, just do it. If the patient has metastasis in the peritoneum or malignant ascites, or there is tumor infiltration in the stomach, for example, in lanitus plastica or CS stomach, it is better to put a duodenal stent because they have a shorter survival. So anybody who has likelihood of survival of 1 month or less, it is better to put a duodenal stent. Those who have a good quality life or are ECOG grade 0 or 1 are I think the ideal candidate. Like this lady, she walked in, so which is a very good sign, and she's able to take care of her own work. Okay, deflate. Okay. So while I am sucking out the fluid, the balloons are getting deflated, and We'll pull back under fluoron. You see the balloon I'm pulling back, I'll pull back. Okay, it's now. I still want to see the stent and gauze piece. Gauze piece रखेंगे? Sorry? No, stent नहीं लेगा. I don't want to dilate the balloon as Samir you asked. So this is the gastric end of the stent. Sometimes we get a good view across the stent lumen into the, which I'm trying to do now. You have a view inside, but it's still dark. Can you have the maximum light here now? You light बढ़ाओ, maximum कर दो. And we can often see the tube or a guide wire in the jejunum while I am peeping through this. I think going inside means I have to dilate, and each dilation also has its own risk of stent malposition. So I will not dilate, let the stent expand, which will take 4-5 days. We can start liquids today itself in this patient. So he has biliary obstruction too. I think we'll tackle that. Radhika is there with me and she is ready to fire the biliary stent.
Dr. Sandeep, what is the dietary advice? Is it advisable to give low fiber soft diet?
Of course, yeah.
Normal diet because whatever said in terms, 10 calories to 20 meters. So low fiber diet, but you should.
It is always preferred, yes. So I would start with the water, juices, clear liquids today, and maybe thick soup and puree-like material tomorrow, day after, and then she can take non-fibrous foods, non-leafy material over next few days. She can start off. We can take it out, I think. Fluoro on. So I'll pull out the tube now. So all the assembly is out. Only thing that this is oblique wing endoscope, is a US scope, and that's why we don't have a peep inside. If somebody has a doubt, you can actually go in and peep and see that. But I think it's
Canada and do entogram
So-
if you want to confirm, but basically
so we're not doing that because we saw the contrast which was trapped between the two balloons coming out on the real-time fluoroscopy. So that confirms. Blue color also helps. Unfortunately, we had the NBI light on, and that's why we could not see that, appreciate that well. But I am quite confident that this position is perfect. We just go ahead with the jejunal, the biliary drainage part of it. Okay.
Thank you.
Thank you. Yes. US. US. That's what we are doing. We don't do the biliary stenting now. So we're looking at the liver now. The left lobe of the liver, which is visible on the screen, has not much of IHBRD peripherally, but as I pull back and turn, this is the central part where the arrow is. This is a little more dilated. Radhika, this will be nice. So we can do from here. Yeah, so this is segment 3 duct, which we can puncture from here. But you'll also look at the duodenum, although I would prefer to do an HGS in this patient rather than choledochoduodenoscopy because we want to stay away from the tumor. So, but anyway, we'll just have a good look at the duodenum. So that's the, okay, so we have the gallbladder, which is distended, which is another area of a drainage. It's like a pseudocyst drainage, which is more fixed. We don't need anything for that. So there are options, more than one option available. No, that's true. I still prefer. In some situations, you don't get the favorable biliary anatomy for puncture. And you see the stomach from between the gallbladder is such a juicy organ here now at this point of time. And surgeons were doing gallbladder drainage earlier as one of the options of malignant biliary obstruction when nothing else could be done as a palliative procedure. So this also remains provided the cystic duct is patent. But we'll just spend a little bit time and see what's going on where. That's a gall. So that's the duodenum. Do we have the bile duct? This is all tumor here. Tumor. So I will not consider, I think duodenum is mostly out. One, we don't have a very nicely dilated CBD. This is all gallbladder. This is the gallbladder. which we can drain from the duodenum, and that's a small lamps can be placed. But I think I would prefer, as Samir said, to do an HGS because bile duct is more dilated above in the intrahepatic side. Okay, Radhika. So it's all yours now. I'll stand behind you.
Good afternoon, everyone. You have already heard the history and as well as the demonstration of left liver lobe. So this is left lobe.
Sandeep, what is the choice?
I'm sorry, sir.
Doing a drainage from the liver or
Sir,
doing a
so
gallbladder
liver.
drainage?
So we're doing an HGS.
Which is easier and better?
Okay, so the if the bile duct in the liver, that intrahepatic ducts are dilated well, that's a good target. But CDS is much easier. It's very easy. It's a fixed organ there next to duodenum. But as the tumor is just at the D2, the bile duct, it will get blocked. That stent can get blocked. And the food can go through the stent like a some syndrome. How to?
Avoid segment 2.
There are two ways. Either you can mark a G junction with a clip or with an endoson also you can see the position on a fluoro, whether it is below the diaphragm or not. That is two way you can identify that you are not puncturing the esophagus. So
Yes.
for HGS, the biliary.
Yeah. Radhika, we'll come back to you soon. We are going to the other room because
sir.
the case
Okay.
is getting finalized. So shift to Vikas room. Yeah, we are
Contrast
coming
डाल देना
back.
नहीं तो खराब हो जाएगा.
We
थोड़ा
go to the
saline-
other room.
saline डाल के
Dr. Vikas Singla is doing. Yes.
Yeah.
Now we are.
Yes, Vikas, you're on.
Sir, we are in the tunnel now and we have completed the myotomy. You can see that on the esophageal side muscle is very thick. You can, on the left side, you can see it's very thick muscle. And this is the tight area and we have gone beyond and this is the end of myotomy. So once we finished the myotomy and went towards the luminal side, there is total giveaway. So initially we were not able to enter the G junction. Now once we are going in, we can see there is loss of resistance. Now the scope is going easily inside. Earlier, even with the force, we were not able to enter the G junction. Now with the minimal pressure, it's going inside. So I don't think there is any doubt that this patient should benefit with the myotomy. There should be significant relief of dysphagia. So now we are able to go very easily.
What was the length of myotomy?
So it's around 10 centimeter esophageal and 2 centimeter gastric myotomy.
So longer myotomy.
Longer myotomy, sir. And I want to show you diverticulum also. So earlier the scope was going towards the diverticulum. When we were pushing inside, we were going more towards the diverticulum. Now you see, now it's going, its natural movement is towards the G junction.
Lumen.
So earlier it was going towards the diverticulum, and even with the force, we were not able to go across G junction.
Yes, perfectly right.
Yeah.
Myotomy has worked.
Yeah, definitely, sir. I don't think there is any doubt in this room that
yes.
patient should benefit with the poem procedure.
And this patient had a very tight and a very long LES, which was almost, I believe, 3 to 4 centimeters.
Yes.
And now with relief of pressure,
and
so even the gastric mucosa is literally pouting now from the esophageal side.
And we can see mucosa is intact.
Yes.
Excellent.
There is no coagulation injury on the mucosa.
Diverticular was secondary to the tight ecclesia.
Yes, sir, definitely. So we have treated the primary etiology, and so that should relieve the symptoms.
So I think big round of applause in the audience for
Excellent,
Vikas.
excellent demonstration,
job
Vikas.
done.
Thank you, sir. Thank you. Thank
One of the
Thank you,
very
Vikas.
difficult,
Now we
excellent.
shift back to Radhika.
Radhika, you're on.
देना है को देना नाइफ देना नहीं वो उसमें कराना है ये तो कट गया ना सारा ये वाला है ना ढेर कुछ करना तो नहीं माइट में और
Dr. Radhika, can you hear us there?
ये वाला
Sorry?
Sir, is there a liver met around the site of puncture where
There are several liver mets, and that's a
Yeah.
very important. I'm glad that you picked it up. I think kudos to the person who pointed it out. that these are liver mets and one has to be wakes. This is a liver, just turn around, turn. Let us show to the audience how the this is a liver met.
Yeah, that's a hypo.
Okay.
Yeah.
And there are several of them all over. So we have to be careful.
That is
not
why
to
we
go-
wanted you all to wait for the puncture actually.
Can we enlarge the
Yeah.
US image? Dr. Sandeep, can we enlarge the US image?
Okay.
This is a segment 3 duct, which is running
Enlarge the
from
US image. I think that will be better here.
So this is big, very big. You have the US image there on the screen, hall.
No, we have a smaller image. We
I
want
think
it
so
to be
the transmitting person has to do that because we have a already maximized view in the room.
fluoro position, please.
no,
So this
हम
is
ही
segment
करेंगे.
3 duct, which is running from left upper quadrant to
we are seeing some other case. Can we switch to a US case? Yeah, that's fine.
This is also a good position.
Okay.
Avoiding the tumor. We should avoid the tumor on the way.
19 gauge needle, please. So this is segment 3. This
But
is
Sandeep,
segment
if you
2,
don't
and
have a
this
way
is
out,
their-
you have to go through the tumor, whether it gets blocked after some time or not. It will
So
block.
in that case, sir, if we have to go through the tumor, we should try to manipulate the wire across the lower end of the biliary obstruction and try to take the wire across and do an antegrade stenting.
Okay.
Then a stent will not remain. It's only for the puncture, but the stent will not be hitting the metastasis because that can bleed. Sometimes can cause more issues.
So there are 2 points I want to highlight here. Whenever you are doing a HGS, you should see for IHBR dilatation more than 5 mm is considered as a ideal, and you should look for a intervening parenchyma. If the distance is between 25 to 30 mm, then it is ideal. So here you can see 29.3 mm, so less than 3 centimeter.
Okay, good.
Dr. Sandeep,
think
any
Radhika-
specific choice for needle? Any specific choice, especially for HGS, where chances of sharing is much higher with a guide wire because you may need to go repeatedly with the guide wire in and out. Would you prefer any specific needle for this? HGS or any 19 gauge needle will do?
Radhika, is there any angle that you have to choose between that you are trying to?
So it has to be parallel, not to be perpendicular with the bile duct.
But that's not always a foolproof mechanism. I know it's theoretical that if you have the aligned duct, then you can go. But here it's almost perpendicular to the long end.
Sandeep, is there something inside the bile duct? I mean, the intrahepatic duct? Yeah, I feel there is a mass inside.
There's a vessel just below that. Doppler, Doppler.
Doppler is there. Doppler. Take out the Doppler. Okay. So
Just be inside the duct. Just be inside the duct. Don't overshoot. I think you're across. Okay. You're in.
Still it pull. Still it push. Push kar. Okay.
Oh, okay.
Fluoro,
Okay.
fluoro.
So I didn't notice that.
Fluoro.
I would never use a stylet to puncture. The needle should be primed with contrast always.
Okay.
I did not notice that. Yeah.
Aspirate bile. Yes, sir. Bile came, sir.
Okay. So bile has come. Stop.
10 ml.
Okay.
Aspirate 10 ml.
Okay. I think that should be good enough. That should be good enough.
Okay. Now inject the contrast.
Always use a three-way. So there one important point over here that if you use a three-way, then air will not go in. Now they have a contrast is loaded.
Contrast.
Okay. Good.
Fluoro. Sir.
Is there any amount of bile that you want to aspirate before?
Actually 5 to 10 ml. Okay. Now
This is air going in, which is not a very good thing to happen. But anyway, we'll follow the duct. Okay, so that you see the hilum is patent. I think now it's you can. There's a very nice picture. I think stop. Don't put more. Don't put more. I think get the guide wire, angled guide wire, because this is a very U-shaped turn, angle thermo.
Okay.
Which wire you will use?
We'll use a thermo angled short wire.
O2
that
5.
O2 5.
Yeah.
5.
Sir, hydrophilic oil?
वो shear
With
हो जाएगा।
O2 5.
Whichever you want, whichever comfortable. Angled है कि नहीं है? No, it's a straight wire. No, we need an angled wire because it has to take that curve.
Actually, I prefer a guide wire with a hydrophilic tip, sir.
That's okay. Any hydrophilic wire has to be used. it can be short or a long wire. The purpose is that it should go to the area we want it to go into the common bile duct basically. And as you see the anatomy on the fluoro, it's taking an upward trend.
Dr. Sandeep, would you like to prefer an angle tip wire because the angle is going to cause problem. So instead of taking a straight tip, anyway, most of the time
using an angled wire only.
most of the time we prefer angle tip. Anyway, in such procedures.
Radhika, you are happy with the puncture site and
It's
position?
going peripherally. That's कोई बात नहीं.
थोड़ा withdraw करके 1 minute.
And too much exchange here of the wire sometimes can shear it, and that's and again a small disaster which we don't want to happen.
आराम से फ्लोरो सर.
फ्लोरो ऑन है.
फ्लोरो थोड़ा withdraw. So
गुड्डू पूरा अंदर लो वायर. पूरा अंदर लो वायर. आ रहा इजी आ रहा है.
Yeah.
And then you वहाँ पे फिंगर से घुमाना. यहाँ पे यहाँ फिंगर से घुमाओ. It has to go above. नहीं इधर नहीं आना. यहाँ फिर.
It's going in periphery.
एक बार और ट्राई करो, एक दो बार. नहीं तो if it doesn't go, then we'll go on that only. No,
it's going in periphery.
You withdraw your needle little bit. No.
Okay.
Radhika, just withdraw little, just 2 millimeters back, and now गुड्डू फिर try करो. Try. ऊपर जाएगा.
It's going in periphery. 1 minute.
Rotate.
Keep your go गुड्डू.
So guide wire manipulation is the key to. I think we're not online. Are we online?
गुड्डू loop करके जा. Go loop and go. Make it loop, sir. With loop technique we can go.
You go on peripheral to segment. जाने दो. Segment 2 में जाना दो फिर.
आशीष भाई को बोलो. No. Even if it gets go there, you just loop it, so it will go and full loop technique. Loop it.
नहीं जाएगा. Would not go. आज चला गया. Okay. Go. Oh, very nice.
Excellent.
Perfect.
Okay, 1 minute, Buddha. 1 minute. My needle has come out.
Exchange
फ्लोरो just एक बार फिर से.
Exchange.
Okay.
Fluoro picture, please.
Fluoro picture just.
Fluoro.
Exchanging good. No, don't do that. Withdraw कर थोड़ा.
Please last
I think get the fluoro on.
Fluoro. It has gone.
Fluoro
like
picture,
this and
please.
changed
Come back. No
itself,
problem. पहले wire exchange करो. So we're exchanging the wire now.
1 minute.
So we have crossed one major hurdle of guide wire manipulation. Are we online? Samir, we are there with you?
Yes.
Okay.
Yeah.
We all are also there with you.
Yes, sir.
Sir, fluoro.
So now you're using a 0.025 stiff guide
This
wire?
was 025 short angle tip thermo guide wire.
Okay.
So Radhika is very carefully looking at the guide wire on the screen. The EOS screen, the guide.
I think let us complete that.
Yeah, I think we have gone away from the case. Can we have
discussing-
can we go back to the case again? That HGS? Yes, sir.
Dr. Nijavan, I think we can go back because they were just.
HGS case. So screen is showing another case, sir. Can we go back to HGS case, sir? Possible?
No, Dr. Randeep Sood has to leave, so we are actually, we'll wait for there. No
So we
problem.
can continue with Sandeep's case, I think that.
Yeah, I
because
think
we
Dr.
were in the
Sunil-
crucial phase there. We can
No,
go back to that room.
We can show one case at a time. हाँ वही ले रहे हैं ना. हाँ. Okay.
So we are, this is a case about a 50-year-old female. She presented to us with her complaints of pain abdomen and progressive jaundice with pruritus from past 1 month. CCT abdomen and MRCP was done, which was suggestive of irregular soft tissue thickening along the fundus and neck of GB, which were invading into the CBD and possibly causing type 2 hilar block. Lesion was completely encasing the main portal vein, celiac and hepatic artery. She had also undergone a USC guided percutaneous biopsy outside, which was suggestive of adenocarcinoma. The plan is for going for ERCP and bilateral SIMS. Uh, this is the CT image, and this is the MRCP image. This is probably type 1 and type 2, possibly type 2 hilar block.
So this is carcinoma gallbladder.
We are going for ERCP and bilateral
No,
stent.
no, the diagnosis carcinoma gallbladder.
Yes, sir.
So you like to do ERCP or do a PTBD from there? This is a hilar block.
Yeah, Sandeep.
दो ही देखना चाहता हूँ.
Yes, sir. Dr. Randi, you are on.
Okay. Hello.
Yes, sir.
Good evening. Now, this is a patient with the bismuth type 2 hilar block. Her ECOG status is poor. दिखाना फ्लोर दिखाओ. Wire डालो. And she's inoperable. And so purpose is to do bilateral hilar stenting so that subsequently, if she improves, we can do adjuvant therapy. And the biliary excess I had gained with the needle knife. नहीं जा रहा है? तो क्यों नहीं जाता इसमें से? नहीं बारह के मारो अब मारो. So बस नहीं क्लॉट से थोड़ा प्रॉब्लम आनी चाहिए. So we have put in the guide wire into the right system. Can you see the fluoroscopy image, please?
Yes, yes, we can see.
So
Sir.
I have done the air cholangiogram, and we can see the right anterior, right posterior ductal systems. Now I want to put in place a guide wire into the left ductal system. My challenge here is that I have to use PIP mode for fluoro, and so we are now, the trick to go into the left duct is that, no. See, now this is the hilum. Where is the hilum? Between the 12th and the 11th rib. You can see the gap between the two, and this is where the hilum will be, and we have already got in the right anterior ductal system, which is continuing with the right posterior. You can see the opacification with the air. Now I will, like my endoscopy sister, आपका नाम क्या है? Ramveer is assisting me, and he is very, familiar with the movement of the thermo guide wire. I'm using a J thermo guide wire. So, chaliye. I normally take over from here myself. I do the wire maneuvering myself. Just ऐसा सीधा रख लेना. नहीं उल्टा नहीं करना. नीचे से बल्कि इसको सीधा नीचे को कर लो. वो यार वो नहीं करना होता. चलो अब कर लिया. इसको निकाल. हाँ, लाओ. So ये पकड़ लीजिए. Right side की वायर पकड़ लो.
Sir, what is the trick you are using?
See, this is the wire maneuvering. So, because I'll have slow fluoro, please. I'll start maneuvering from here.
You are trying to go into the left ductal system. Now he has gone into the.
I'm in all probability into one of the ducts of the left. Yeah, I'm in, but I want to be deep in. Yeah, first let's have the confirmation that this is not a duct of the right posterior, because that could be another possibility. What we'll do is we'll progress our papillosphincterotome. वायर थोड़ा टाइट रखो, नहीं तो ये ऊपर को जाएगी, और ऊपर को भाग रही है तो इसका मतलब हम नहीं है उसमें. और इसको थोड़ा बो करो. आप वायर को नहीं कर सकते, बो करो. नहीं, आपने वायर निकाल दी. ये राइट पोस्टीरियर है. See, this is that, many times you think that you're in the left ductal system, but you may be in the right posterior ductal system. So one has to be very careful when deciding double stenting. Fluoro, please, fluoro. No problem. See, this is right posterior. So I'll unbow it. I'll pull back my papillotome and go from below. I'm sure if I'm at the across the spine. Otherwise, it's not. The patient is prone. I know, I know. One has to be a little patient and
Randhir? Randhir?
yeah.
Have you seen for atrophy of any of the lobes?
No, there's no atrophy.
No atrophy.
At least I can see
Both are functional.
MRCP shows very dilated left duct, but and also there's no atrophy. We should never put in a stent in the atrophied lobe. Fluoro.
So we go back to Dr. Radhika and then come back to this
Sure.
now.
Yeah,
Yes,
I think.
yes.
Not a problem.
Yeah.
Yes, sir. Shoot karo.
Yeah.
Yeah, Sandeep.
Yeah,
You're on.
Sandeep, you're on.
You're
Yeah,
on.
हाँ चिंता नहीं करो ये ठीक है ये नहीं जाएगा कहीं भी हाँ यही लगता है
Actually, fluoro. Fluoro sound ज़्यादा करो.
Move all images in Sandeep's room, please.
मेरे को बोलना पड़ता बार-बार
You're not getting fluoro.
I think this okay, slowly, yes, very nice. Very nice. या चाहो तो एक जैग वायर ले लो दूसरा वाला जैग वायर ले लो
थोड़ा शॉर्ट हुआ है सर एंडोस्कोपी
good position now.
डिप्लॉयड हाँ डिप्लॉयड सर
Okay, let's go the endoscopy view. And I'll have the fluoro also. Tabung है.
हाँ बट ये ओके
And you see, we have the endoscopy.
Yeah.
Perfect.
एक मिनट स्टेंट डिलीवरी गाइड वायर
There, you can see the stent on the right upper part. And the
you
file
can
is coming out. So that's done. Well done.
guide wire so should we place a plastic stent not required so take it out the guide wire
Assembly निकाल दो पहले.
guide wire
पहले assembly
guide हाँ
sometimes assembly can be liquid.
हाँ
हो गया? निकला?
yes sir
So we done with it. So we have done both the procedures. Very nicely done, Radhika.
thank you
Nicely done.
thank you sir
Hello.
आप
आपकी डक्ट को डैमेज नहीं करेगा.
नहीं वो भी और
Now we are shifting back to Dr. Randhir's room.
yeah so we have been able to place a guide wire in the left ductal system also.
Can we go back to Dr. Randhir's room?
थैंक यू यार बहुत ही बढ़िया
air
आपका सजेशन इतना बढ़िया था मैं हमें
Javan can so we are in one wire is in the left ductal system the other is in the right inferior ductal system both are thermo can you see the fluoro please
No. Yes, sir.
okay
No.
both are Visiglide
I think we need
O25
fluoro
guide
from
wires
Randhir sir's room. We are seeing his
we
face only.
took the access with the J thermo and now we have no fluoro now we have changed to the Visiglides on both sides so I am going to use a 6 French assembly on both sides after dilatation so I'm going to do as hurricane dilatation up to 6 millimeter.
Can we see the fluoro?
No.
Oh, this
It
is
may
from the
hurricane.
other room, please. We want all images from Randhir sir's room, please.
6 mm. 6 mm. Go ahead. कम क्विक इसी में जिसमें
Yeah.
पहले डला है हाँ
Sir, we have all the images. You're on now.
We are going to place this Tevung Niti stand.
this is a there are all the companies have now 6 French assemblies for simultaneous deployment of the stents in the hilum side by side. No longer we put in stent through stent anymore. Earlier we used to put in Y stents because re-intervention is very difficult with that. So 6 French assembly has the advantage that we can position both the stents together and then deploy simultaneously to get good deployment. There is no risk of the other stent not going in or pushing in the or buckling the previously placed stent. And we attempt is to bring the lower end out, but that's not always essential. It is 8 centimeter, so the left side may not come out.
Sir, which stent you are using?
We are using Taivung Niti S M type stent, which conforms to a bend of the bile duct very comfortably. And this is an 8 mm stent after deployment, but 6 French assembly.
Randir, do you still have Y stents and diamond stents?
Yeah. No, we put in 10, but problem with the 10 mm is that you have...
No. Do you still have in the market?
What you have?
Do you still have them in the market?
Yeah, they are in the market.
Distributor is standing beside it.
You see, Boston Scientific has 6 French assembly stands. The Epic stand of Epic stands are there. The Cook has these stands. Now I'm using a hurricane balloon 6 mm first, so that there's no problem in I don't end up struggling with the putting in the stand. So please, dye, very dilute dye.
Sir, Randir sir.
Yeah.
I want to ask you a question. Once you have wire right side and left side both.
Yeah.
So which one you will prefer to put first, right or left?
Left always. The more difficult first.
Okay.
In fact, cannulation should also be done on the left side first, if possible.
This is 4 mm. I'm rolling in dye along with syringe, not with that injection.
ये 4 mm है 6 नहीं है चलो कोई बात 6 है ना हाँ तो उसी से क्यों नहीं करते चलो करो इससे करो पर 20 इसके लिए फिर आपको बड़ी सिरिंज चाहिए होती है चलो करो इससे प्रेशर नहीं ना लगता आपका हाँ चलो
So can you see the balloon and the CM in it? The balloon is being inflated with the dye here.
So aspirate. I'm going to come down because stricture is lower down. Yes. See, I told you the hilum is between the 11th and the 12th rib. So this is where the stricture will be. Come now. Here. अब dilate करो. थोड़ा एयर जा रहा है इसलिए प्रॉब्लम आ रहा है थोड़ा इसको ना ऊपर करके करो ऐसे हमेशा इसको एस्पिरेट कर लो फिर एयर निकाल लो हाँ उससे गन से क्यों नहीं देते गन से करो नहीं चल रही कोई बात नहीं टाइम टू नहीं लगता यार टाइम चलो करो इन्फ्लेट चलो अब इन्फ्लेट करो एयर निकालो और बड़ा डाइल्यूट चाहिए होता है हमें okay deflate you see you always use this कोई नहीं दिखाइए फ्लोरो वायर डिफ्लेट तभी वायर नहीं आएगी वायर का ध्यान रखो अब मैं वायर अब one trick is that when you are coming out use the same balloon to dilate your papilla so that your stent introduction is easy now you do it यहाँ करिए
The good sphincterotomy, do you need to dilate the papilla?
Always end up doing it. We have already a device there. Why not use that?
But 4 millimeter and 6 millimeter will make a difference.
This is 6 mm.
So how does it make a difference?
It makes a difference that the introduction of the assemblies is very easy. We are going to put in two assemblies simultaneously. Question is, you are not using any new device. ठीक है, फ्लोरो ऑफ, जस्ट एस्पिरेट, आई एम गोइंग टू टेक इट आउट। वह डालो, अब ऊपर दिखा दो, जूम इसका हट सकता है, इसका जूम तो नहीं है, ओके।
So if you, there was a
वायर
recent
डालो,
study also said that intra CBD deployment of the stent was less infectious outcome.
या इनफैक्ट वी आर, ओ वायर निकाल दी यार, तो
एक
वायर
वायर
निकल
निकल
गई
गया
तुम्हारी।
बाहर, नहीं अभी है।
रुक जाओ रुक जाओ रुक जाओ रुक जाओ रुक जाओ रुक जाओ रुक जाओ, वो रुको, ऐसा नहीं करना, कुछ नहीं करना आपने। ओ यार, हाँ तो वो नहीं ना होनी चाहिए, एक बार रुक जाओ।
लूप कर गया अभी,
ओ
है
यार,
अंदर, है अंदर अभी। ओहो, इसका आउट।
गड़बड़ हो गया, चलो कोई नहीं, अब जिसको निकालो, इसी को रखो, दो मेरे को, इसी से वायर डालो, इसी से वायर डालो, कोई नहीं दिक्कत, अब वायर डालो इसी से, इसी इसी से वायर डलेगी आराम से।
So going through the
अच्छा ये
balloon.
निकालो, वायर दे दो।
You're going through the balloon?
No, no, it came out inadvertently.
No, no.
The
Now you're
left
trying to
ductal
go through the
wire.
balloon, but now he's changing.
The wire while withdrawing the balloon, the wire came out of the papilla and then it was a loop in the duodenum which pulled the wire back into the duodenum. So we are going to
The right one has come out, huh?
yeah, we are going to recalibrate
The left duct.
duct.
What
Left
will-
duct, so it's-
Now that is dilated, so it should go easily.
Yes,
I don't have any worries.
hopefully, yes.
वायर आप लंबी वाली ले लो, कोई बात नहीं, चलो।
Can we have the fluoro image, please? Yes.
Now you are able to see the fluoro image.
चलो 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 चलो, नहीं नहीं, एक मिनट, ऊपर जाएंगे, ऊपर जाएंगे, पहले ऊपर जाएंगे, थोड़ा सा ऊपर जाएंगे। ए, यार तुम्हारा ये बड़ा ज्यादा, तुम्हारी वायर, वायर का ध्यान रखो, जो तुम्हारा जो वायर का ना अपना कंट्रोल अपने पास रखो। दिखाओ फ्लोरो, अब मेरे को ऊपर जाने दो, ओके, वायर ऊपर जाओ, हाँ बस, लेट माई पेप्लोटोम को आप, ये क्यों इतना रेजिस्टेंस हो जा रहा है, अनबो करो, ये सॉफ्ट होता है बड़ा ना, मेरे को आई डोंट लाइक दिस पेप्लोटोम एट ऑल फॉर दिस पर्पस। नहीं इसमें नहीं जाना हमने, चलो दिखाओ फ्लोरो, फ्लोरो फ्लोरो मेक फ्लोरो बिगर, नहीं नहीं नहीं, हो गया हो गया।
Restart करना, restart करो। वो restart नहीं मतलब वो power।
Fluoro, please.
फ्लोरो बाहर निकालो, बाहर बाहर निकालो।
राइट में गया है।
अभी फिर रुक जाओ, नहीं तुम कुछ नहीं कर यार, तुम यू डोंट डू एनीथिंग, बस अब इसको बो कर, विड्रॉ करो वायर को, हाँ विड्रॉ करो, अब वायर को डालो, टर्मोल ले लो, इसको निकाल दो, टर्मोल ले लो, अब राइट मत निकाल देना यार, हाँ बस, हाँ टर्मोल ले ले, टर्मोल डालते हैं,
Luckily you are holding the right.
हाँ
It will come out.
नहीं, नो डोंट बी नर्वस, जस्ट रिलैक्स एंड 2 मिनट में हो जाएगा। It's not his fault because the endoscopy image becomes very small. He was unable to see it.
But he has to just push the guide wire inside.
Eh?
He has to just push the guide wire inside and manipulate. That's all.
Yeah, he pushed a little more. So, हाँ.
It happens
Rotate
sometimes.
करो इसको ऊपर, हाँ चलो चलो चलो.
The problem is that you have dilated the hilum and the right duct is open now.
No, but we have not dilated the right ductal system. We have dilated the left. फिर ये मेरा निकालो यार. Because एक मिनट, तुम मत निकाल, तुम थोड़ी वायर टूट
hilum तो
जाएगी.
dilate किया.
दिखाओ फ्लोरो. नहीं 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 राइट पोस्टीरियर में yes थोड़ा सा ऊपर जाएंगे यहाँ पर तो ये क्या कहाँ गया नहीं नहीं है ऊपर ना इसको पकड़ो अब द्वार नहीं निकलनी चाहिए
Sandeep, Dr. Nijavan,
वो करो
Sandeep,
बस थोड़ा 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 ज्यादा नहीं
do we have some
बहुत
other
ज्यादा कर
case
दिया
in the other room?
वो करो यार तुमने बहुत ज्यादा कर दिया
Hello?
किया ना ये अब रोटेट ये ना बहुत घटिया पेप्लोटोम है आई डोंट लाइक दिस पेप्लोटोम विजिक लाइन नहीं जाएगी इसमें कभी भी
So you can see Dr. Andhir has taken off the glove. So the gloves are out.
Yeah, the gloves are out.
Gloves are out. And he's using his bare hand so that he can manipulate it well. It's very slippery wire. If it's a bit wet, it slides between your thumb and the finger if you're wearing a glove.
The problem with high-density picture is you have to place the stent in the anatomy that you desire. If you place a right anterior, right posterior, you won't be able to achieve
As slippery as a
Yeah.
needle.
It's very important that
Dr. Randir, for a minute, we are going to room number 2 to show the fixation of the.
That's good.
We'll be back soon.
Not a problem.
Yes, sir.
Whether I'll be done
Right.
soon or not.
No, it will go, sir. It will go.
Okay, so here, am I audible?
Yes, yes.
Okay, so we are just going to show how we are doing the fixation of the submucosal resection polyps. So this is a small piece you can see, and the polyp here. So on this, we have fixed with the pins, the polyp has been fixed, the margins have been inked, and now the margins are not going to curl. And this is the mucosal side which is up, and it will be put upside down in the formalin. And the volume of formalin has to be 10 times the volume of the tissue. And this is going to be left overnight for fixation. And tomorrow we will take it out and then we will slice it at 1 to 2 millimeter sections. And then we will proceed with the biopsy reporting for this tissue.
Very nice.
Thank you.
Very nice. Very nice. This is a very novel way of doing it.
This is 10% formalin.
10 times the volume of the tissue.
No, the concentration of formalin.
It is 10%
10%
buffered
formalin.
formalin.
Okay, that's
The ideal fixative for all tissues is 10% buffered formalin.
Thank you. We go back to Dr. Randir's room.
Saurabh, I can see you there.
Yes, sir. You are on again.
Yeah.
We are at the same point at the hilum, trying to go into the left duct. Dr. Randir is manipulating the wire and he is multitasking right now. He is holding the right wire, he is holding the sphincterotome, and he is manipulating the wire also.
Sandeep?
Wire in the right is a Visiglide.
Dr. Nijaman?
Yes, sir.
Can we start with the panel discussion here and we come back to Randir
Yes,
later?
yes.
Yeah, you can do that.
That should
Yes,
be that
yes.
should be a good idea.
एक मिनट रुको।
We'll show it. Later
मेरे
on,
को
we'll
ना
show it.
ये निकाल ले मेरे को कल वो दे
Thank you.
Thank you, Dr. S.P. Misra Sahab. Special thanks to you. And thank you all the chairpersons for chairing this live session. We move on to the next panel discussion on malignant hilar block. Can I request the moderator of the panel discussion, Dr. Nilay Mehta, to come on to the dais? Can I request the panelist, Dr. Sameer Mohindra, please stay back on the dais. Sameer, please stay back on the dais. Dr. Ram Daga, Dr. Aman Minocha, Dr. Rajesh Bhojwani, Dr. Nitu Kumar. Sameer Mohindra, Ram Daga, Rajesh Bhojwani, Aman, Dr. Nitu. Dr. Nila is all yours.
At the outset, I thank the entire organizing team for giving me this opportunity. I think my panelists have a minority as far as endoscopists are concerned. Yeah, but I see only 4. I'm sorry, Dr. Bhojwani is not here, right? Okay, fine. So let's move on to any hilar block could be a benign lesion, malignant or indeterminate. Why hilar blocks are important? Because many times it's extremely difficult. Can I ask one more gastroenterologist to work, even though anybody can join me? Please. Yeah. So basically, why it is important to discuss malignant hilar block is because many times it's extremely difficult to differentiate between benign and from malignant. Even if it is malignant and if you want to do surgery or drain it, it again is a difficult proposition. If we cannot drain it properly, then there are higher chances of cholangitis. Hilar cholangiocarcinoma, hilar block could be because of a variety of reasons. Hilar cholangiocarcinoma, CA gallbladder, HCC, malignant lymph node, or any other obstruction. It can be type 1, which is much below the hilum, less than 2 centimeter, type 2, where the confluence is not involved, type 3A, or type 3, where the confluence is involved and the lesion going into either into the right or left lobe. And if it is type 4, it's involving both the lobes. So what we are going to discuss today is issues with malignant hilar block. First of all, the question comes is whether it's a benign or a malignant lesion. If it is malignancy, does it need endoscopy? If it needs endoscopy and we need to do palliation, whether how to drain it, how much liver to drain, whether it should be done endoscopically or percutaneous, whether what sort of stents we should be putting, plastic stents, metal stents, how many stents, and where to place stents. And that is what we are going to discuss. And of course, we are going to discuss the role of endoscopy in preoperative setting. The first question is to Dr. Ram, who is a surgeon. Whenever you get a patient, photographer, can you just move aside so I can start discussing? Yeah. So whenever you come across a lesion and it's a hilar block, what do? Do you do surgery straight away or you ask your radiologist to give you more knowledge, or ask him to see an endoscopist?
Sir, usually we go with our radiologist first. We have to look what is the cause of the stricture. There are various possibilities, as you already told, that it can be carcinoma gallbladder, it can be cholangiocarcinoma, or at time extensive compression from some lymph nodes can be there at times. So we have to load this primary pathology first. Then we go ahead with further, our primary imaging modality in our setup is usually a good triple phase CT along with a MRCP image. So this is all the initial.
Dr. Aman, how sure you are when you see a hilar block that this is benign or malignant, and what are the problems you face? Can you keep the mic properly? Yeah.
Yeah, it's very important to differentiate. Yeah, it's very important to differentiate between a malignant hilar stricture with the other benign pathologies, like the benign biliary strictures, IgG4 cholangiopathies, and primary sclerosing cholangitis. First, there are certain radiological criteria which fits into the malignant stricture. One is the length of the stricture, right? It's generally more than 2 centimeter favors the malignant stricture. And there is an irregular enhancing thickening with irregular stricturing when shouldering in malignant strictures as compared to the counterparts of the benign one. And the degree of dilatation of the biliary tree is much more in malignant strictures than its benign counterpart. And more importantly, basically in the PSC, basically there are multiple strictures. And if there's a there's a single stricture with the significant dilatation and deep jaundice, it favors malignancy over benign
So
pathology.
multiple stricture, probably you would think about benign, single stricture,
with shouldering, irregular stricture, and a significant enhancing thickening with significant luminal compromise.
Can you differentiate between IgG4 and primary sclerosing cholangitis?
Yeah, it's a difficult thing to differentiate between the two at times, but there are certain clinching points radiologically also. In IgG4 cholangiopathy, there is a smooth enhancing thickening of the bile duct. And very specific point of IgG4 is that the lumen is quite preserved. Lumen of the duct is preserved, while in malignant strictures, the lumen is totally compromised. And the degree of dilatation is slightly less in IgG4 as compared to the malignant ones. And there is a 80 to 90% association of IgG4 cholangiopathies with the autoimmune IgG4
Or
pancreatitis.
other IgG4
Yeah, other
related
organ,
sites.
yeah, other organ
It could be
involvement.
pancreas, it could
Yeah,
be
it can be
retroperitoneum.
retroperitoneal fibrosis, and we can see the GB wall thickening in 15% patients also associated with it. Other organ involvement is more common in IgG4 cholangiopathies.
Dr. Ajay Kumar, so the patient has come to you with hilar block. What would you do?
So a couple of things. So if the radiologist have given it's likely to be a malignant, then the next step would be to establish a diagnosis, a tissue diagnosis. And depending on the availability of the expertise, you can go. So you can do an ERCP, take a brush cytology. Sometime you can do a needle aspiration, dilate and take the brush. That will be one. If you have an endoscopic ultrasound expertise available, you can do an endoscopic ultrasound, do some FNA-B and FNA-C and try and.
But how effective it is? Like how many times you would be successful as far as US guided biopsy is concerned?
So not very successful. Maybe about, if I remember the figure correctly, it's about 60 to 65%. It's not very effective. So it's a combination of the things. And nowadays, if you have a cholangioscopy, spioscopy, you can directly go and take the biopsies, the spioscope, and take the biopsies.
But this is a malignant hilar block. So,
yeah, you have to be prepared to put a stent soon after taking the biopsy. Ultimately, because the problem is you have to confirm the diagnosis. But if your radiologist is too short, jaundice is less than 5 milligram, the patient is well preserved, I probably might straight ask my surgeon to go ahead and do a surgery. Maybe before doing a surgery, a PET scan may be a kind of thing which will give them a confidence. So depending on the bilirubin level, depending on the expertise available, depending on the physical status of the patient, the decision will be taken whether to establish the diagnosis upfront or go ahead directly with the surgery.
So question to Samir. First, would you do, sir said you can do cholangioscopy. Would you do cholangioscopy? If you are doing cholangioscopy, what precautions you would take? What are the features you would see on cholangioscopy as far as malignancy is concerned?
If you're planning to do any endoscopic procedure, whether we do ERCP or cholangioscopy, we should be very clear what is the backup plan. If it's a type 3, type 4 block, I will talk to my interventional radiologist as a backup, because it's possible in type 3 and type 4, we may not be able to adequately drain. Because once you do ERCP or you do cholangioscopy, you have to put in contrast, which makes it a sterile environment to potentially infective environment. So if you are able to drain it well, we go ahead with ERCP, take cytology, biopsy, cholangioscopy, and come out with stenting of all the systems which we have opicified.
So see, hilar block, I'm extremely cautious to do cholangioscopy, especially in type 3 and 4. 4,
Absolutely.
absolutely, I'm not going to touch that patient. Absolutely
So
no.
for example, if there are lymph nodes, I would ask my radiologist to take a lymph node biopsy. If there's a hilum mass, I would ask him to take a tissue from the, though there is a possibility of seeding, but it's much, much less invasive as compared to getting patient into cholangitis after our endoscopic procedure with incomplete drainage.
Yeah, so situations where I would not do cholangioscopy is primary sclerosing cholangitis and also hilar block. But there are reports you can do it, but you have to be prepared for cholangitis. And many a times, if you are extremely cautious, then probably you would do PTBD first and then do cholangioscopy, and then you drain it, and that's why you can avoid cholangitis. Suppose we have taken biopsy, madam, then what are the things you would like to have, and which probably we would not be able to give, because this is a different situation where brushing or even spyglass, while the biopsies were taken during spyglass, what difficulties you face and how sure you are that this is a malignancy and benign?
Uh, Actually, when we actually depend upon the multiple samples that you give. So it's a correlation between brush cytology as well as biopsy. We try to salvage all the material that has been given to us. We go for cytological studies. We will try to prepare if the brush material has been given in the formalin solution. We will try to make a cell block out of it and then go for biopsy, study of the biopsy also. So if it is a clear-cut case of malignancy, then it's okay. But if there is some doubt, we will go for ancillary studies like IHCs, and then fish. The fish is not available everywhere, but we can refer to higher centers for the diagnosis.
See, why did I ask this question is that whatever you do, it is extremely difficult to get the sufficient tissue while doing brush cytology. And best way is to either do on ERCP, you can take biopsies on IITV guidance, or you take biopsies during SPY. And I told you that what are my apprehensions about SPY. Yes, sir, please.
Nilesh, is it one question to you, one to Neetu? Is it possible that you do a PTBD and through that you take brush cytology?
Yeah, you can always do that, but it depends on the indication of PTBD. If PTBD is done primarily for the palliation, suppose patient is inoperable and it is type 4, then it's obvious that PTBD guy would take biopsy. If it is palliation and I'm doing bilateral or multiple stenting, then I'll take biopsy. The question is, it is very good to discuss, but many times we don't take biopsy. Because of the problems which we face, biopsy will be inadequate. It can increase the cause more chances of cholangitis.
They are more serious in nature. It's very difficult to take biopsies from that area. And to Neetu, what are the 10% false positive for malignancy here? 90% specificity.
So high-grade dysplasias, reactive ATPs may be very difficult to be.
So they are not malignant. You don't call them malignancy. 10%.
Malignancy, reactive ATP is not malignant, while high-grade dysplasias can be malignant. It could be intraepithelial lesion.
No.
Or
if you have a specificity of 90%, that means somebody has committed that this is malignant, and it does not turn out to be malignant. That is specificity. So what are the lesions which confuse the pathologist that he or she says that it's malignant, it doesn't turn out to be malignant?
Primary sclerosing cholangitis like lesions, they will be very atypical on cytology, but may actually not malignant.
And also, if there is stent placed, then it can falsely give positive dysplasia. If there is significant infection, also many a times they are not able to tell us whether it is yeah.
And a very learned panel. How many times have you seen tuberculosis over there? 2 cases. I've seen one. Anybody? 1 case.
Primary biliary tuberculosis, no. lymph node going into bile duct, it's a different thing.
Primary
It is
biliary.
primary biliary. That's why you said only one, and he
two.
said two.
Four.
And mine is 0.
Nilay, here
Yeah.
just one comment.
Yeah.
See, while you're looking at the hilar block, the etiologies are different. When you're suspecting a cholangiocarcinoma, all these problems are there. But if it's a carcinoma gallbladder, then taking a tissue diagnosis is...
You don't take biopsy.
No, we are not taking. We
Yeah.
can take FNACs and confirm the diagnosis. See, because sometimes you would take the biopsies and biopsy have come negative and you have done all these palliative procedure, then there is a problem.
See, why am I asking? I have a patient right now admitted in my care, has been going on to all centers of India, and still his diagnosis is not done whether it is malignancy or benign. With multiple biopsies, multiple SPY, while SPY were done, PTBDs were done, after SPY stents were placed, PTBD were taken out, and still after January 2024, this is November, still we don't have a diagnosis. That's the difficulty of reaching a diagnosis in hilar tumor.
So in all probability, it's a benign disease.
Yeah, no, I don't know if he's cirrhotic, and many a times cholangiocarcinoma are known to prolong for years together. So you think that it is malignancy? No, cholangiocarcinoma I've seen, we put bilateral stent, they survive for 2-3 years.
So have you taken consider surgery in this patient?
He's cirrhotic. So only thing is liver transplant. Yeah, but if it is liver transplant and cholangiocarcinoma, then prognosis is extremely poor. So what? Yeah, if it is extrahepatic spread, then it's bad. If it is intrahepatic, then it is still okay. Yeah. To my surgeon, when would you say, okay, this is not my case? Hilar block, straight away, the radiologist and surgeon, they have to tell us, okay, put stent.
When it's a type 4 stricture, by both...
Can you just take it? Yeah.
Bilateral second order biliary involvement is there, ductal involvement is there. When one-sided atrophy or is there and other side tumor is there, when tumor is on the right side and left portal vein or left hepatic artery is involved, then definitely we can or vice versa, when tumor is on the left side.
So opposite side artery and vein is involved, that means there is metastasis.
Yeah. And of course, distant dissemination, any liver mets or any
that
lymph
is
node.
true. Like, you know, a metastasis anywhere, aortocaval lymph node positive. So significant lymph node positivity. But this is important. What we usually don't see and surgeons see is that opposite side portal vein and hepatic artery, and also opposite side atrophy.
Yeah. Other thing, at times we can have this coexisting disease like CLD, where hepatectomy is not possible. Again, we cannot go with the patient which you mentioned just now.
Yeah. So same with radiologist, Dr. Aman? Same? Or you have to, you want to add?
Despite the radiological staging for the surgical resection, almost 30 to 40% on table comes out to be non-resectable. Despite the best of the radiological imaging, what we use.
Nilay, if you have portal vein occlusion only,
Same side
can you give
portal vein occlusion is
SBRT followed by transplant?
So if same side portal vein involvement is there, we can always resect. Even main portal vein, we can
give SBRT, downstage it, and then do a transplant.
So there are some studies which says that you can go ahead with stenting and then SBRT or radiotherapy, local radiotherapy. But again, these are limited to very few selected centers actually.
They do it for HCC at least, I know that.
Okay, so now we have decided that this is not a surgical candidate. And we want to drain it. Samir, what are the things you would see?
The thing is, we need to look at the CT volumetry. We need to look at right lobe and left lobe. See, the aim is to drain 50% minimum.
We are going to discuss, yeah. So,
okay, sorry.
Yeah.
How much liver to drain?
Yeah, how much liver?
50% of a abnormal liver and 33% to 50% of a normal liver. But for most of the cases, it has to be more than 50% of the liver volume has to be drained.
But at least 30.
At least, I would say 50% would be a good thing. For example, if a surgeon wants to do something like a procedure where for atrophy, then you need to have enough liver reserve so that liver failure doesn't happen post, which you will be discussing, embolization basically. So I think 50% drainage and reserve survival is almost double if we have 50% versus less than 50% volume drainage.
So before we do, there are two investigations which are absolutely must. And radiologists tell us which are those two.
The CT volumetry has to be done before.
And why do you do CT volumetry and how do you do it? So what information I'll get from CT volumetry?
Basically, the purpose is to drain the 50% of the liver. The functional liver remnant should be more than 50%, but it should be drained at least. And for that, we do the CT volumetry, and the main we measure the left lobe liver volume, the right anterior segmental volume, and the right posterior segmental volume. And based on these volumetric calculation, we have to decide whether we have to put a single stent or a double stent, either via PTBD or by ERCP, depending
Very
on the types
important.
of.
So normally we see just CT scan. That is not enough when you are treating malignant hilar block. Volumetry is absolutely must, because I'll discuss it later. It will tell you what stent, where stent should be placed. And second most important thing is MRCP.
The second investigation of choice is MRCP, to see the length of the stricture and the type of blocks. So accordingly, we have to decide whether we have to go for a single stent or a double stent accordingly.
Yeah.
Only on MRCP we can tell you that this lobe is atrophied, because the ducts will
sir.
not be dilated.
No. Because nowadays we used to do it and we
Yes.
still do it.
Yes.
But radiologists are better telling us that, okay, this is this much.
Any
this much, this
randomized
much,
control trial
and
of.
you are more comfortable. It's not extra money.
So you're doing a CT first, volumetry.
CT is absolutely must. Without CT and MRCP, you should not.
MRCP has to be done.
Both. Without that. So, okay, Aman, can you tell us what are the policies if you only do MRCP?
Basically, staging, because CT has a much better spatial resolution, and the involvement of the portal vein and the hepatic artery, involvement is better seen on CT rather than MRCP.
You cannot replace CT scan with an
I
MR,
know, I understand.
because first you have to see whether it is operable or inoperable. And that is better seen with CT than an MR.
No, but suppose you do a CT, volumetry is not being done, and do MRCP, we can say with this lobe is atrophied because the ducts are not dilated.
So if the radiologists don't, it's a software based, right?
Yes.
So if you don't have that software, then you can get away with it. But if you have a software, that is the most ideal thing.
And what about endoscopic ultrasound telling you that?
It is useless most of the times. My great sonologist can tell you things, but it is most of the times is not effective. If you have a mass, then it is fine. If it is infiltrating hilar lesion, how come an EUS tell you more? No, sir. Let us not replace the methods which are already standard methods. Let us not doing everything ourselves. That is the problem.
Does air cholangiogram have the same complications as the putting in a dye?
That will come later, but air cholangiogram is good only if you are putting unilateral stent. If you are putting bilateral or more than 2 stents, I don't think air cholangiogram should be done. I think the normal contrast should be given, because that will delineate the bile duct better. You are 100% sure where you are putting your stents. Air is great to tell you that you are in particular duct and the duct is dilated, but you don't know the exact proximal extent. So again, it is great to discuss when you are actually doing it. And problem is, once you put air and then try to put contrast, and contrast and air mixes, it just spoils the entire picture.
Right.
So you should know whether you are putting 1 stent, do air cholangiogram, fine. If you are putting 2 or 3 stents, don't do air cholangiogram, put contrast. Delineate the bile duct properly so that you know how to place stents and where to place stents.
But Dr. Randhir, while putting in bilateral, say he always uses air cholangiogram.
So it is a personal preference, but this is my preference. Yeah.
Just as we are talking
Yes, sir.
MRCP, we should not only rely on the static films. We should have a dynamic rotational of the, because we must have the CD to show that which duct is which side.
I wish that was the case, but unfortunately, it's not an ideal world. The kind of MR we see and a kind of MR, I'm sorry, but kind of MR images we get, they are absolutely useless. And this is not an overstatement. If I have one request to my radiologist, don't give us 50 plates. We need only 5.
And we need one motional picture so that we know which duct is given.
Yeah, they give it in CD, but most of the people don't give it in CD.
We should try.
Yes. And also we don't need 200 images, small 200 images. Okay. So now coming down to that CT volumetry, that is why it is important. And so right anterior is 35, right posterior is 30, and left is 35. And that's why you have to place your stents accordingly. And this is what my radiology colleague was saying, that volumetry is the most important thing. You have to place the stent in non-hypertrophy segments. If you place stents in ectropic segment, it will not drain properly, and there are more chances of cholangitis. So, Dr. Ajay Kumar, type 1, there is no problem because you just place one stent anywhere and it should be okay. Type 2, what would you do? One stent, two stent, right lobe, left lobe.
I think in type 2 also, you can get away with one stent, and whichever is the dominant duct, you can go ahead and put this, because there will be internal communication. So even one stent in type 2 will be sufficient.
But preferably in right.
Preferably in the right, because that's the dominant lobe, and both, because in this patient, it will be if it is a type 2, it is not a type 2, but this kind of a where type 2 stricture, right lobe will be a preferred to be drained, and you can leave the left lobe, and that should be. Sometime if they, maybe subsequently, if the cholangitis develop, then you may have to go in again and put it. Otherwise, you can do a
No, but you have placed one metal stent. Now, how would you place another metal stent?
No, then you can do a PTBD and salvage the patient. The backup rescue should be always there.
So this is another problem. If we have placed one metal stent, then we try to put another metal stent while going through the mesh of the previously placed metal stent. It's extremely difficult. Most of the times you will fail. So then probably the PTBD guys are better. Not only they can place the stent, they can also pass their stents, because the distance what they need to traverse is only small. And then they can push through our stent through the mesh and put another stent. Sami, you were doing like this. You don't agree with whatever, sir?
No, it's not like that. See, our policy is we place beyond type 1, type 2 or beyond, we place minimum 2 stents.
So even for type 2, you place two stents?
Because see, confluence is involved. See, the problem is today
It is involved. It is just reaching there.
Today
It may involve later.
today it is looking like just reaching. 15 days later, patient comes with a contralateral block. If we have two guide wires, it's always better. What we do to place 2 stents, whether plastic or metal, that is secondary. But if you get access to 2, then that is not only for palliation. Maybe some patient may have pre-op drainage.
We are going to discuss that.
Yeah, okay, sorry. So we try to place 2 stents.
So 2 also, 2 stents.
Because that makes sure that more than 50% of liver is.
But Dr. Ajay Kama is not agreeing with you.
It's preference. I mean, it's not, I may be right, he may be right. I mean, I'm not saying that. But generally, if we get access, we place 2 stents.
Yeah. So point well taken. 1 is good, 2 is better. If you have type 3, then as our surgeon said, it is absolutely mandatory to see whether there is atrophy or no atrophy, because putting a stent in atrophic duct would not serve any purpose, and there are more chances of cholangitis. So you have to select out the segments which are normal segments. So if it is a left lobe atrophy, Samir, again, where will you place stents?
See, any atrophic gland means less than 30%. So if you drain atrophic gland, whether right or left, it is 30% drainage. So we need to drain the non-atrophic segment.
So probably then you will place stents in right anterior and right posterior.
Instead of going to the atrophic. If the guide wire goes in, we can place the third stent. But the priority will be right anterior posterior, which are normotrophic, not the atrophic, because atrophic is going to give us less volume drainage. That's what we try to do.
So same, that is what the message is. Avoid the atrophic and then put. So coming down to that question, plastic or metal? Plastic or metal?
Ideally metal, but depends upon patient affordability, availability of the stent, and patient choice.
Patient is not affording.
Patient not affording, I would place multiple plastic stents.
And after 15 days, he'll come.
No, he will not come back. If it's always a positive. We explain the risk, but if he can't afford anything and he needs drainage, it's PTBD versus our plastic stents. So I would, and it's type 1 or type 2 I'm talking about. I'm not talking about 3.
Colleague is
Not 3 or 4. I'm talking about 1 and 2 only. So I would place plastic in 3 systems if space occupied, or one right and one left.
About type 1. Type 1, you put plastic, metal, I don't have a problem. Still metal is better.
Ideally,
plastic is fine. I'm talking about type 2 onward.
Ideally metal. I would say arrange for money. If patient is not in cholangitis, I will go home, arrange, and we'll place metal.
Samir, the problem is not with hilers. If it is because of carcinoma of gallbladder, then the complications are higher with plastic stents. In CAGB, I'll never put a plastic stent.
Even metal stents get blocked within few days in
Yes,
hilar
so
block.
that's a big problem.
Dr. Ajay Kumar, do you put plastic?
I try not to put it, but sometimes the patient has high
Yeah, you don't
bilirubin
have a choice, then probably
then
you would,
yes.
otherwise no. Yes, sir.
You have to look at the performance state of the person also. That is very important, whether he's going to live for 3 months, 2 months.
I know, sir. That is a great thing to publish. It is extremely difficult to say whether this patient is going to make 3 months or not. Of course, patient is having ascites, poor performance status. I would not do anything.
That's also right.
100% cholangitis. Very few who are the luckiest of all would survive on plastic stents.
Yes.
So metal is the way to go. The variety of literature which has proven that metal is better, longer patency, less chances of cholangitis, better clinical efficacy. Unilateral, bilateral, we have discussed that 2, probably unilateral, but bilateral is preferred. 3, 4, definitely bilateral. Avoid atrophy. Put either right left or right anterior, right posterior, or right posterior left, whatever good lobes are there. And that's why you should have it in mind before you are planning an endoscopy therapy. Same, so the literature says bilateral is better with higher functional rate, longer patency, and longer survival. Dr. Sood was saying that previously we used to put stent in stent, and now we put side by side. So what is stent in stent, Samir?
Stent in stent means you use a large caliber stent, large caliber net caliber. You put a stent in a Y configuration and there's a gap and you go into the other system through that stent. And but the important thing is the difficult system should be stented first.
So this is what the video is showing. 2 guide wires are gone. One in the right, the other one is the left. If you see the date, that is 2013, because those days we used to put side stent in stent. 2013. But now we, as Dr. Sood said, so as you were saying, difficult, and most of the times difficulty is in the left. So what you put is either a Y stent or large cell D-type stent. And then once that stent is placed, the other stent is placed through the first stent. So Y is open stent in the middle, so you can pass through the other stent. Or the large cell or the meshes are bigger, so you can put another stent through the first stent. Anything to be added?
The only problem is this technique is very good if the diameter of CBD is not large. For example, if it's a 7-8 millimeter duct, putting side by side stent is a bad idea. Because number one, the second stent will not open up adequately. Number two, there's always a chance of vascular injury. The vessels which are running peribiliary, they are getting to get compressed and cause injury. So if the diameter is less, then it's better to put stent in stent. I mean, this is a very small indication.
Yeah. So diameter less than 7 millimeter, put stent in stent. Don't put side by side. And very important, what Samir told us, that if you are putting side by side, if the diameter is not much, there are chances of portal vein thrombosis and vascular injury. That is, that's why you should not be putting. Dr. Ajay Kumar, what is side by side? We missed that what Dr. Sood was doing, but that is what he was planning to do.
So in side by side, you put first 2 guide wire, one in the right and second one in the left. And then you have now the assembly, which are smaller in size, 6 millimeter assemblies. Put both these stents, you upload both these stents and then release one by one and gradually, so that you put both these stents together.
So that's what this video is showing. Now, both the stents are released simultaneously. So either one assistant is releasing both, or both the assistants, they have to be extremely
they have to be very careful.
Very careful. What are the things you would do, Samir, you have to keep in mind when you are putting side by side stents?
See, the problem with side by stent is if you do it simultaneously, I had experience very rarely the stents stay at the same level, because markers are same, orange colored.
They are at the same level.
But they are saying you are an exception. See what happens, what I'm saying, it doesn't make a difference. Even if one stent goes inside, but below the stricture, it doesn't make a difference. The only problem is if you need to re-intervene. then getting access to the stent which has gone in is a problem. But otherwise, preferably both the stents should come out of the papilla. But that is one issue which which always comes up because it has to be very methodical, and it rarely happens.
Very right, very right. So it's not mandatory to keep it outside the ampulla. It is better to keep it outside the ampulla. But even if you are keeping inside the bile duct, it should be at the same level. Then only you can do reintervention. But otherwise, one stent is here, the other stent is over here. You cannot do any reintervention. It is extremely difficult to go into both the ducts when the ducts are blocked. It's more theoretical that you should be doing it. And it is practically what Sami said, it's very difficult to maintain the same thing. One is going in, you try to pull out, the other one is also coming out because it's a very tight space. But
one trick is what we have started doing is we use one stent as an epic stent and one as a silver stent. So the markers are different. If you're using the same stents, the markers are so mixed up because there's a small space and the moment you don't know which marker is moving in and out. So use a different brand of stent where the marker color is different. That's what we have started doing it. Let's see how this experience.
Problem is that I don't want to go discuss, but one is very difficult to see on IITV, you know, and that's why even if the one brand is very great, I don't use it because even with my specs, I can't see it properly. And then there are at least four companies which make 6 prints. So these are special stents, 6 print delivery system. They are not 10 millimeter SEMS. They are 8 millimeter SEMS. And they come in different sizes, 8, 10, and 12. And because it is a hilar, many a times we have to use 12 if it is a male patient. Female patient, even if you think it is a long, don't put 12 because it's going to be long. So female is either 8 or 10, male is 10 or 12. Yes, sir.
Samir, what about silver is very soft. So it might get compressed by the other stent.
Sir, but Epic
Both
is also
are very soft.
Very
all
soft.
are very soft.
Epic is also
they all
soft.
are laser cut stents. All are very soft. All are very difficult to see. But silver is the worst to see. So there are Tium stents available, Hanaro stents available, the Epic, that is Boston Scientific available, and silver, which is Cook. All four, they all are soft, but silver is the most difficult to see.
And if you need a re-intervention, you're not able to do your intervention, radiologist is always there to help you out.
Yes.
We have access, what he said, if they're at the same level with outside or inside the papilla, then most of the time access is there. But problem is different levels. Then your wire goes here and there, and then it's very difficult to get access.
This is the most ideal situation, and that's why you show the video, which is.
But congratulations for the performance.
Yeah. Nilay, really, because both the stents are absolutely equal in size, which is very difficult to achieve when we are putting through.
Yeah.
You are lucky on that day.
No, I try to do it. And then I shout at people when it doesn't happen. Yeah. So both are same. Efficacy is same. But if it is less than 7, then side stent in stent is better. If the angle is between the right and left, then stent in stent is not better. Then you have to do side by side. Aman, so it's a type 4. What would you do?
You will definitely
ask your endoscopist to go for.
No, not at all. We will directly go for PTBD. If it is type 4.
So still, I know that people still would try to put 2, 3 stents endoscopically, but this is the place where I personally think, and then literature also says, you have to take care of it by take help of your radiologist. It's absolutely must. Unless you want to have your patient cholangitis and sleep late night. It's getting over, yeah. Then it is fine. Combined approach. Dr. Ajay Kumar and Samir, do you combine US ERCP or do you do US guided drainage in hilum? And if yes, what?
Well, I don't do personally US guided any drainage because I'm not comfortable with it. So if it's a type 3 or type 4, I always go with PTBD. And now these radiologists are very comfortable putting the self-expandable metallic stent through the PTBD route, and they can put
They were more comfortable than us. They started doing it earlier than us.
No, but in type 3 and type 4, they do a wonderful job, and they're there. So I personally, I don't do HGS or these endoscopic EOS guided biliary drainage.
So HGS is okay if there is confluence is not involved. Confluence is involved, then either you have to put one stent from right to left, another HGS. Yes, Samir.
What we can do is, the problem is communication of right anterior posterior. If right anterior posterior are communicating, We do a ERCP, place a stent in the right anterior, and in the left system with the hepatic gastrostomy.
Yes.
That's a reasonable,
Yeah.
minimally
I
invasive.
think that is the base thing, rather than putting one stent going from left lobe to one stent between the right and left, another left and stomach. I don't think we should be doing all those
Absolutely,
crazy
absolutely.
stuff. Interventional radiologists are better than us.
Do better.
But if it is right so this is what you were saying. So right and left anterior duct were patent. So we placed initially one stent in the right duct and then EUSHGS, as you can see over here. And that is what probably is our preference if we can do it. Otherwise, my patient goes to. So you can see there is a stent in the right hepatic duct, and this HGS is seen being done. So this is what we do if that is the scenario. Okay, so surgeon comes into play. Now, this is basically a surgical case, and absolutely surgical case. Hilar block. Would you go for surgery straight away, or do you prefer preoperative biliary drainage? And if yes, in which situation?
Most of these patients comes to us at a very late stage. They come with high bilirubin. Many of them come with cholangitis. So if cholangitis is there, very high bilirubin level, though there is no such cutoff point, but if very high bilirubin level is there, or patient comorbid condition is not good, is medically not very sound, some cardiac diseases are also there, or performance status is not good, is nutritionally poor, then we will look to go for preoperative biliary drainage in this patient first. Most of the time it's PTBD in our setting, and then we can go ahead with surgery later on.
Okay. So, and also I added to it, if you want to do neoadjuvant therapy,
Yeah.
or the patient nutrition status is not good, or you don't have sufficient future liver remnant, then probably we would do PTBD or preoperative biliary drainage. A question to surgeon, or a question to both my gastroenterology colleague: do you do PTBD or endoscopic stenting for pre-op biliary drainage?
It depends on the type of. So if type 1, type 2, I'll put endoscopic biliary stenting. Type 3, type 4, my personal preference is to send it to a radiologist and get a PTBD done, and then palliate them, get their bilirubin down, improve their nutritional status, reevaluate them after about, say, 4 to 6 weeks, and then surgeon take a call for this.
Yeah. So for us, type 1, 2, we do endoscopically, type 3, 4, PTBD. And I tell you, surgeons are very happy with PTBD in type 3, 4 because we are not interfering with their plane of dissection. When we cross the stricture from below, surgeons are very unhappy because it leads to inflammation, ongoing
So
sepsis.
the answer is PTBD.
PTBD
better,
type 3,
even though
4.
people have done endostetic stenting, NBD drainage. Last question, and that stops here. To my surgeon, I have put endoscopic stent. It's a metal stent, but it's an operative lesion. Can you do surgery?
So depend upon the upper extent of metal stent. So if it's going very high in the liver, then we definitely cannot go ahead with the surgery in most of the patient. But at times we are able to take out the stents. But again, it increases the mortality as well as morbidity in the postoperative course. So if stent is to be put, it should not be too high in the liver. Only then we can go ahead with the surgery. Otherwise, it's very difficult to go ahead with surgery in these patients.
Okay. I think it just ends our discussion. Thank you very much.
Thank you, Dr. Nila and the co-panelists for a very nice discussion. We are going to the next set of live cases. May I invite the moderator of the session, Dr. Sanjay Rajput, the chairpersons, Suresh Chawla, Dr. Harshal, Dr. Vishnu Agarwal, Dr. Deepak Sharma, Dr. Dhaval Dave, Dr. Manisha Dwivedi, Madam, Dr. Deepika Parmar, Dr. Sanjay Rajput. Dr. Nijaman, we are on now. Harshal. Workshop. Now we are to the case number 13. We will present that case for it is a case for Stern.
this 44-year male can be tested with abdominal fullness and bloating since 1 year. When we did upper GI endoscopy, a esophageal subability lesion at 30 centimeters from which they were found. We did in US. In US, we found linear submucosal hypertrophic lesion in mid esophagus at 30 centimeters from which they had myoclonus. So plan for this stir procedure. This is endoscopic image, and this is US image. So we proceed. Sir, proceed. What do you know?
How you are getting the images or not?
Yeah, we are getting the images, sir.
In the voice also?
Yeah.
Okay.
Sir, is the patient symptomatic for this leiomyoma?
Yes, often,
So do we need to remove it?
yeah, that's a big controversy actually, that whether we should remove the lesion or not. I think those lesions which are bigger ones, one, and second, those lesions which are actually growing in size, you can go ahead and do it. Otherwise, it is controversial.
So can we keep this on follow-up also?
Yeah.
Can we keep them under follow-up and see?
Yeah, that's the best way to do it. And under the follow-up, if you find that at times the patients are very apprehensive that they have a tumor, they have a tumor. So the best way to go is remove them, because once they know that there is a lesion, then they will come back to you again and again. What will happen? What will happen? The best way is to remove it. And the second is, if they are increasing in size, again that becomes an indication. So Zahir, you are on.
I think they are intubating the patient.
Yeah, I know, but Zahir can answer a few questions.
Good evening. So
Yes, yes. And there was a controversy going on whether we should remove this small tumor or not. So because of lesion, whether we should remove it, what are the indications for removal?
To remove esophageal subepithelial lesion, for practical purposes, almost all of them are leiomyomas. Small proportions are granular cell tumors. And it's very rare to have a GIST or lipoma here. So now, if we see the spectrum of these lesions, I think none of them qualify for endoscopic resection. But then why do we still remove it? I think what discussion was going on, that patients have a concern. Do they need endoscopic follow-up? We don't have any quality data. And if the patient asks me that, are you sure that there's nothing going to happen? And I say that in my experience, probably nothing is going to happen, but still I would like to scope you after a year, and then maybe one in 2 years or 3 years. So in that scenario, I think it's okay. There was a time when we didn't have any safe endoscopic techniques to remove these subepithelial lesions. Now there are so many safe techniques. There are practically no adverse events. Then why not?
Does Nabi, does it matter what is the size of this?
Yes. It does matter. More than the size, the available data in my experience says that if the length and multiplied by the width is more than 1000 millimeters square, you can still remove it, but you'll have to remove it in pieces. So size is important if you want to remove it en bloc in one piece.
No, the question is, what is the size which indicates the removal? What is the smallest size, which is the larger one?
So it's less than 3 centimeter, more than 3 centimeter.
Okay.
The largest that
Right.
go ahead with.
So smallest size, I think there is no limit to. So those who are lesions which are extending, again, length is not important, but the width of the tumor, how much circumference of the esophagus it's involving, it's more important. So if it's extending till half or more than half of the circumference of the esophagus, I'm little bothered that will I be able to remove it en bloc. So the circumference of the tumor, what width of tumor it's involving, is more important to me than the length. In length, you can remove it. You can remove 6 centimeters, 7 centimeters as well. But then again, I say that it's the width multiplied by the length which finally determines the outcome. If the width is more than 30 mm or 35 mm, I think these tumors are very difficult to remove in a single piece, because the width of this is the main determinant of en bloc removal and success of the procedure.
And I think the symptoms are more if they are near the GE junction. So patient comes early when they have near GE junction leiomyomas. In mid esophagus, they are all either asymptomatic or they are coming late when they grow in size.
Yes, yes, yes. And in fact, those leiomyomas or submucosal lesions which are symptomatic and which are located in esophagus, it's very difficult to remove them endoscopically, because by that time they have grown, and they are also close to some of the vital structures like your airways. So there is a high chance that you may injure the trachea or the bronchus. So it's very important to get in these large tumors, to get a good CT done and see the relations with the nearby structures like especially the airways.
And also it is important whether they are growing more towards esophagus or whether they are going inner side.
So the beauty of stir is, even if they are going a bit exophatic, I think still you can do a stir and remove it, because you are going to keep the mucosal layer intact.
But
So
definitely not when it is abutting the vital structures or the.
yes, but having said that, if you do an EUS and you see all those structures so close to it, that does not mean that they are actually so close to it. So often we have seen that these lesions are quite far from. So I feel that unless there is an indentation of that particular structure, they can still be removed quite comfortably.
And how many times you have seen EUS miss the guiding you in the size?
EUS is not a good modality for measuring the size.
And as most of them are leiomyomas, will piecemeal resection matter?
It doesn't matter. It doesn't matter. But then if I have 99% of the occasions, there are leiomyomas. But then unless you have a pre-op biopsy of that particular lesion, I'm not sure. So the intent is to remove en bloc. But in the process, suppose if the lesion is too big and you're not able to go below the lesion, the inferior margin of the lesion, you are not able to clear it well, then sometimes it turns into a piecemeal resection. It matters more for GIST, not that much for leiomyoma. But having said that, the basic principle, basic technique, intention is to remove it in a single piece.
But you'll get an answer with your crush biopsy in 2 minutes before your thing is over.
Yes, yes. So the crush biopsy, yeah, it looks like an interesting technique. Okay, from the look of this lesion, this is a very small linear lesion. From the look of this lesion, I feel it should not be deep. It looks superficial to me, and I don't think that there should be any. You can see the stretched mucosa here. So that is one indicator that it's probably not.
We are not seeing the endoscopic image. Yeah, now it's there.
Yeah. Have you received the?
Yes, now we are seeing it.
They have LCI and.
Any EUS done before?
EUS was done before. EUS suggested that the bulk of the lesion is in submucosal layer. The muscularis layer appears to be free. So now the decision is how to remove this lesion. Should I do a stir, or should I simply do an ESD, which is a simpler procedure in such case? Can I have the knife?
How proximal do
How
you
you decide about that?
So
I
I make a tunnel to begin with. I go behind the lesion and see the attachment to the muscle. If there is no attachment to the muscle and there is no muscle injury, I'm going to convert the same procedure into ESD.
It is anteriorly located, so difficult. The location is near.
Location is anterior. So because now we are most of the tunneling procedures, knife out, please.
How proximal to the tumor do you start tunneling?
So I start very close to the tumor. I start very close. I don't keep a very long gap between tumor and my incision.
So do you always mark the esophageal lesion?
Yes, because the moment I inject, I'll show you why I mark it.
So this burn was not for marking. This one for making a mucosal incision so that you can inject better.
Yeah. So you can see I'm using a hybrid I-type knife, right? So what is the advantage of that knife? That I don't need to ask my assistant to inject again and again. So I inject at my own goodwill. So this is a, so can you see that? This is a superficial incision right now. I am deepening it up.
Blue, they have not put in methyl blue. They can put in some methyl blue.
It's okay. If they want to put, they can put knife out, please.
Methyl blue. Oh.
So this is my initial incision. I'll widen it more. You see, I didn't make a vertical incision right now. The reason being, I have a strong intuition that we may convert, yes.
Yeah,
And
this
the second reason is that if you make a vertical incision, it tends to extend while you try to enter, especially along the anterior side.
And
do you think you need any tunneling for this? Because there is no extension seen beyond this mucosa.
no, he is planning for ESD.
You can just remove this by a simple ESD.
Yeah.
That decision will be made once we go below the tumor. And can we have some methylene blue inside? The knife out, please. So we haven't added any methylene blue. It's okay, but if we can add a little bit, knife out.
Yeah, it's not colorful.
It's not colorful, so I thought the same. But it's okay. Like methylene blue is just a guide. It's not mandatory to.
With an experienced operator like you, it is not difficult to identify submucosa when it is not stained by methylene blue.
Yeah.
For beginners,
Sarans, you are not audible.
Okay, we have added some methylene
Keep
blue.
your mic near your.
Am I audible now?
Yes.
So with an experienced operator like Dr. Zahir, it is very easy for him to identify submucosa when it is not stained by methylene blue. But for beginners, I would recommend strongly that you use a dye so that you are able to differentiate between the submucosa and the muscle.
Is there any easy method to do this? Because if you can suck now and see, it's coming into your cap.
So
it's a little longish one.
Yeah.
If it was
For
a
the
little
cap,
short.
it is longer than the cap diameter.
No, just to see whether it is not attached to the muscle, because it will come into your cap easily.
Yes.
Zahir, we are also starting one simultaneous case, so we'll come back to you again.
Sure.
Yeah?
Yeah.
So we go to room number 2 with Dr. Khurana. Yeah. Dr. Khurana, you're on. This is a patient of carcinoma esophagus with TO fistula. Yeah. We can hear you.
Okay. Good afternoon, Dr. Kalla, Dr. Sanjeev, Dr. Nijaman for this.
Dr. Amit Mathur is also here.
So, sorry, Dr. Amit Mathur. Hello, Dr. Amit. So today we are going to do a case of esophageal stenting. Patient is a case of CA esophagus with large trough. So initially we had planned to do a TTS stent placement from Niti company.
Dr. Neil Kamal is with you?
Yes, he is with me. Dr. Neil is with me, Neil Kamal. So we had planned for a TTS stent, but unfortunately that stent is shorter in length. That lesion is 10 centimeter and the stent is 12 centimeter. So whenever we do a stenting, we need at least 4 centimeters longer than the actual length of the stricture. 2 centimeters on either side. So we need at least 14 to 15 centimeters of the stent. So we are now planned to put a ball flex esophageal stent in this patient. So before we put the stent, I just loaded the scope with the guide wire, and I want to show to all my young gastroenterologists endoscopy how to do the proper endoscopy. So always hold the endoscope at 25 centimeters. I repeat, always hold the scope at 25 centimeters. Give a curve to the tip downward
and just go over the tongue, keeping your right and left blocked. No, am I?
Hello?
Am I audible?
Yes,
Yes,
yes.
yes.
Okay, so
Sir,
hold
which
the
stand
stop
you
at
are going
25
to place?
centimeter.
Which
Keep your
stand?
right and left knob fixed with your thumb, and keep your index finger just free.
We are
Don't use
not
only
seeing
one
the
finger.
image,
Don't
sir.
use two fingers for suction and air and water. So you just go over the tongue. Just see you can, and then use your up and down knob.
Can we have the endoscopic view?
Slowly and slowly.
No.
Endoscopic view, please.
Yeah,
And
now we.
just focus the larynx. You must see the vocal cords in the case of CA esophagus, whether they are mobile or not. You can see they are absolutely fine, and we have done the endoscopy. They are moving properly. Since now he is under sedation, we can't check the movement, but we had done it is moving properly. So that is number one. Number two, you have to see what is the upper and upper sphincter. Now it is at 14 centimeter. I repeat, always measure the upper sphincter, the lower sphincter, the starting point of the growth, the end point of the growth. So it is starting at upper sphincter at 14 centimeters. Then I go slowly into the esophagus, and as we advance, you can see there is some oscillation starting at 20 centimeters. Can you see the oscillation? So this is starting at 20 centimeters. So as I go down slowly and slowly, this patient is esophagus, no chemo, no RT. So he has spontaneous tracheal fistula. So as you go down, there is a big fistula opening at 25 centimeters. Can you see this fistula?
Yes, yes.
Big fistula. You
So
can
there are
see
two
the
openings seen.
trachea. You can see the right and left. These are main. These are trachea. Can you see? So that is big fistula. Is it clearly visible?
Yes, yes.
Yes, yes,
At
it is
25
visible.
centimeters. So then I go down the into the esophagus slowly and slowly. We see where is the lower end. Now it is just
Sir,
at
how many times you put a stent into this big fistula and they have migrated into the fistula?
very uncommon. I must tell you, basically a patient who has a esophageal cancer, especially long growth, there is hardly any peristaltic activity in the esophagus. So unless until you give chemotherapy, radiotherapy, or patient lot of retching, usually stent remains in position. So we have a lesion which is 10 centimeter long.
No, because of the size
finishing
of
at
the
30
fistula, not
centimeter,
because of the
and
tumor.
the fistula is at 25 centimeters. I'm going slowly and slowly down into the esophagus. Now our lower end is at 41 centimeters. Then I go into the stomach. So we have the stomach. Slowly and slowly examine the entire stomach so that we don't miss any ulcer.
My question is, sir, because of the size of the fistula, how many times this stent migrates
I'm saying
into the
maybe
fistula?
less than 10% in my own practice. So I have done more than 1,000 plus.
You have clips to anchor it to the
So I'm the
esophageal.
No, madam. The stent migrates just because of the size of the fistula. The stent goes inside the fistula. It is not from this side. You have to place the stent at least 4 to 6 centimeter above the fistula. Even though we have seen the stent migrating into the fistula, patient coming up with the cupping, and then we have to remove this stent. So that is a very common complication with large fistulas.
I feel metallic wire is the one which can cause more complication in such patients. So always use a stitch superstick guide wire, whether it is Terumo or this zag wire, or you can use a Visigland, any wire you can use. But I avoid using metallic wire. So I'm just coming out slowly and slowly. And you see, I will not be putting
What
any
is the
marker.
size of the wire?
No marker on the patient.
Sir, would you prefer
Varna?
placement of a tracheal stent
It is
first
super stiff wire or
before
normal?
Really,
esophageal
I
stent?
think in this patient, yes, this patient will require a fistula closer by the tracheal stent.
Which is 15 centimeter long. 15 centimeter long stent.
Fistula is very big.
To focus the way I do it now. So this is a different technique which I use. I do not use any marker either inside the esophagus or outside the esophagus. No marker on the chest wall, no marker on the.
Sir, your voice is still not coming very clearly.
Okay, I'm saying the way I do it is that there are no markers on the chest wall. There are no markers on the esophageal mucosa. So I use it without markers. So what we do is, if you see the stent, can you see the stent?
Yes.
So this is the proximal end of the stent. So we want this stent marker to be at 20. Now the growth is starting at 20 centimeters.
So we want it to have at
How,
18 centimeters.
how much length it is, sir? It looks 15.
So this is
It
growth
looks
is from
15
30
15 centimeter.
Visual at 25. So I want this proximal end to be
Is
18
not
centimeters.
visible.
So what I will do, I will put a mark using my endoscope. So this is my scope. Oh, you can use an inchy tape to put a mark. So I'm using this, my scope since we don't have inchy tape. So I will just see where the 18. So this is 18, but so whenever you, but I give a margin of 2 centimeters. So I will put my marker at 16 centimeters. So this is my 16 centimeters.
It is fully covered or partially
This
covered?
fully covered. We don't have nowadays very difficult to get partially covered. So it is better to put a partially covered. If given a choice, always put a partially covered. The migration is very less. So you can see I put a marker on the stent assembly at 16 centimeter. Can you see this 16 centimeter? So when we deploy a stent, there is a jump of the stent by 2 centimeters. So if you want the stent to be 18, put a marker at 16 centimeters. Suppose you want the stent to be at 40.
Sir, what is the length of the stent and what is the diameter?
The length of the stent is 15 centimeters, the diameter is 18 millimeter, and the flare is 23 millimeters. So most of the stents, they have diameter 18 mm, and the flare is 5 millimeter plus or 6 millimeter plus. So this is 18 and 23. So I hope I'm clear.
Yes.
So can I proceed further?
Yes, sir.
Okay. So now I'm passing the guide wire.
Dr. Khurana?
Yes.
I think this Boston stent has 2 centimeters up and down uncovered portion.
Sorry?
No, this is the fully covered stent.
This is fully covered. You
Mukesh.
don't have partial. It is better to put a partially covered if given a choice.
Yeah.
But तारी छोड़नी चाहिए. So tell your assistant not to leave the guide wire because that's the main thing. Number two is the assistant who is helping you make sure that he holds the guide wire in a fixed position. So there should not be too much guide wire inside and he should not pull out the guide wire like it happened with Dr. Suitcase. So guide wire came out. It has to be fixed position by the assistant. So what I'm doing is I'm just pushing my stent assembly over the guide wire. So I've gone in. So now my marker is at the level incisor. I don't know, you can't see this thing, but my marker is at incisor level. The one I placed at 16 centimeters. So that incisor marker is at the incisor level. So what I will do, now I will hold the stent assembly like this, fixed to my abdominal wall, and I will just pull back my outer catheter slowly and slowly. Can you see?
We have the fluoro?
They will show the fluoro. Fluoro, please.
Show the fluoro.
Where the fluoro? I can't see the fluoro. So I'm just pulling back my outer assembly. Just see slowly and slowly, without changing my position. So now I will again hold. Just show me the fluoro. And be relaxed. So even if there is some bad position, it can be readjusted. There's not a problem. Now you can see my stent has opened partially.
Sir, do these
I'm pulling back.
stents have force shortening? Do these stents force shortens?
Fluoro. Again, can you see? Slowly the opening. Slowly and slowly. Move up. Fluoro. Fluoro. Okay. Okay, so I'm just about to release the stent. Now stent has been released, so we'll check the position endoscopically. If required, we can readjust the stent. So I'm taking out the assembly and we'll do the endoscopy again. So we'll just check the position of the stent. Endoscopy view. Endoscopy view. Okay.
Khurana sahab, you are very fast.
So I'm going in slowly and slowly. Now just see. You can see it is 16 centimeter. Anybody
Very
with
nice,
me,
very
they can
nice.
see
Very
it is
nice,
16
yes.
centimeter.
Wonderful.
Exactly 16 centimeter. Can you see? So, but do not try to go to the stent too much. So now stent is fully, that fissure is totally covered. So I'm not coming out slowly, and so I'm coming out.
Would you like to do a contrast study before starting
I
these
never do. I
patients?
never do.
There are few things which I never do.
But sir, in this
Parker,
patient,
no
I think
contrast
we should
study.
do, because there
Doctor
may be
from
some
the
contrast
the
passing
writing.
by the side of the stent into the
Yeah.
fistula.
It takes
The
time.
fistula is very big.
Excellently done, Dr. Khurana. Now we are going to room number 1 with Dr. Zahir. Very nice, Dr. Khurana, please.
So can you see the lesion? We converted it to ESD. It was not deep enough. So
Lesion appears to be arising from muscularis mucosa?
yes.
Okay.
And because the bulk of the lesion lies in submucosa, sometimes we interpret on US as it's arising from.
Zahir, why you change the plan?
So the plans are meant to be changed. So in such cases, because if I try to separate the lesion from the mucosal layer, the superficial layer, I'm going to fail. The reason being, the lesion appears to be arising from muscularis mucosae. That is the second layer, which means that the only a small superficial thin layer
Very
will be present.
superficial.
Yes. So in such lesions, basically stir is not meant for such lesions. And ideally in these cases, and the plan is changed once you have cleared along the muscle side of the lesion. So once you clear along the muscle, you are sure that there is no more attachment left. And then you can go ahead with your new plan. Because if there is slightest of muscle attachment and there is a chance that the lesion, there may be a muscular injury later on. So that will be a problem for you, because then a robust closure will be required. But in this scenario where the entire lesion is arising from muscularis mucosae, I have no problem in converting it into ESD. Now you can see if I show you the amount of attachment left, that's a very small attachment left.
Yes.
That you can see here. You can see this is the only part that is still attached.
So the 7 o'clock is the only part probably which is attached.
Yes.
Sir, can this lesion would have been subjected to band EMR also?
So it was a bit longish
Yeah.
lesion. The only problem in band EMR is I doubt if the length of the lesion, the depth, there is no problem. If this lesion was not long, it's very easy to do it, do a band EMR. But if the lesion is not so,
what about conventional EMR?
Conventional
Yes.
EMR can also be done.
Yes.
Can you do an underwater EMR in
Very nice.
esophageal lesions?
Very nice.
Yes, if the patient is intubated, I think we can do it. So this is the
Any
final
advantages?
slide.
So amazing work, and you can see the field is completely clear. There is no vessels at the base. We have to make sure that all the vessels are being coagulated. We will retrieve the specimen and then do a relook for the base again.
Yeah.
And then we'll stop the procedure.
Very nice, Zahir, very nice. Excellent presentation.
So not a big lesion. There is, we'll just see if there is any muscle injury, and it can be left as such. There is no.
So which lesions can you leave as such? Can you leave a stomach lesion as
There's
such?
no, all. In fact,
So-
there is no muscle injury except for right colon
Okay.
and duodenum, which is where the muscle is very thin. I think rest of the places you can just leave it like that.
So we need to close all right colon lesion, all duodenal lesions,
Yeah,
and
right
all
colon lesion,
muscle
more than
injury
one,
lesions.
yes. More than 1 centimeter right colon lesion, I will close. Those on antiplatelets, I will close. Those on anticoagulants, where I have to start it the next day or after a couple of days, I will close.
And CKD also.
Yeah, CKD, bleeding, those who have bleeding tendency, right? But yeah, this is fine.
Very nice demonstration, Jair.
Thank you, sir.
Very good.
So I'm using, in this case, I used a Fuji scope, EG760Z, right?
Z.
Because Fuji guy was looking with anger at me. Let me tell.
With a tapered cap, Fuji cap.
With a tapered Fuji cap.
Ec-
And we
So
Yeah.
this
used
tapered cap is useful for lesions when you have to get underneath the lesions. It's also useful for beginners when you want to start third space procedures, it is helpful in your entry, and you must have it in your armamentarium if you are willing for third space endoscopy.
Yeah.
Coagulation required there?
Yeah. If we are not closing it, if suppose we were closing, I would have, there is no need. And you see that we really don't use coagulation forceps now too much. And that saves you one accessory. Yeah, my fault.
So this is a precise sec that you are using?
Yes. So all potential bleeding
Yeah.
sites, they have to be managed.
What is the advantage of precise cut?
Precise sect has it is intelligent mode. You can say that it's a mode.
Thank you, Zahir. Now we are shifting to the other room. I think it was an excellent job you have done.
Thank you, sir.
It looked very simple in your hands, actually. Thank you so much. Now we are shifting to room number. Which room number? OT4. We are shifting and we are presenting the case.
रहने दे वैसे उसको close कर.
So this is a 46
फिर से
46
दबाओ.
year male.
आई जो है नीचे वाला 3 को 4 कर. दबा उसको 4 कर. हाँ, अभी क्लोज. और अभी इधर 4 को एक दबा ऊपर. हाँ, उधर प्रीसाइज से कर. हाँ, इसको 4.5 कर.
So this is a 46 year male
Close.
presented to us with
अभी लो.
complaints of constipation and intermittent pain abdomen from last 2 months. He was having FOBT positive anemia. The CT imaging was suggestive of a large sigmoid colon polyp. Colonoscopy confirmed the same. Biopsy was taken during the colonoscopy, which was suggestive of tubulovillous adenoma with low-grade dysplasia. The plan was to go for EST with of sigmoid colon polyp. This is the colonoscopic image, and this is the CT showing the sigmoid colon polyp. Now we'll proceed towards the case.
Amol, you are on.
Okay.
Yeah, Amol, you are on.
Sanjay?
Yes.
Okay.
Good evening.
So we put in the scope and
So it looks you have a difficult case, Amol.
again in the sigmoid, I think Dr. Kalla has given me all sigmoid cases.
Yeah, it looks very big.
Today you must have eaten a watermelon because you are getting big cases.
No. But the first case, fortunately, I did not have to do anything.
Yeah.
We have left it for the surgeon.
Yeah.
Now here also, you can see that this is a polyp. It is kind of a semi-pedunculated polyp. Let us first look at the surface. The surface looks more like a JNet 1A, 2A.
Can you apply NBI on this?
Yeah, I'm just applying NBI. Predominantly,
Yeah, it looks
it's
good.
a 2A kind of a lesion. With a little bit of mucus which I am washing. But no obvious dysplasia. There is some villous fronts, and here probably because of biopsy or because of scope trauma, there is a little bit of oozing. And overall, the lesion is very much 2A like a lesion.
What are the chances of these type of big polyps having peduncles?
Pseudopedicles, yeah, I mean, there is a pseudopedicle. As I'm going there actually to show you the pedicle. I don't know whether to call it a pseudopedicle or a pedicle, but you can see that there is a small attachment. So the attachment is much shorter, narrower over here.
This probably could be just because of the weight.
Yeah, because of the weight. It looks like because of the weight it looks like pedicle.
So this is not good for applying a loop and cutting.
But the other important thing is when it is at an angle and there is this kind of a pseudopedicle, there can be considerable fibrosis at this point because the polyp keeps prolapsing.
Yes.
And that can cause fibrosis. So that is the main thing. So what we will do is we will inject here at the pedicle and then elevate this. I'm going to use gelofuscin.
Yeah, do putting some more water will give you the direction. If you can change the position of the patient and
Sanjay, this is a sigmoid, so changing the position is not going to give me any benefit.
no, it will reduce the weight of the polyp, and you can be easily.
We will first inject, let me see, because just now I'm getting a good position to approach the pseudo stock, at least the base. Sometimes after you change the position, you may not get that. So let us at least inject and see. Needle.
Dr. Mole, do you think that you really need to do such a procedure of ESD, and this can't be just put an endo loop and leave it out?
He's telling that endoloop will not be effective, and this is not a good case for putting an endoloop because
Endoloop,
it
you
is
may
a
not be
pseudo
able to
stock.
get an envelope.
But the stock is quite, I mean,
After injecting, he will cease.
It's actually not a stock.
Yeah.
See, putting an endoloop, I have no problem. We can put an endoloop. The stock is very short. So when we cut using a snare, there is a high risk that the endoloop may get cut. Needle.
And it is not very
Yeah.
a good idea to just
Right.
loop it and leave it.
Yes.
No. That I think we need histology on this polyp. I don't
And do you
we can
think,
just-
sir, EMR will be enough if you inject it and it is very good lifted? Can we do EMR of this type of polyp?
EMR could be done technically, yes. It
Yeah,
can.
Dr. Amol.
Yes.
Yeah, we are shifting to the other room for showing some interesting finding, and then we'll come back to you.
Sure.
Surely, sir,
Okay.
surely.
Yeah, there's a patient where actually we did EPT
Surely,
for
sir.
biliary stenting, and there's an interesting finding there. So we shift to the other room for that finding. Yeah, room number 2.
I think if you can
Yeah,
inject,
Nilay, you're on.
inject good amount of fluid and get a good cushion,
Yes,
you can
Nilay.
do EMR in this type of cases.
Do a piecemeal EMR?
Yeah. Mostly this type of lesions I have piecemeal EMRs. Nilay?
Nile, can you hear us? Dr. Nile?
No, he's not audible.
Is it a stent with the blood around it?
Yes, lot of clots, maybe hemophilia.
He must have removed the stent, it must have come with it.
Yeah, one must have.
Okay, can you all hear me?
Sanjay? He must have removed the stent.
Sanjay, can you listen to me there?
Yes.
Yeah, we can hear you. Yeah, this is quite an interesting situation. This patient was referred to us. We requested all our friends to send these patients for a US FNAC because radiologically it was an operable CA-HOP.
Okay.
Dr. Nijaman had sent this patient to us.
No, but
Unfortunately, when
we're getting our
we
AV
landed here,
situation
the second
sorted.
week post-procedure, this
my
patient
bad.
had a bleed.
So yeah, can you hear us in the audience? Can you
scheduled
please
to do a US FNA, but we requested him to see this problem also, which if we encounter sometimes how best a senior person manages this situation.
Yeah, can you let
What
us
do you
know in
delay?
the audience if you can hear us?
no, you people are not clearly audible.
Okay, we are not audible.
Now it's okay.
Now it's okay?
Yeah.
Dr. Rajput?
Yes.
Yeah, okay. Good. Yeah, so you got your mic?
I don't know.
Okay, you're getting the mic?
Sanjay, am I?
Yes.
He's
Hi,
getting the
Nilay.
mic. So yeah, this is a
Ge-
patient with a
Am I audible, Sanjay, there?
ERCP and a
Yes,
plastic
yes.
stent and has a drop in hemoglobin by 5 units from 14 to 9.
Yeah.
It is suspected malignancy. So this patient had bleeding, lot of blood in the stomach, and therefore we are doing ERCP to assess where the bleeding is from. Now it appears that a temporal relationship to bleeding from
Saurabh, your voice is cracking, so you have to change your mic.
Okay.
Okay, so am I audible there?
Yes, Nilay.
So basically, this is head of pancreatic lesion, and they had done ERCP and put a stent before 4 days, and now patient has presented with melena.
Yes.
And this is what we are seeing. So it's a post-papillotomy bleed.
Yeah, is it hemophilia? You suspect hemophilia?
Yeah.
Yeah.
And
this patient upper GI are bleeding.
so looks like pneumobilia versus papillotomy bleed. Yeah.
Nah, because the stent is clotted and lot of blood is seen around the stent.
A stent is going in. Open.
It's about 3 days out, 6 patient got this.
So I'm trying to see what exactly is happening to this patient. This stent is coming in between. So I'm trying to take it down, but it will fall back. Then we'll have to take out the stent. Open. Okay. So now we are better. Now give me water. So we need to see whether the blood is coming from inside or from the papillotomy.
So what do you typically, what was your approach to handling
Like, do we have a fully covered stent
So in
available
most
there?
cases depends on two things. One is while doing the procedure.
Yeah.
So if we are doing procedure and then bleed,
Sir.
then and if it is halfway,
Do we need
yeah,
to
I
have,
think it is papillotomy bleed. Pani.
do we need to have a CT angio before removing the stent?
I can see there's obvious bleed coming from the sphincterotomy side. So I think this is, it is coming from. It's almost like a vessel, is it? No. Yeah.
Nilay,
Yeah.
there is a question. Do we have a CT angio?
No. Actually, this is a different story. This patient was to be taken up by EUS and
Okay.
to see for locoregional staging
Okay.
and FNA. But
Okay.
then patient complained of Malina. So instead of putting EUS scope, we put ERCP scope because we suspected because papillotomy was done before 4 days, 3-4 days, that is the most likely cause of bleed.
Okay.
Now the question is what to do.
So do you keep fully covered metal stent in your room before
Yeah.
doing this type of cases when you see this type of bleeding?
No, I think fully covered stems is a great idea. I mean, it works really well pretty much all the time. But I think if we can manage it with, I guess, clips and injection, what is your thought?
Yeah, so that is what we were discussing. If the bleeding occurs while doing procedure, then if we see if half papillotomy, then we complete the papillotomy. Many times it stops on its own. Put adrenaline, put saline adrenaline injection, or something and something
Do you
which is
think
not
there is a
getting
large
controlled,
vessel?
then the base thing, looks like.
Yeah.
I don't know whether it is clot or there is a vessel beneath. So if it is a uncontrollable bleeding, then probably the best way is to put a SEMS fully covered, or if that doesn't solve, then only treatment is angiography. Don't do surgery.
Yeah.
Cannula.
Most of this bleeding can be
Got
controlled
mechanism.
endoscopically or the angiographically.
Huh?
Nowadays, we don't send the patient for surgery now.
Yeah, we have to do CT angio if it doesn't control with SEMS. Get control with SEMS.
Yeah, I think the least invasive is like an injection, then you put a clip. If that doesn't work, I think then a fully covered stems. And by and large, with all of that, I don't remember any case which had required surgery or angiography.
SEMS, no, yeah.
After having the
definitely not
fully covered stems around, I mean, I don't remember the last time a patient had to go for surgery for such type of an issue. Yeah.
We could put in coils after doing a CT
What is this
angio.
protruding lesion actually?
Embolize.
Okay. That's the sphincterotomy. Okay.
Yeah, it's a long sphincterotomy. Yeah, someone was asking me something.
Yeah, it looks something protruding.
Nile, what has
I
been your
think the
experience?
bleeding is
Nile,
from this age.
Yeah,
The clot, yeah.
I think it's an adherent clot or
yeah.
so.
Shall we put
Probably,
a-
yeah.
Dr. Nile, can you hear me?
Huh?
Nile, can you hear me?
Yeah, we can hear you. Please go ahead.
See, if the stent is smeared with blood, it is unlikely to be a post-EPT bleed. See, the
You
whole
think it
stent
is
was
coming
smeared.
from inside?
It's coming from inside because the whole stent was smeared with blood and it was
Yeah, it's
clots.
from the
See,
papilla.
post-EPT bleed should not have stent smeared with blood. When you took out the stent, the whole stent was smeared with blood. And if, for example, if you do a CT angio and you get an aneurysm, would you prefer a radiological intervention or would you like to do it yourself?
No, I think the stent is clear inside, so bleeding is not from inside.
No, I think the blood must have gone up into the bile
Yeah,
duct.
stent is very clear from inside. So
if
the
you
blood
see
is
here,
not
there is no
coming
blood
from
coming
inside.
from here. And you see the stent.
Yeah,
which
there,
is,
it looks like a large blood vessel outside.
Yeah, I think it is from the left edge of the papillotomy.
Now you can see the active bleeding, no? You can
Now
see
you can
active
see the
oozing
breast
here.
bleeding.
Water. Let us try to clear the doubt and see what we can do.
If there's active oozing that we can visualize with a adherent clot, I mean, there's no reason to believe it's coming from the.
I think the vessel is beneath the clot, I think.
Yes, beneath the it's a large vessel, yeah.
Let us put a clip straight away. What do you say?
Yes.
I would suggest maybe
Take
put
out the-
injection epinephrine first. I would prefer to add injection epinephrine.
I would
then
try
wait
to,
if it up-
no, I would do clip straight away because if I put injection, then
Yeah,
I
it
would
will
not
swell,
know.
yeah,
If it
it-
stops, then
Yeah, it
I
will.
stop. If I do clipping and it stops, then I'm 100% sure that it is a
I
bleeding
think
vessel.
clipping is better option
Yeah,
than
yeah,
the
yeah.
injection. Yeah.
You have Boston clip. Uchilar kai clip છે આપણી પાસે. Better option. I'll first do. I told you why I'll put clip. Yeah. The idea is that you want to actively see that the bleeding is stopped. Yeah. And then then I'm 100% sure. No, fair enough. Because anyways, FE is just a temporary measure. So it's
So
not a
clip
long-term.
versus soft coagulation.
Soft coagulation, you can try. No harm
Yeah,
with
but
that.
if it starts
the
bleeding,
problem is there is a clot.
And
So
s-
soft
and-
coagulation will not work. I
and
have
the
to
ve-
remove the clot.
Yeah,
You
Nilay
want me to
vessel.
remove the clot?
No. It looks like a major vessel because patient has dropped down
Yeah,
of
yeah, yeah.
hemoglobin.
So I don't want to
and-
remove the clot. You
Yeah,
want to
yeah, we
remove the
cannot
clot?
remove.
I would not remove
Patient
the
will
clot.
bleed torrentially and you will not see anything after that.
Yeah, but
CT
if you even had to do it, I would do
angio
enough
followed by
epinephrine
coils.
before that.
That should be the answer.
I think a clip should be fine. Yeah. I'll do it from here. Yeah. From up to down. No, but
Which clips will open, Nilay? Which clip will? There are chances
No,
that.
I prefer Boston 360 Ultra.
Okay.
Because see, all the clips are good, but when you want proper hemostasis,
Yes.
maximum power,
Yeah.
this is the clip I use.
I think Cook is also good.
Cook is also good. Cook-
Instinct is good because
Yeah.
they open up with the ERCP scope.
Yeah,
Other clips don't open as good as.
No. Cook clip, it is difficult to open, na?
No, Instinct will open, I think.
Yeah. But now we have opened Boston.
Okay.
Yeah. Is it okay if I use Boston?
Yes, it's okay.
Yeah.
I thank these set of chairpersons for their nice discussion. May I invite the next set of chairpersons and the
Can you
moderator.
hear me?
Dr. Kapil Sharma, please come on the dais.
Nilay, we have some China clip which can open
Saurav, can you hear me?
worst position.
Dr. Sunil Gupta,
We have got few China
Dr.
clips.
Sudhir Mahershi,
No, I think
Dr. Kapil Mohta,
the other question is
Dr. Surinder,
if you're looking
and
at
Dr. Ashok
Nilay,
Jandaria.
are you getting my voice?
Sudhir?
Yeah, the other thing is if you had see this, Sanjay, are you there? I think it is from the age. Yeah, it is. I think it's pretty obvious that it's a source.
Dr. Dinesh Agarwal,
Open.
Dr. Dinesh.
The question for me is if you're dealing with ulcer bleeding, not oncogenic like this. Make it open. FE plus clip is proven to be slightly better than clip alone. That's the reason I was questioning. But I don't know if it applies to us.
I'll say again.
Yeah, it
Dr.
opens up very well.
Your
Nilay.
guess
Dr.
is
Sunil
as good as
Gupta,
mine.
Good choice.
Close it.
Dr. Kapil Mohta and Surinder Kaswan, Ashok Jandaria.
हाँ? नहीं ओपन नहीं क्लोज नहीं हुआ सी no, that is because of ERCP and elevator. Yeah.
हाँ बोलते रहे.
The elevator, no? Yeah.
See, this is the problem with the
no.
clips, Nilay. When you open it and then they get released during this.
I think he got a perfect position, but once it closed, it did not deploy. I think that's the.
Yeah, they don't deploy when you want.
Yeah, the other.
So we have got some China clips and they are opening it and they are closing very
Medora. Let's
easily.
try Medora now. I think we're going to try all the clips until one fixes.
Yeah.
That will be a live experience.
Which works? Which clip works? That one did not.
This is instinct.
But the other question raised is there's a lot of data on rotatability of clips, and especially with the duodenoscope. Yeah, I think that's a good area.
Yes, this is good position.
But I think the question is with the elevator, how
Yes, with the
easy,
elevator.
difficult is it for you to close it then, right? That's the problem in such scenarios. See, I think that's the.
I think Microtech has this Mantis clip. They also get close. Yeah.
Okay, nice. Well, it's still there. It's not been deployed. Do you want to go long? Would you do long position? Yeah. Gloves, please.
Sir,
Gloves, sorry.
Dr. Madhura here. Do you want
Here
to go in with a
instinct will
cap
work.
and a forward viewing scope?
Scope
We cannot hear you.
A forward viewing scope with a cap. I mean,
Yes.
for our sphincterotomy bleeds, that seem to have helped better because this clip problem coming out with the
Yeah,
elevator.
Nilay, there is a suggestion of forward viewing scope with the cap and then you can apply this clip.
Yeah, you can do that, but let me try this first.
Yeah.
But I think we have not given enough time to this.
Getting the the other Dr. Shrimpi is here. She was wondering if we can do a needle knife coagulation or one of the. What's your thought on that?
No needle knife coagulation. If I am using coagulation, yeah, close it. Coag grasper, yeah. Close. Yeah. Close. Okay.
Yes.
Very nice.
Wonderful.
Now I need more water to see what is happening there. Okay, no, give me this only. Let me try to take out the clot if I can. Yeah. So I've used the small
Coag grasper forceps in side viewers because the problem with the side viewer is with the elevator, coag graspers, you want to use maybe a smaller one. That can be an option. But again, I would probably do epinephrine injection before that.
I'll do afterwards.
No, of course. No, I'm saying coagulation.
That is my way of not agreeing with you.
No, if you had to do coagulation grasper forceps, maybe in that case, then it's really,
Yeah,
you know,
for coagulation,
you have to remove the
adrenal-
clot, look at the vessel, target it. So in that scenario,
Delay.
Yeah.
Can we go to the other room for some time and come back?
yeah.
So yeah, no problem.
Sure.
Yes, sure.
Now
Okay.
there is some bleeding.
We go to Dr. Amol. We'll see at what stage he has gone for ESD. Yeah, Amol, you're on. We can't hear you.
Hello.
Yes.
Yeah.
Yes.
So
Amol.
we've completed approximately half the circumference on the anal side. And you can see over here that we've dissected under the polyp also.
Yes. Very nice dissection, Amol.
And centrally there is some amount of fibrosis, which you can see.
Yes.
But so far we have not encountered any major fibrosis.
Amol sir, what are the
Yes.
tips and tricks to avoid a muscle injury while dissection of these large polyp lesion from?
See, basically a few things. One is copious injection, inject over here. Inject karo.
Because the tip of these knife, they tend to face the muscle.
No, so you have to modify and move your scope position in such a way that it becomes tangential. Now you can see the muscle underneath. Give me the knife.
And see the plane in which he is dissecting.
see
You
the
can
plane
see
in
the
which I'm
blood
dissecting.
vessels are all
On top.
On top. He is dissecting below. This is the SM3 layer.
I am dissecting only with the tip of the knife.
You
And
are-
you can see that I have also put in near focus over here, and I am dissecting underwater.
You are using tunnel as a method of traction here, sir. This is tunnel
This is
ESD.
more like a pocket.
Okay.
Here you can't, the lesion is too small for it to create a tunnel as that kind of a thing. But we are more of a pocket. It's a pocket ESD.
And Kapil, the problem is with such a bulky lesion, it is not very easy to go do a retroflexion
Yeah.
going above it.
So I did a retroflexion, but I could not see the margin from above. So that's why then I again came back to the.
So the plan is to dissect as much as you can in the forward viewing, taking mucosa bit by bit on both the sides. And then
narrow the pedicle
Yeah.
on the distal side, on the oral side, and then we can further this thing it. Back lelo. Right? And inject here.
Amol, you're using a gastroscope or a
Yeah,
colonoscope?
it's a gastroscope. Makes my life easier, sir, because handling the scope in the sigmoid becomes very difficult otherwise. So I prefer the gastroscope whenever I can use it.
You are
So
the-
you can see the mucosa on top. That is the mucosal incision. You can see just at 12 o'clock, 11 o'clock.
that margin which you
Margin. So I have pushed the margin on this side, on top over there. So what I'm going to do is I'm going to dissect from here
and
and reach, cut that margin.
Yeah, the picture looks like a rainbow from here.
Acha, actually, I don't know why.
There are multiple colors in them.
Probably because underwater the white light is getting diffracted.
Yeah.
But actually, underwater, you will get a good image, very good image.
It looks very beautiful from here.
In underwater, only cut current work. The coagulation is also work.
Well, coagulation also works. You have to use a little bit of high coagulation. And the other important thing is you will get a lot of bubbling. You have to keep irrigating intermittently, or then you have to sometimes use a slightly different coag current.
Here you are also using some injected viscous solution like a jelly fusion, sir?
Yeah, so I have used yellow fusin for the primary injection, and I'm using irrigation, water irrigation or saline irrigation. This is actually saline, it's not water. We always need to keep water because saline, because otherwise it can cause, electrolyte imbalances also, because sometimes we put in a lot of water when it's a large lesion. So you don't want that to cause any.
So that is, I think, a practice with all of us doing third space, that in the flushing
Flushing
tank,
pump always
we
use
always
saline.
fill saline.
Never water. It is called a water flushing pump, but should be always saline, never water.
Sir, for beginner, we can also use some kind of additional traction here.
See, Kapil, this is a semi-pedunculated lesion. So here traction is going to be very difficult, actually. Traction may not give you the desired, effect. Here cap traction and buoyancy actually will give you more.
Traction would work for mucosal lesions.
For flat lesions.
Flat lesions. Anything apart from that, trying to use traction may or may not work in your favor. So you have to be very careful. Okay, it will not always help when it's quite cumbersome in sigmoid and areas like that. Lower rectum, stomach, I think it's better for mucosal, flat.
Yeah, lower rectum, even right colon traction works well. But sigmoid, it's very difficult. So here, I think it's only the mucosa which is remaining, Pankaj.
Yeah.
That's what I feel. Because this polyp has fallen back. This is the mucosal incision. And it is coming from this side. Give me some injection over here. Needle back le lo. Inject karo. Bas. What I'm going to do is I'm going to make a mucosal incision here from, this is slightly against the principles because I would not want to cut from the mucosa to the muscle. But here I am going to be doing that because that is the only direction that I'm getting. But because of that, I have to be very careful about doing that. I'm also pulling my knife back and my scope back. But what I may have to do now is probably again try on this side.
So on lateral.
Needle back.
Hello.
Needle
Amol,
back. Yes.
we'll shift to the other room for some time
Okay, inject
because
karo.
your case is very, very long.
Yeah,
You again, okay?
We'll come back here.
Yeah.
Needle.
Yeah, Nilay, you are on.
What we
Nilay sir,
did-
you are not audible.
Yes, yes.
Am I audible now?
Yes, yes.
So basically, what we did was that we dislodged the clot, and now you will see bleed out. Take me.
We can still see some kind little bit ooze.
And you see it's a pulsatile arteriole which is bleeding.
Can you see that?
Right? I mean, I can see that very nice pulsatile.
Now we have change of plan. First, we'll do try to see coagulation.
I told you on the first impression, there is a big vessel behind.
Everybody told the same thing, but we need to find it, and we could find it because there is no clot now.
Yeah, I think. Do you think there are two areas or there's just one? What is your thought?
Yeah, I don't know. You have?
I think there's one on the right and almost on the left I saw.
Can we pick up these vessels by the coagulation grasper forceps?
Yeah, it's a good suggestion, and it's exactly what we are planning now.
What is the plan?
We are getting coagulation grasper forceps to coagulate the vessel. We are getting this arranged in the room. That's why it took us a little time. But I think we are in good shape now. We're getting a small coag grasper forceps.
This is mini coag grasper?
Mini. You see, mini is better, I think, in my personal opinion, because going through the duodenoscope versus a regular one, because it's a small vessel and mini should address it.
You will use the soft coagulation now.
Yeah, we're going 4.5 soft coagulation settings on the
with knee or B machine.
This is a ERCP and soft coagulation 4.5. And we'll see the magic. We'll see the magic happen now. Yeah, yeah.
Nothing is happening.
Okay. Is it padded well? Okay. Patient is padded? Yeah, okay, let's hold it. Dalo, yeah. Do you want to put it on the thigh? Maybe it's not padded
it's
well.
okay, not
It's
in-
not passing the current, you know?
Now it is started bleeding. Huh?
Started? Is it working? Yes, now. Sorry. Now try.
No.
Okay. I think the socket. No. Oh, what karo. Okay, soft coag. Sorry, we're figuring it out. Technical stuff. Chalo. Okay, yeah, now we can. Okay, now it's working and we can hear the nice sound.
Nothing is
Feel
happening.
so? No, I think it's must be doing. Yeah, it's making a noise though. So yeah. No? Okay, open.
Open.
Sorry.
नहीं हुआ है, नहीं कुछ नहीं हुआ है. Open कर दे.
Yeah.
Open. Clip ले ले नहीं तो. Close.
Not working. With the papillotome setting, so I don't know. We need the coag grasp for forceps setting. We should not do it on this.
Open.
The ERCP setting, we can't.
ERCP setting मत करो, उसको ESD या poem में ले जाओ.
Sorry, let's
उधर का soft coag करो.
इसीलिए बराबर setting था पहले. Let's do this. Yeah.
Open.
D. Okay. Sorry, you'll have to wait for a moment. Huh?
Is it?
Yes, because this one is not connected here.
Even we can use a needle knife and we can use a spray coagulation for it.
It's taking it, no? Okay. But it won't take it. No, open. It's incision and tunneling. We need a coag grasp of setting for coag.
So we are waiting for the cautery to work and there is a bleeder over here. हो गया भैया?
This is lighting up. This is not lighting up. Yeah, this has to light up, no?
कोई यहाँ ध्यान आपने पहला.
Nilay, there is a suggestion of spray coagulation.
Yeah. Eventually, probably we'll have to do it. If
Okay, I think it's got it now. But do you want to try now? I think we are fine. Let's try it now. Yeah. Okay.
Nilay.
Yeah.
Dr. Nilay.
Yeah.
So we were all wondering. That
Working fine now? Yeah. Okay, fine.
Yeah.
Okay. I think it's saying that now.
No, it's not happening.
It's making noise. No?
Noise, but nothing is happening there.
Not burning?
Should we need to change the cautery?
Yeah, I think we are just.
No, place a clip. Give me clip. First wash and then clip.
Yeah.
Give me Boston only. And give me water. And give me fast now. Whatever you are giving, give me fast and give me water, please.
Yeah.
Dr. Nilay?
Yes.
So we were wondering that like if you take a TTJ, you will have the
Yeah, you can do spray.
but advantage of flushing as well.
That is a good idea, but
so if you can flush, you'll be able to see the location. So
I know where it is bleeding. Give me clip.
I think there's only one spot which is very obvious in the middle of the
But
screen.
now I can't waste time. Now I have to do
Yeah,
something.
I think the cautery is not.
Give me any
working.
clip.
Clip. Yeah.
Nilay, you can see the blood spurting from the edge.
Yeah, open. Yes, please.
Yeah.
थोड़ा
Okay,
घुमाओ थोड़ा भैया. घुमा. एक मिनट.
So amongst the clips, I think Boston 360 is a nice rotatable
This
one.
is not Boston.
But it's not Boston.
This is not Boston. This
Because
is
the Boston did not deploy, unfortunately. So we're using a Medora clip right now.
घुमा.
And we are managing to get the rotations. Okay, nice. That's good. I think that's good, right? Yeah.
No, it's not good.
But this it'll get the other side. and
The
we wanna-
problem with all these clips are movement during the elevator open, elevator up.
Yeah, I think I
Yes.
maybe
yeah.
opening the
Yeah,
elevator.
I think
that's
this
good,
looks
that's good.
better.
This looks great. Yeah, go close. Oh, sorry. It's very tempted to say close. right now.
Close.
Yes.
Okay.
Let me see.
So it looks good. I think the location is perfect.
Yeah.
But
So what I'm
I
doing is
cannot-
I'm
yeah.
opening the elevator a little bit, so you'll not able to see the clip. Close, Baba. Close. થયું કે નહીં?
I think the clip mechanics are compromised when you use the elevator. There's very
So
nicely
you have
placed
to open
clips.
the elevator. You have to go away. You will not see the clip end transiently, but I think this is fine. Give me water now.
Yeah.
Microscope.
So that's it. I think very nicely demonstrated. You something to remember for the youngsters.
Wonderful.
I think is
Can we irrigate with water and see whether we
Yeah.
are controlled?
Yeah, that is what I'm doing.
I think the elevator has to always be open when you're making movements or deploying the clip. So you may not see it on the screen, but that's the advantage is the clip will deploy correctly. It will rotate correctly, which when you use the elevator, then you have problems where the clip is not deployed and then the rotation is a challenge. So of course,
I think it is not bleeding now.
I think it's worked fine now.
Sanjay, what do you say?
Saurabh?
Yes.
Yes,
What
now
I
the
was
bleeding
wondering
has
was,
stopped.
In your practice, how many times you
Yeah, we can
sorted
continue
to,
with the ERCP.
IR procedure for doing embolization to gastroduodenal artery?
Oh, wow. No, how many times will I have had to do? I have not seen it done even once. I
Yes.
mean, I'm not very old, but
Yeah.
but
Sir, you
at least
will
in the
still
last
do
10 years
angio
in
in this patient?
gastroenterology, I've not seen it happen.
Yes.
For post-sphincterotomy bleed.
Sir, you will still do angio in this patient?
I'm sorry?
You will still do angio in this patient? No?
Will we do
NJ?
NJ? Oh,
No,
I
angio.
don't think NJ is required at all.
No. Only if he keeps on bleeding, then yes. Otherwise, no. I
Yeah.
think he has stopped.
I think the nasojejunal feeding idea is probably going to do it.
Angio
No,
or
he is
NJ?
not for angio.
Oh, are you saying angiography?
Nasojejunal tube is not required,
Not
and
required.
angiography is also not required.
Yeah.
Unless he keeps on bleeding.
No,
But
even if
even
he rebleeds, you can again use the
Go, go.
endoscopy.
Yeah.
We can
Yeah,
again
we-
go for endoscopy.
We can do
We
that
can see
or
the
just
bleeding.
replace it with a fully covered metal stent. That will pretty much address
No,
it
I
if
don't.
it happens again.
I don't think it is peripheral, so it metal stent will not work in this, Saurabh.
Yeah,
It is
it's at the
peripheral.
edge.
Yeah.
So what is the opinion of house? Bleeding is on or gone?
Bleeding has stopped for now, but after finishing procedure, we have to have a relook and maybe the
I think
later.
this should be
Yeah.
fine.
It should be fine.
Yeah.
Will you go ahead with the US?
So here
Epinephrine.
everybody says it should be fine.
To make us feel good, we can add some epinephrine. So that will be like
No.
perfect.
I think this is fine.
Do you also change the stent? Because I think this stent is already blocked.
No, this is not blocked.
Blood on the outside.
Blood on the outside. And if you see papillotomy is too big, there is of course lower CBD block. So I think otherwise also we have to come back again a day after tomorrow and see if there is any bleeding or not. If there is no bleeding, we can do EUS and take biopsy and other things.
So, Nilay, you want to delay the USFN?
Oh yeah, I would not combine two
Yeah,
procedures.
that's what we were thinking. Yeah.
Do you want to combine, Saurabh?
Agreed. That is not an urgent procedure,
Yeah.
so we can wait it out. Give it another
You
48
can
hours.
do it. It is not so unsafe.
Yeah, let
but
us tide
why-
over the crisis first,
Why
yes.
to do it? Yeah.
Nilay, while doing ERCP, what are the risk factors for this kind of a bleed?
So basically, if you see the papillotomy, it is too big actually. So first of all, we should know for what we are doing papillotomy. If we are doing papillotomy just to place a stent, you don't need such a big papillotomy. And otherwise, any papillotomy can bleed. There are no fixed criteria, but longer papillotomy, there is a when you
Say
are
cirrhotics probably.
Yeah,
Maybe cirrhotics.
anticoagulant, antiplatelet,
Antiplatelets,
cirrhotics,
anticoagulation, CKD.
CKD.
Yes, liver disease, kidney disease. Yeah.
Saurabh, this is second week of procedure.
Sorry, yeah. Second week.
Yeah. Sorry, I mean, I'm just told that it's the fourth day of post procedure.
Yeah, day 4.
It's a delayed bleed here.
So I think we all consider 96 hours post cutting a muscle, I would say, is always a risk of bleed. So even for starting anticoagulation, you want to know 96 hours after a sphincterotomy, you should start anticoagulation,
the
right?
word you used is very important. This is a muscle vessel.
Muscle,
This is
yeah.
an arterial, small arterial bleed from the muscle. Not
So we are
from
cutting a
the-
sphincterotomy is a muscle cutting. So when you're cutting a muscle at say 4 days, do not start anticoagulation. That's the way I look at it. You agree, I think?
Yeah.
So 4 days is my rule of thumb. And this is precisely the point. 48, 96 hours we have now bleed at
Yeah, I
three and
think
a
the
half days
bleeding
out.
has stopped completely.
Yeah.
Good job, Nilay.
Thank you. Great. Thank
Yeah,
you.
thank you, Nilay. Thank you for such a nice demonstration of managing a complication. Thank you so much.
Yes, thank you.
Now we go to Dr. Amol case.
मेरा आवाज जा रहा था।
So switch on to room number 4. Yeah, Amol, you are on.
Hello, sir.
Yes.
Yes, now you are audible.
कितना रह
So
गया?
we are going bit by bit.
Yeah.
We're going bit by bit. We are going around. The patient is pushing a little bit too much. So that is the reason we are taking a little bit longer. Inject here.
What was happening was the lesion was.
Lesion keeps falling. See, if the
Yeah.
patient pushes, there is straining, then the lesion falls forward and then you can't see the margin very well. So that becomes a problem. So now we are getting a little bit of plane.
And just because we could not get behind the lesion, we have turned the patient to
Yeah.
supine position so that now the lesion is falling a little to the left and we are able to get on sides of the lesion, which we are not being able to get in the left lateral. So in such lesions, it is always better to keep thinking where gravity would help you and
Right.
in what direction.
Right here, right? देख के रखो. देख के रखो.
Pankaj?
Yeah.
Yeah, we're shifting to the other room
Yeah.
for some time.
Yeah, sure.
Yes.
Come back. This is
Once
going to
we'll-
take some
yeah,
time.
this will take some time.
So we
Once we
shift
have-
to room number 1. We have an interesting patient with multiple polyps. So we'll be doing polypectomy by different techniques. So the case will be presented first and then followed by the techniques.
I think.
Dr. Kapil,
Yeah.
we
Kapil,
can
how
see
are
you. You
Am I
are on.
audible? Am I audible?
Yeah.
So the case given to me has multiple polyps in the colon. Presently, I am the cecum. You can see this is the IC valve, and we can see 2 polyps. One is in the just at the verge of appendicular opening. Second is in the lower part of this one. So I'm using a Fujinon scope, and I have used the AI, and it shows that both of these are like adenomatous. So you can see on the vascular pattern. So it's more of type 2, I can say. There is no irregularity, and there's a long stalk. So our plan is to remove. I've seen some going
We
down.
can see
up
stalk in
also.
other polyp.
Pardon me?
We can also see stalk.
Yeah. Stalk is there in all polyps. So this one also has a stalk. You can see. And while I was going towards the cecum, I could see multiple polyps in the left side of colon also. So
Any
he has-
special precaution you take while removing polyp from right side?
Yeah,
Any
Dr. Kapil.
cautery setting?
Cautery setting is we should not burn too much because that time.
Yeah, Dr. Kapil.
Yes, sir.
This patient has got some pigmentation over the lips and the buccal mucosa. So it appears to be a case of Pews dagger.
Yeah, as per history, sir, and what I could see is there's no pigmentation.
Yeah, but it appears to be like non-adenomas.
Yes.
Hyperplastic.
So my plan is that for long polyp, I would like to use a endoloop. This one, I think the small one, I can remove with a normal cautery and injection. So I would try
Would
to
you-
avoid too much of burning, so that because the wall is thin on the right side as compared to rectum and.
Would you like to characterize these polyp before you jump into the polypectomy, or in presence of peduncle, does it really matter?
So I think the base gives us an idea. If the base is not involved, even if we do. So it can be a complete resection. So because if base, you can see the mucosa is normal pit pattern. There's no abnormal vascular pattern. And I can just.
Would you change the patient position?
Yeah. So it's separating. So you can see the polyp is moving, mobile.
Would you apply endoloop or clip?
So endoloop for this big one, this one can be clip. I think clip also can be applied, but I think the upper one clip also can be applied. That's also a good option.
I think there is a long peduncle in this large polyp.
I think. What we can do is. तो resolution clip दे दो. There's a bigger one in the proximal, I think.
In the Fuji, does the LCI give us some kind of additional advantage over this NBI alone, because it has a two feature, BLI as well as LCI, this Fuji non-scope?
So as per my knowledge, there is not much added benefit, but Fujinon team can say.
Instead of polypectomy, we can directly dissect these peduncle by dissection.
Resection means you saying ESD or hybrid EMR.
Yes.
So I think this can be, if we apply clip here,
yeah.
And it is already separating, so we can remove it easily. This is already a long stalk, so we don't require to do a.
So, Kapil, what is the plan?
So for this, we will use a clip to clamp the base and followed by polypectomy. This one we'll do inject and then remove. There's a one, I think, a large polyp in the left side, which I think will require a endoloop. So initially I was thinking, but now seeing at the size of the polyp and at the base of the polyp, I think we can remove
This
it with a.
AI is telling us this is neoplastic.
Pardon me?
This AI.
Yeah.
AI tells us this is neoplastic.
Adenoma also it's shown as neoplastic. So anything which is beyond normal hyperplasia, it's called neoplastic by the AI.
So you'll apply endoloop first?
So I'm trying, I'll use a clip here because it is well separating.
Yeah.
So a clip also will, a resolution clip will also work because it will, and over that then we'll cut it.
Okay. We are waiting for the clip, right?
Dr. Kapil, what are the chances of bleed if we cut it directly with snare without applying clip at the base?
Chances of bleed are like 2-3%. Only thing is problem is this is right side of colon. So I don't want to, if it's for rectum, we could have taken a chance, but for right side colon, I would not like to take a chance and wait for rebleed. Because the stalk is not very thick. Suppose it was very thick, then my chances of bleeding directly will be high. But suppose
it doesn't look like very thick.
Thick means at least more than around 7 millimeter or more. इसको ऊपर नहीं बढ़ेगा. रोटेट हाँ बस अब खोलो पकड़ो डोंट डिप्लॉय अभी रुक जाओ डिप्लॉय नहीं करना वेट खोलो इसका मेरे को नहीं आना चाहिए क्लोज
You want to grab it with close to the polyp or close to the wall of the colon?
What is happening? Otherwise, I have to change the position of the patient. Suppose I have to bring it down. I have to change the position of the patient. This is also okay, but I think fire. Size. किसी को पकड़ना पड़ेगा ना एक बार इसको सुपाइन करो
How will measure the size of polyp and how will select the size of snare?
So the opening of that, what we used was around 13 millimeter. So it is bigger than that. So it's around maybe 2 centimeter. So any bigger than 2 centimeters snare will be good. So we are using a 3 centimeter snare. 25 mm snare.
Hello. Kapil?
Yes, sir.
Yeah, we'll be shifting to the other room for some
Sir.
time, then we'll
Oh, sir.
get back to you.
Okay, sir.
We are starting a new case, right? Okay. We are shifting to room number 3. We'll present the case first, followed by the demonstration.
इसको सही कर लो यार
So this is a 30-year-old male patient. He presented to us with complaints of epigastric pain abdomen, which was radiating to back from past 15 days. His previous history suggestive of pulmonary cox, for which he took ATT for 6 months. Last dose was taken 6 months back. On workup, CCT abdomen showed a heterogeneous enhancing soft tissue density lesion, 3 into 3.6 mm at the head of pancreas with loss of fat veins to the duodenal wall. US was done, which showed a hypoechoic pancreatic mass lesion with peripancreatic lymph node. Our plan is to go for US guided biopsy and with more forceps. This is the imaging finding. Pancreatic
Your voice is not very clear. Please be loud.
पकड़ ले हाँ
The CCT abdomen showed a heterogeneously enhancing soft tissue density lesion, 3 into 3.6 centimeter head of pancreas lesion with the loss of fat planes to the duodenal wall. US showed a hypoechoic pancreatic mass lesion with a peripancreatic lymph node. The plan is to go for US guided biopsy with a More biopsy forceps. This is a CT image showing a pancreatic head lesion with distally dilated PD. And this is a US photo. Now we'll proceed towards the case.
Close करो
See, I have a question. In a solid lesion, why are we using Morey's forceps? See, why
That's
are
the
we
same, right?
why are we using a Morey's forceps?
I think once the FNA was done, that was negative, right?
But we need a stiffer needle. I mean, Morey forceps is for basically, lesions which are kind of softer and because the bite is much weaker. So
So must be with the Morey forceps, you get more tissue or what? Because once the FNA was done, that was negative.
Who is the operator?
We try to see the IVC.
Can we have a room picture?
Yeah, can we have the room picture, please?
More at the
We are seeing only EUS image.
Peripancreatic node is
between the liver and the it's perihepatic.
Correct.
Dr. Harshal is there?
Yeah.
Yeah. So,
So hi, good evening. Am I audible?
yeah.
Okay.
We can't see you. We are arranging for that.
That's okay, sir.
You can put on the lights.
So can you see the endoscopy image?
Yeah, definitely. There are multiple lymph nodes or what?
But we can't see you.
We've been discussing just now. We put in the scope. So actually, we I'm just below the G junction now.
There's some areas of necrosis also.
Yes. So these look like lymph nodes.
Maybe
actually,
tubercular?
and possibly tubercular. Yes.
Past history of tuberculosis there in this patient.
Yes. So probably it's just a reactivation or probably inadequate treatment.
That's better for the patient actually, as far as prognosis is concerned.
Once you see these type of necrotic lymph node, what's your preference? Which needle, which size of needle, what is the technique? And what is the advantage of Murray biopsy forceps over the needle?
Frankly, the Murray biopsy forceps has been designed for cystic lesions with a mural nodule. So to biopsy a mural nodule, or if you want to biopsy the wall of a cystic lesion, when there is a solid component to the lesion, actually it's a very difficult situation. You won't be able to use the Murray forceps. So in this situation, actually, even a 22 gauge needle should help. We have to just aspirate and probably send not only for culture, but all gene expert as well as AFB culture.
Do you think that the thicker needle would give you a better yield?
Yeah, if you consider this to be an abscess and you want to drain out the abscess, but this looks like a lymph node with a necrotic component.
Yeah, at times you get just like pus, no?
Yes. So
Do you
that,
use
in that
suction?
situation, and in this case, I'm just below the G junction. So put in a 19 gauge needle won't be so difficult. Sometimes in the D1 or D2, it
This is
can
the
be extremely
retroperitoneum or what?
This should be the gastrohepatic, or you can say the porta hepatis. So you can, I just go this side, you will see the liver and the aorta. And if I just come this side, you will see the celiac axis and just sitting on the near the pancreas. So somewhere at the porta.
Yeah.
So I think I'm just trying to see if I can get a window from here to put in a needle, but there seems to be some vessels
Dr. Lalit there, Dr. Lalit Shimpi.
Yeah.
Who is with you? Who is assisting
Dr.
you?
Lalit and Nilay, both are there.
Oh yeah, left and right.
Yes, sir. So without the left and right, you can't work.
No, I think
Baya or Baya.
more than the gauge of the needle also is important which needle you use. So if you use the FNB needles, your yield would probably a little be better. I think if the sample is adequate, that is the most important thing. What you see in it is ultimately the pathologist will tell you. But you just need to ensure that there is adequacy. I think that is more important. So if you use the new fork tip needles or the Francine type needles, I think you'll get a good tissue.
This seems to be a good place.
Are there morphological differences between the lymph nodes of different types, maybe malignant and non-malignant?
Here we can also see the gallbladder filled with the sludge. Is there any stasis?
So like these lymph nodes that are seen look more
so rounded oval lymph nodes more than a centimeter, you are probably more in thinking in terms of malignancy, whereas these kind of lymph nodes with large matted, they seem to be sort of conglomerated, and a necrotic center, it seems they're more likely to be inflammatory or infective.
And especially in this case, he's a young fellow.
With a past history of tuberculosis,
I think,
yes.
talk should be...
As compared to the diagnosis of
CA pancreas, I think this, if it turns out to be tuberculosis, is probably.
Very high on cards. Yeah.
This pancreatic duct is also dilated. Can you measure?
Yes, it is dilated. So probably we have to look at a lymph node mass.
You need to get a good window because
I'm
there's
just
a lot of
trying, there are a
vessels.
lot of vessels here. I'm just trying to see if I can get a good window.
In the portal vein is
Otherwise, you should always
patent or
go
there is
through the
collateral
diaphragm.
formation?
This is good window. I need someone to hold the scope, please. Please hold the scope.
Gloves then. Gloves.
और मेरा needle कौन सा दे रहा है? 22 का. हाँ दे. FNB.
What are these vessels? Major vessels?
Portal vein.
The portal vein, sir.
Yes, yes. So these are periportal lymph nodes.
Yes. Yes. Like porta
Just,
hepatis.
just beneath the liver.
Just beneath the liver.
And here the position of the needle is quite straight. So
Yes,
it's
just
easier to
because-
push
so
it
it's-
rather than going down
yes,
and push
yes,
it.
Yes, so that's, and secondly, there are two ways to look at it. If you consider this lymph node as tubercular, you will get the answer and the diagnosis as well. And if this shows up anything other than tuberculosis, also it shows probably a malignant metastatic lesion.
Were there any mediastinal lymph nodes when you went in?
We haven't checked really. Maybe while coming out, we'll do that. We were actually tuned to the fact that this fellow has a pancreatic SOL, and we were more inclined to just go in and look for that.
At times lymphoma also, you have multiple lymph nodes like this.
Yes, but then the necrotic component is something that would go again,
Yeah, yeah,
and a little bit
that's
of
right.
matting is again against the.
But you should have some differential diagnosis, not 100%.
Yes, I agree.
Generally, lymphoma nodes would be.
They are more circular, they are more discrete.
circular and they're
and they're more
uniformly
discrete.
hypoechoic.
Yeah, and more discrete.
More discrete, they are more circular, they are more separate. This is like,
22 का है ना?
the shape is also elliptical. Elliptical shape goes more in favor of benign.
Yes.
And they're uniformly hypoechoic.
बड़ा वैसे.
And some necrotic area in between.
That's a vessel you need to be a little careful with.
We'll see.
There is a question, if there is a small vessel, can we cross it while doing a FNA with a thinner
Sometimes
needle?
it's a very small vessel, yes. But the one which we were seeing was a pretty large one. So I would like rather avoid that vessel
Yes,
rather
yes,
than manage bleeding the way.
Yes.
I'll have to call Nilay to manage the bleeding then.
You can elevate a bit so that.
It's very difficult to find Nilay everywhere. That is the
So
problem.
that's why I've held him back here.
He's like Shah Rukh Khan, ना? और Shah Rukh Khan को पकड़ना बहुत मुश्किल है.
Don.
This is it.
Carlos?
Yeah.
Needle बाहर नहीं आ रहा है भाई. बाहर नहीं आ रहा है. क्या निकल?
Just need to check on
निकल रहा है. वो बाहर
the
है.
endoscopic view.
Elevator open है.
Endoscopic view, just check the sheath.
ये निकल रहा है. एक मिनट.
Just check the sheath once.
अभी आया शीत बाहर.
It's always mandatory that you either get a feel or you check the sheath coming out of the elevator before you puncture so that you don't.
आया ना अभी आया. आया ना अभी आया. अभी परत करत लागेल.
You can adjust and hold.
Yeah, we have moved, we've shifted the.
Plain tail of pancreas, I think. Yeah. Anti-clockwise. Yeah. That was good.
Yeah.
That window was good actually.
This is good. This is there still.
Yeah.
Okay.
Yeah.
Can you hold this? ये इसमें से बाहर नहीं आ रहा है। ये बाहर नहीं आ रहा है। ये बाहर है अभी। So open है।
No, you can just check it on the endoscopic view. Just get the sheet out.
ये आ गया है बाहर। एक मिनट। I have checked that already. This is already out. उधर दिख रहा है देख। वो तो बाहर है।
What is the size of the needle you are using?
Sir, 22.
22 should come out easily.
No, it has come out. The needle is not coming out of the sheath.
You can get it on the sheet.
Get another.
Just change it. Any 22 gauge should be okay.
Yeah, any tentative way is okay. ऐसा पकड़ना। उस तरफ घुमा के पकड़।
Now, what is the size of this lymph node?
Yeah, we'll just check. I'll show you. Hey, Lalit, can you just check, please? Please.
I think it's a group of matted nodes.
Yeah, but just see.
The exact size.
So about 3 centimeters.
Probably
3 into 2. 3 into
3 into
Yeah, around 3 by 2.
15 or 20 millimeters.
A few small lymph nodes around also.
Yes.
Take out the needle first and I'll.
पण तरी असंच ठेव मला वाटतं. चांगलं शोधणं त्याला अवघड आहे. मिला क्या बाबू? अभी कौन सा लिया? कौन सा भैया? ओलंपस का ही लिया वापस. सही है भैया.
Okay, the sheath is outside. Just put on the Doppler once. I think this is a little bit. Here the vessel will come in.
Gilly vessel?
Uh-huh.
Yeah, okay.
There's a vessel there.
No, but they are with the needle. No, suno. Yeah. Ruko.
Okay, so we are inside the nodal mass now.
Yes. Perfect position.
Slowly nikal.
So, what is your technique of taking the
So generally
material?
what we follow is the fanning technique. So what you do is with your up and down knob and with your elevator, you keep.
And you keep actually taking out the.
Yeah, and you gradually, the assistant gradually withdraws the stylet. So it creates a
and
gradual
you give multiple
vacuum.
jabs.
Yes, so about 10 to 12 jabs and maybe 1 or 2 or 3 passes.
Looking at these necrotic lymph node, at the first stage, you will do suction or not?
If I get a good amount of clot, I don't think suction is required. So if you see the various studies between
sometimes
suction,
we find some kind of cheesy
Yes,
material
so-
directly came
so the
out from the
point where I would actually use suction is a very small kind of a node or a difficult position where I may not be able to get a second pass. Those are the situations where I might want to use a suction. Otherwise,
Actually, if
most
you
of the
get
times, lymph nodes,
one should
it's-
avoid suction.
Yeah, it's not the best to
Darshan,
use.
what is the feel? Whether it is a
It's
hard
very
or
soft. No, it's a very soft. Very soft.
goes in favor of tuberculosis.
Yes. It's definitely going in favor of an infective or inflammatory lesion.
Very good for the patient.
Yes, definitely very good for the patient.
In
Yeah,
fact, we
they-
have actually stopped most of the times using suction for any of the FNBs because with the current generation of needles,
actually.
it is actually
it is not-
counterproductive to apply
Yes.
suction because it just gets more blood rather than tissue. And if you don't apply suction, most of the times you can make out the core tissue, whether it is adequate or not adequate.
But Lalit, how you actually process the tissue you get if you are suspecting tuberculosis?
Sometime by the suction, we get some kind of cheesy material. You can directly demonstrate the FB
So
bacilli
that's
and the
okay.
culture.
That cheesy material can
See,
come
that can even with the needle, you will get the cheesy
fillet
material.
withdrawal, you will get that cheesy material.
That-
We'll just try to maybe examine here.
Maybe
in
we
the
get
tissue.
it here.
Cheesy material is definitely something that will be.
That's tuberculosis.
Yes, will definitely tell us. But even if you get something like purulent white or material or even that will favor infective rather than a malignant pathology. And at our center, we have an on-site pathologist who comes and tells us whether the tissue is adequate. And once that is confirmed, I think we are more or less happy with our procedure.
But grossly, we can see the slides and decide whether the tissue is there.
Tissue is there, or not. Yes. No, but if the pathologist just stains and tells that there is adequate tissue, I think we are much more happier in that situation. Good tissue. Very good. So should we take another pass, or is that enough?
I think one more.
Yeah.
Yeah.
Gene
One
expert,
more
we need
pass
to get one
for
pass.
the
Gene expert and yeah.
We got some tissue?
Yeah, we got a lot of tissue.
We've got
Good. But I think one more pass.
Yeah, especially for tuberculosis and culture.
It's always better to have one more pass rather than repeating the procedure again.
Especially if there's been an initial negative FNA, I think it makes sense to take an additional pass.
That's right.
It just takes maybe 2-3 minutes more, but it's one more.
It'll avoid one more procedure. Actually.
You want a better position?
A little more.
Yeah. Okay. Now this is it.
Sure.
So if you are actually confident of having had a good core tissue, we can take, of course, this will go in normal saline, but we can take the samples directly in a formalin bottle rather than putting it on the slide.
Slides. Yes.
So what we normally
how do you
is,
do the fanning technique actually?
So like I said, once you've gone in, you can use your elevator. The elevator gives you one direction, and then you can use your
Body movement also.
Body movement, elevator, and the up and down knob. So these are the
you
three
change the
things.
position, right?
You keep changing the position. Yes.
so if you change the position between clockwise and anti-clockwise, you will fan in a lateral direction, while if you use the elevator, you will fan in a vertical direction.
Vertical direction.
So it will be different from the direction you poked it. So
Yes.
you get more tissue.
So most of the times you're fanning, you will do it once you are inside the lesion.
Yes.
So one should
And
not come
the
out
other
of the
thing
lesion.
is, you should try and not come out.
Out of.
Should continue to stay inside. So those are two important points about the fanning technique. So just waiting for them to.
Now can we shift to the other room now?
Yes, sure, sir. I think
Thank
that
you.
will be
It
the
was an
process.
excellent
Thank you, sir.
demonstration,
Thank you.
Harshal, Lalit. Thank you very much.
you.
Now, Kapil, you are on now.
You are on. Dr. Kapil, we are not audible. You are not audible.
Now you will be. Yes.
So I've removed 3 polyps from the right side of colon. Now I've reached the left side. So I'll show you again what is the site after. So this is the first polyp and this is the second polyp. We have retrieved the sample and one more polyp was there on just proximal to the hepatic flexure. We also removed this one also.
This was the one we applied the clip, right?
So, no, sir. This second clip. Already we have applied clip. This is the clip one.
Yeah.
This is that one. This is the other one which was there.
Yes.
And third one also we have removed. So this is the polyp is lying here. We'll remove it later on. So this small polyp.
Yes.
And we are coming to right side now. No further polyp on that side. Left side we have a polyp which we'll be removing. Let us see the size of the polyp and then decide.
Vinayak, do we have the previous biopsies in this patient? Not yet. And we have done the upper GI in this patient? We have the upper GI report? Yeah, there were multiple polyps on the upper GI also. So it appears to be a patient of Peutz-Jeghers actually.
Sir, when we are trying to place a clip on the stalk of
Your voice is not clear, Vinay.
Sir, when we try
What histology we are expecting in the Peutz-Jeghers polyps?
Hematomatous, hyperplastic. Chances of adenomatous polyps are very less in Peutz-Jeghers.
When we're trying to apply a clip on the stalk of a polyp, sir.
We can also find the one small sessile serrated adenoma.
Yeah.
So better is to place near the base only. Suppose you're not comfortable or there's some problems, then you could apply. Otherwise, the target should be towards the base of the polyp only.
Here we can do cold snare on this piece.
Yeah, I'm just trying to because delineate the polyp. I'm trying to see the stalk of the polyp, then we'll decide whether we use a cold snare or what. So it's at the bend.
Very tiny.
This is the, I think the.
Kapil, we are shifting for some time to Amol and see you.
Yes, sir.
Yeah. एक बार अमोल वाले.
Are you here?
Hello?
We can hear you, sir.
Yeah.
But we
Can
can't see you.
us?
Yeah, now we can see you.
It's good that you are not seeing.
At what stage you are? Like?
Yeah, so we have identified the central scar here with the central vessel. So here we are cutting through the fibrosis. There may be a little bit of muscle which we may have to take over here, but that is okay because what we did was we retroflexed in the sigmoid and we got the proximal incision also. And now this seems to be the central vessel of the polyp.
The big vessel?
Yeah, it's okay.
It is a
Yeah,
very
it is a
thick scar actually.
It's a very thick scar.
And sometimes we fear that it is all muscle. It is a muscle which is going in, but then you have to cut.
You have to cut through it. There is no option, but because without that we will not be able to.
Just to try to remove as possible and discuss with patient. Suppose there are too many.
What current we are using, sir?
I'm using 4 square.
Yes.
And precise segment.
Precise segment.
Precise
segment. So whenever you have this large bulky polyps, this is always
on a fold.
Yeah.
You should anticipate this, that in the center you will have something like this. That is quite common. Knife back line.
Back.
Back line, back.
Hello.
Hello.
Sir, very nice demonstration. Sir, may I ask one doubt, sir?
Yeah.
Yes, of course. Go ahead.
In case of this bulky polyp in sigmoid colon, as submucosal involvement chances 2 to 10% chances of lymph node involvement, and
Can you speak a bit louder? We cannot hear you.
in case of this sigmoid colon bulky polyp, sir, large bulky polyp,
Yeah.
chances of lymph node involvement if submucosa involved is 2 to 10%. And
Yeah.
after removal, also oncologists sometimes ask that we need to see lymph nodes. So
No, you have
is
to
that
look at the margin. We are not talking about lymph nodes.
I
If the
agree.
margin of the polyp and the JNet pattern and the final histology, that is what is important. I think you are confusing between polyp and cancer.
Yeah.
So if there is cancer with submucosal invasion, deep submucosal invasion, obviously the risk of lymph node metastasis is high. But with a polyp, there is no reason for submucosal invasion of the polyp. So I failed to get your question. Maybe you can rephrase the question in a better way.
In biopsy, if it is adenocarcinoma,
It doesn't look like adenocarcinoma. We have
This does not look like adenocarcinoma in any ways. And even if histology comes as adenocarcinoma, if the invasion is superficial submucosa, then this is curative.
because sometimes oncologists ask that even if submucosa some involved 2 to 10%.
You have to show the data to the oncologist in that case. That is all.
Okay, thank you, sir.
Because oncologists cannot take that decision. They can take decision about chemotherapy if at all, if there is invasive tumor or metastatic disease, but they cannot take a decision about this.
very fibrotic area.
It is very common. You have these large polyps. This is the rate limiting factor where your success of removal, because now at this time you will feel that you will do better, you use a snare.
It is almost.
But here at this point you cannot use a
use a
snare.
snare also. Yeah, that's true. That is what.
That is the reason we chose not to use the snare in the first place, because that would have messed it up, because here you will never be able to get an en bloc or something of that sort. You will have to do piecemeal and centrally because this will.
This fibrotic scar usually found in the center of the lesion, or sometimes you can also see periphery.
Center, invariably in the center. The reason is, see, the scar forms basically because the polyp is prolapsing. Because of that, the scar is formed. Let us look at it panoramically once, what we have achieved.
Very nice dissection.
Nice
Wonderful.
dissection. Okay.
Hello. Hello, Amol.
Yes, sir.
Can we go to the other room for a while?
Yeah, I think you can, because this is.
Yeah, it will take some more time actually.
This is continuing, so.
I know. You are actually marathon runner. That is everybody runs a 100-meter race and you are a 5,000-meter runner. Yeah. We shift to the other room.
Action नहीं हो रहा है.
Yeah, Kapil, you are on.
Yeah, so what I'm doing is this has a little thicker stalk, so I'm trying to apply it.
Can we have the endoscopy image?
Yeah.
This is underwater?
Yes, underwater, because the loop is a little thicker.
Kapil, would it be better to have a loop there?
Yes, sir, just trying. If not possible, then I'll use the loop.
He has used clips 2-3 times.
Any chances of transfer of current by these clips to the wall of the colon?
So if you touch while cutting, then it can transmit, and it's not fitting. So I think we'll use a loop. Follow? Follow. Deploy नहीं करना. Open. Hello.
So we have previous. Hello, am I audible?
Hello. Hello.
Am I audible?
Yeah. We can hear you.
So chances of current transmission occur if we apply cutting current just while it is cutting the. So there should be at least 2-3 millimeters of gap between the clip and the cutting, the snare.
I think this polyp look different from the other polyp,
Yeah, yeah. So if you
hyperplastic.
but looks regular pattern only. There's no, we get the base also. So the vessel pattern is okay.
Can you do underwater EMR?
Yes, we had, this is underwater only.
You just apply and snare and then cut.
Want to ask something?
Actually, I was just asking about the biopsy reports. No? I wanted to update them about the
Yeah.
hyperplastic polyp biopsy. The mic is not working.
Thirty, ठीक है, 30 is okay. Right? यहाँ पकड़ना.
You're applying endoloop?
Yeah, yeah.
Can you show us the technician hand, because that is very important while you're applying. First, you have to.
What I want is that loop, the polyp should float. It should separate from the wall. That time you should apply loop. Otherwise, so what will happen is sometimes the part of polyp can come inside the
You have
loop.
to.
Yeah. So that we have to take care. So until unless it gets separated, you should not apply a loop. Until unless you see that it has come, all the sides are clear.
Okay. You should also ensure all the margin.
Yeah, yeah. क्लोज करना शुरू करो, क्लोज करो, हल्का हल्का हल्का.
First, you have to close, then you have to release.
Yes. कोई ना, बात करो. Deploy. Then you can see that the color of the polyp starts changing immediately after deploying the.
You
endoscope. That means blood
strangulated the
supply has
polyp.
disrupted. Yeah.
It is because of strangulation.
Yes, the blood supply has stopped.
Do you change your cautery setting according to the size of polyp and location of polyp?
Yes, yes. That's why Dr. Sanjay also asked. So right side we should avoid burning too much. So that means the cutting should be okay, but we should not be. We should decrease the size, the type of this one.
Any effect, this effect and duration.
So duration, I think the cutting should be same, but the coagulation should decrease on the right side of colon, because burning is there, that, and polypectomy syndrome is more. Wall is also thin as compared to the left side. So we are using endocut Q for this polypectomy.
What is the difference between Q and I?
I think one of the, this is left, one of the branch of it is left out. I'm not sure. Let me say it. Hello? क्लोज करना शुरू करो, क्लोज करो. बोलो.
फिर और खिलाई दो उनको खाना.
बोलो. ये ध्यान रखना एंडोलू बीच में ना आए. करो क्लोज, क्लोज करो. तो खोलना पड़ेगा. क्लोज. हाँ, close. So I'm sure that I feel that I'm above the loop, let us see. And it's separate because it's able to separate. That means I'm not having a wall inside my loop. You can see that it has cut above the loop, just above the loop. Yeah. And we can
Very well done.
So we can retrieve this.
Can you hear the clap of sound of clap, Dr. Kapil?
Yeah, yeah. Thank you.
Very well done. Amol sir, yeah, on.
Alternate.
Okay, just change the patient's position back to left lateral. And now let us see. We've been dissecting in the stalk, the central scar area, and we have probably majority of the mucosal incision is over. But let me try and show you some anatomy so that it's better. No, I think we'll need to turn the patient to the right lateral because this is becoming more difficult.
Sir, what is your sequence? First, if you see large polyp sigmoid, first on the anal side, then on lateral side, then on oral side.
It all depends. So, Kapil, there is no meaning you cannot decide one protocol. Now, if you first right lateral. First, what we have to do is you have to see the orientation, how it is lying, on which side of the wall it is, whether the fluid is remaining there or whether it is going on the opposite wall. All those things have to be seen. Then the second thing is you have to anticipate if there is whether it is on a fold or not on a fold. If it is on a fold and if it is like a bulky polyp like this, then that will you have to anticipate that there will be some fibrosis in the center. रुको स्कोप संभालो पहला स्कोप ये बाजू से ले लो अभी उसको घुमाओ घुमा दो पेशेंट प्लेट देख लो एक बार अभी देखो once we made the patient right lateral I'll also go a little bit proximally and suction out the stomach, the bowel. क्या हुआ? क्या खींच रहा है? स्कोप ठीक है मेरे तरफ से आप देख लो आप अरे पैर संभाल घुटने से उसको मोड़ दे ऐसा और वो कॉटरी का पैर तेरा नीचे चला गया वो अगर प्रॉब्लम होगा तो उसको छोड़ दे अभी तो Are we still there?
Yeah, here, sir.
Okay.
When you prefer to do hybrid ESDs in this last?
No, now this kind of a situation, there is no point in doing an hybrid. You will fail and you will fail miserably. You will neither get the polyp, you will create muscle injury and you will have more problems.
So either you do a EMR or
Yeah.
ESD.
But your EMR would have meant it was a piecemeal.
It had to be. Yeah, I think this is
the last part, but it is going to be adherent that we have to anticipate. क्या हुआ? ऐसा पकड़ ले नहीं एक बार यहाँ से ये म्यूकोजल इंसिजन ना पूरा नहीं हुआ है इस तरफ पंकज ये दिखा यहाँ पे इंजेक्ट कर ले बस जा छोड़ दे स्कोप छोड़ दे एक ग्रीन शीट मिलेगा अपने को यहाँ पे डालने के लिए स्कोप अटकता है नहीं तो यहाँ पर इंजेक्ट कर बस दे देना है वो पकड़ेगा सपोर्ट करते रहा बस CO2 बंद हो गया दिया है
The best thing is here you have to find out the margins. You either find the right or the left, and then
try and go from one edge to another.
Take use of gravity as far as possible.
Back.
Do the same thing. Do the same thing.
नहीं वही कर रहा हूँ. I'm just going.
So, sir, for better dissection, you want to keep the lesion on 6 o'clock or 12 o'clock. What is your preference?
Hanging.
Keep it hanging so that you get space.
12 o'clock, if at all.
Now it is at 6 o'clock.
Yeah, the lesion now is at 6 o'clock, dissection is at 12.
Back.
Here, gravity is also helping us.
It's only gravity is helping. We are changing the position of the patient just to take help of gravity. Because nothing else will help.
Nice दे दे. Nice दे दे. पहले समझ क्या बता रहा हूँ.
This is the.
See, so what I did, I pushed the catheter deep inside in the defect. Then I pulled back the sheath and I asked him to give me the knives. And at this point, where it connects, that is the point of the mucosal attachment, because I am trying to find the mucosal attachment and that I am finding it difficult to identify. So I have to do it that way. Step by step, you have to do it.
Point when you are doing this is you have to keep parallel to the
They-
muscle
where-
and cut through the fibrosis.
It is also very important not to touch the lesion because we need a lesion and block some.
Yeah.
Yeah, I think this is the base. It is 6 o'clock.
That is going to be the next problem.
That also you can do.
No, but coagulous, the only problem is you will have to do point dissection and we still are not at a point where you can do a point dissection. You will lose the way. If we try to do a coagulous directed dissection. तो आपका पीछे आता है, मैंने आपको पकड़ने को बोला ना, तो पकड़े रखो उसको. ज्यादा भी पुश नहीं करना, नहीं तो स्लिप हो जाएगा. तो देख रहा.
Very nice. I think this is the last attachment.
Behind this, there will still be a little
For the last 1 hour, we have thought that something is the last, so I still don't know. Only when I finish the last, then I will tell you. Yes, that was the last.
Legion looks very difficult, but you have done very nicely, sir.
The challenge becomes that because of the oblique muscle band and the fold which actually holds the lesion back, that makes it biggest challenge. Back.
Okay.
This was
this was
back ले भैया आपसे बात कर रहा हूँ ध्यान रखो यार.
this was at rectosigmoid junctions.
Inject.
in the sigmoid.
बाहर निकाल के करोगे तो घुसेगा नहीं. बस 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 बैक. ऐसा है ना इधर ब्लीडिंग हो रहा है वहाँ पे तो वो फील्ड खराब हो जाता है. फास्ट अपने को एक्शन लेना होता है. 3 बार बताना पड़े आपको तो उसमें टाइम जाता है. नहीं हाँ. मैं बताऊं उसके तरफ ध्यान दो, आप दिमाग मत लगाओ.
Now you hook. Can we dissect by what is your opinion about IT knife, sir, at the last part of dissection?
IT knife you can do, but I still have to. I am having to inject at some points, and through IT knife you cannot inject. So that is the reason I have not shifted over to IT so far. दिया क्या नहीं दिया.
This is the fibrotic area, or this is muscle?
This is fibrotic. It is all fibrotic.
To prepare for gala dinner.
This is a part
कैसे
of the
क्या
muscle
बोलना
which
है?
is getting pulled in the polyp. You can stop it. Stop.
क्या हुआ?
I think I think we can have a big round of applause for Dr. Amol. Dr. Amol, this is for you.
Amal, sir,
Thank
you
you
can
so
hear
much.
the clap,
Yeah.
sound
so
of
much.
clap.
Yeah, thank you.
Thank you so much. Hopefully we should be done.
Yeah,
in
I
some
think you
time.
would do it.
Nice.
You would do
We'll
it.
show
No.
you the.
It cannot be done much better.
Yeah. Actually, they need hall to prepare it for gala dinner. So
Yeah, sure. You can sign up.
So we
No problem.
formally close this session for today and meet again after an hour or so for a gala dinner. I thank you all the chairpersons and
Thank you,
moderators.
sir, for wonderful demonstration.
And thank you, Dr. Amol. Very good.
Thank you. Thank you.
Great learning exercise. Thank you, sir.
अभी
Thank you,
retroflex
everyone.
करके पीछे से देखना पड़ेगा एक बार.
I'll meet tomorrow morning 8 a.m. For breakfast session.